Very good morning to one and all. I think our judge for the session, Dr. Shantanu Gupta, is here.
Yeah, good morning. Hello.
Hello, sir. Uh, Sir, have you got the Excel sheet for the scoring? I think you must have received it.
No, I have not.
Sir, you can just write down the scores and you can message it to me privately here if you haven't. I would add the scores here and
Okay, so I have that list with me of the speakers. There are 11 videos.
yes, sir.
So
You
one,
can just send me a picture or you can just send me the list of your marks at the end of the session. You can just message me privately in this.
sure, I'll do that. And what sort of scoring do you normally keep? I mean, I'm new to this, to be honest with you.
Sir, the scoring is based on the presentation, the impact, clinical impact it has,
Hmm.
and the score is out of 10.
It's out of 10. All right.
Yes, sir.
Okay. So this is Dr. Priyadarshini.
Yes, sir.
I could I have a brief introduction of yours if that's okay.
Sir, I'm a senior resident in RP Center. I'm doing a senior residency in cornea and refractive surgeries and cataract surgeries.
Okay, so you are in Dr. Namrata's unit?
Yes, sir.
Okay, okay. Right, right. It is. So I think we have still a few minutes to go, so we can probably we'll just check it in a 2 to 3 minutes time. Okay.
Yes, sir.
Dr. Shantanu,
Yeah. Good morning.
good morning. This is Dr. Goswami here. Unfortunately, I got no mailers from anywhere regarding this, so I'm equally confused as you are. So, so in fact, I don't know. I had sent my video to the DOS office long back. Unfortunately, I'm not ready with my video. Can you please shift my presentation a little later side? In the meanwhile, I'll try searching for my video so that I can host it from my end.
That should not be a problem. Once you're ready with it, just let us know. We'll figure out a way how we can do it.
Thank you very much because I also have to find out where I have kept the video because I thought I have already submitted it to the DOS office. So they should be having it. But unfortunately, there seems to be a huge communication gap. So I'm not able to make out where is it.
So once you're ready with your video, just let us know. We'll have the technical team ready with it at the back end of it at the end of the session, maybe.
Thank you very much. Thank you, Dr. Chan.
All right. So I'll just come back in 2 minutes. And that's just.
Yes.
Is Dr. Praful here?
Yes, sir. Good morning. Good morning, everyone.
Good morning, Dr. Praful.
Morning, sir.
Good morning. This is Dr. Archana Chaudhary. I think mine is the first video to be played.
Absolutely right, Dr. Archana. That's absolutely right. You are the
Yes, sir.
first one with capsulorhexis simplified.
Yes, sir.
Okay, so I think Dr. Jatinder Bali has excused himself for now. He is in another session. And Dr. Prafulla is here. And do we have Dr. Reena Sethi with us? No, I don't think so.
No, sir.
No. Okay. So, Dr. Prafulla, can you let us know if we can start?
Yes, sir. We can start.
Okay. So we will start with the first video of the day for the session, and we will start with Dr. Archana Chaudhary, who's ready with capsulorhexis simplified.
Yes, sir.
Introduction.
So my video is getting played.
Yeah.
No financial disclosure. Keywords. What is cataract capsulorhexis? Capsulorhexis. Best method. Continuous curvilinear capsulorhexis. Older method. Capsulorhexis in different cases. Capsulorhexis in mature cataract.
सर अभी स्टार्ट हो गया है। अब तो सर मेरा थोड़ा टाइम लगेगा, 6-7 वीडियोस हैं, स्टार्ट हुआ है अभी। कॉल एंड में एन यस सर, यस सर, यस सर, जी थैंक यू सर, जी सर, जी सर, हाँ जी सर, ठीक है सर, जी 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 सर।
Capsular in small pupil. Flax. Conclusion. References.
Yeah, so that was a very good video, Dr. Archana,
Thank you.
and very well timed, I must say.
Thank you.
That saves us a few precious minutes. So if we have any questions for Dr. Archana,
Dr. Rachna, is it that have you placed any voiceover, or I couldn't hear that? I'm confused.
There was
The
a
video, it was
voiceover.
just the titles were there, but if you were speaking, or
So there was a
it was just
voiceover
video.
on the subtitles,
Okay.
and the rest was typed.
Okay. I got confused because I thought I might be missing those subtitles. Okay. Thank you. Excellent video.
Thank you, sir.
so do we have our next speaker ready, Dr. Lalit Kumar
No.
Singhal?
I think Dr.
Lalit,
Lalit Singhal is here.
sorry?
Dr. Lalit Singhal is here, sir.
Yeah, Lalit, I can't see you.
Good morning, sir. Am I audible?
Yeah, very much audible.
Okay, sir. So my talk is regarding, I'll be playing a small video.
You will be speaking on mechanical dissection in posterior.
Yeah, mechanical
cataracts.
dissection, sir. I'm just looking for my video to open this.
Meanwhile, I request the next presenter, Dr. Ashit Handa, to be ready with her video.
But I don't see her. I don't see her.
No, sir, she's also here.
She's here. Okay.
Yes.
You have shared your screen, Dr. Lalit?
Yes, sir. Just a moment. This video is it's going to take few seconds. Is it audible, sir?
Yeah, you're audible, but we have to see the video. Start the video, please.
Sir, I think I've already. Just not coming up on the screen. Just wait for minutes.
Sometimes there's a lag, you just have to click and then wait for a while.
So just wait for a minute. I'm sorry. This delay.
So in that case, I think if the next speaker is ready, we can move on to the next speaker, and then Dr. Lalit will be presenting after that.
Yes,
Dr. Ashit Handa is ready.
Sir, I'm audible.
Yeah, you're very much audible, Ashit. Can you start? In the meantime, Dr. Lalit will be able to gather his video and then. Dr. Ashit, you can share your screen. If you're ready with your video, you can start with your video.
Yes, sir. Yes, sir.
Surgical approach for lens aspiration in young with synechiae and posterior subcapsular cataract.
Yeah, this is my topic, and I am Ashit. I am from UCMS and GTB Hospital. My mentor are Dr. P.K. Sahu and Dr. G.K. Das, sir. This is the video in which here we demonstrate that phaco surgery in a 15-year-old girl which have history of previous history of anterior uveitis, which was on topical steroid for 2 years. Then she developed posterior subcapsular cataract, and we perform initial step of phaco surgery, that is air dye wash. With that, we are trying to maintain the anterior chamber with air, and due to posterior synechiae, the anterior chamber is not fully formed, and there is irregularly dilated pupil in this case. So what we do is we through iris repositor, we try to bluntly dissect the posterior synechiae. We try to break them out. We tried first with viscocohesive. Anterior chamber was not maintaining. Then we tried mechanically breakdown of the synechiae. Then we constructed the main wood with keratome through opposite side to break down the synechiae from the opposite side also, so that 180-degree we can get some view of the anterior capsule. Here the anterior synechiae has been broken, and then what we do is we, as the young got elastic anterior lens capsule, so we stain with the Triben blue to make it more rigid. And after we are trying with cystitome needle, it is quite difficult as it is more elastic.
Dr. Ashit,
Yes,
may I
sir.
interrupt you, please? Your video is not playing. I'm seeing a still picture here.
Wait, sir.
Is it with me or is it with everybody here?
No, sir, even I'm not able to see the video playing.
Yeah,
Yeah,
now
so
it's okay.
I should just make sure it's playing. Yeah, now it's playing. Yeah.
Yeah. Now with keratome, now we are breaking down the posterior synechiae through the opposite end, through the main wound, so that we can get some view of the anterior lens capsule. Now, as the anterior lens capsule is quite rigid in this case, and we have also tried with Trypan blue to make it quite rigid, and we also led to exposure of the light, because in young the anterior lens capsule is quite elastic. By method of Trypan blue and exposure it to light for 2 minutes, and to make it more rigid, so that capsular access can be performed quite well. So we failed with cystitome, but we tried to make few nicks and through Utrata, and we trying to make the access complete. And the hydro procedure are being now done. This is now with we are aspirating the lens matter through coaxial system. I think there is some disturbance.
Dr. Ashit, I think there's some disturbance in your audio end.
I think Mohammed Shah. Now it's clear. Through coaxial system, now we are aspirating the lens matter. As the this 15-year-old got soft cataract without much using of phaco emulsification energy, we are just trying to aspirate it. Then lately the subincisional area is being aspirated. There's difficulty as PSC develop in case of steroid use, so there is difficulty in removing the posterior plaque from the posterior capsule. Then the foldable eye will be injected. Centration of it's being done. We try to place it in the bag itself. Later the visco being washed out. stromal hydration is being done. But as air keeps on leaking through the main wound, later what we did is we suture this main suture of the main wound is being done. That's it.
Yeah, so that was a good video, Dr. Ashit. It was a
Thank you,
difficult
sir.
case and it was well managed. And especially in the young, you have a large, a bigger responsibility to
Yes,
give
sir.
a good result. It was well managed and the capsule X is well done. The phaco part was easy, of course, in a young patient. So all in all, a good presentation.
Thank you, sir.
So can I try my video? No.
Yeah, you back, Dr. Lalit?
Yes, sir.
You ready with it?
Yes, sir.
Please go on. Do we have Dr. Anshuman Goswami? The next presenter, Dr. Goswami.
Dr. Anshuman.
Hello, Dr. Shantanu, I told you, there was a problem with the uploading of the video. I'm searching for it.
Okay.
Just give me
Yes, sir. It's
10,
it's
15
taking
minutes. I
little
think
bit
I'll
of
put it from
time.
my YouTube. That will be easier.
Should
Can
be
we
fine.
put it from our YouTube, please?
Sir,
Yeah, you can
is
play
it?
it from there. That's not a problem. But let us know when you're ready after this.
Yeah.
Okay. And do we have Muhammad Shah Zaki Siddiqui ready also? Muhammad Shah, you ready
Dr.
with your
Mohammad
video?
Shah.
Yeah. So he's waving his hand. Yeah, he's ready.
Yeah.
I can't
It's
hear you,
taking
Muhammad
little.
Shah. Your audio is off, Dr. Muhammad. Your audio is off. Unmute yourself. Yeah, you can speak now. Are you ready with your video, Dr. Muhammad Shah? Anyway, so we'll start with Dr. Lalit.
Sir, it's taking little bit time.
So you're not ready still?
I'm ready, but it's not. I'm just trying to share it, but it's not playing over here.
Shantanu, can I try playing mine?
Yeah, why not? Please.
I have to try this experiment, so please forgive me if it doesn't work very well, right?
That's
Because
okay.
I'm doing it for the first time from the
we all
YouTube.
all try and then we learn. It's okay.
So I'm sharing my screen now.
Yeah.
Are you able to see it?
Yes, you're
Yes, sir.
ready.
Yeah. Thank you. I'll play it now. Phacoemulsification in a cataract with small pupil is a challenge in itself. Not only does the small pupil hinder access to the cataract for emulsification, it can result in a lot of collateral damage to the surrounding tissues like the iris and cornea. Compounding this is the high incidence of peroperative complications and postoperative inflammation, resulting in poorer postoperative outcomes. Amongst the various devices available, the Malugian ring is a very effective device used to enlarge the pupil. It's a square-shaped ring made up of elastic 4-0 polypropylene. It can be easily inserted and removed through a 2.8mm incision into the anterior chamber with the help of its injector system. The ring has 4 straws as its corners, which are designed to engage the pupillary margin and keep it expanded during the surgery. The Malugian ring is loaded into its injector system. The anterior chamber is formed with viscoelastic, just enough to create some space in the AC, and the pupil is dented up slightly where the straws would be engaging them. The ring is inserted through the main incision such that the distal scroll engages the distal pupillary edge first, and then the 2 side scrolls engage the pupil on either side. The proximal fourth scroll is then manipulated to engage the proximal part of the pupil using a dumbbell dialer or a Sinskey hook through the side port. The phacoemulsification is now carried out safely with a now expanded pupil, and the ring is removed only after the IOL has been inserted. Once the IOL has been implanted, the anterior chamber is again reformed with viscoelastic, and the distal scroll is first disengaged from the pupil using a dumbbell dialer. Once done, the other scrolls are also disengaged one by one. Lots of care has to be taken at this stage not to pull the iris too hard to prevent injury to it. Once all the 4 scrolls of the ring are free, the ring is re-engaged by the injector device and removed from the AC. A second instrument like a dumbbell dialer is very useful while pulling the ring into its injector. Another challenging situation is the bogged down pupil in a post-uveitic cataract. Not only is the pupil small and non-dilating, the iris is often rendered flaccid by the disease process, making the surgery even more challenging. The anterior chamber is filled with adequate amount of viscoelastic to allow for easy manipulation of instruments. A blunt instrument, like an iris appositor, is then used from the side ports to break the synechiae 360 degrees between the iris and the lens behind. The pupillary margins are then stretched in 2 opposite directions using 2 Coughlin's hook, and this is repeated in direction 90 degrees away from the first stretch. This allows the pupil to become a bit larger for putting the ring in its place and increases its stretchability. This is followed by insertion of the Malugian ring into the anterior chamber. As shown previously, we try to hook on to the 3 sides of the pupil with the help of the scrolls, but at times it doesn't happen, and the Malugian ring is extremely forgiving. You can do it as a second step. The main thing is to get a hold on the distalmost pupillary margin, and as you can see, all the 4 scrolls are now in its place. Once the cataract has been removed and the IOL has been placed in the bag, the anterior chamber is again refilled with viscoelastic, and the Malugian ring is removed in the usual fashion, taking adequate care not to pull on the iris and cause any complication like iridodialysis. The BX ring, an invention of our own Indian doctor, Dr. Suven Bhattacharya, is a relatively cheap and easily available ring in our paraphernalia. Unlike a Malugian ring, it's a hexagonal structure with a flat profile of 0.075 mm. It has alternate notches and flanges designed to give the pupillary margin to get a pupillary diameter of 5.5 mm, enough to carry out a safe phacoemulsification. The ring is inserted into the anterior chamber using a specially designed 23-gauge forceps which has grips like a crocodile. The mouth closes in a plane perpendicular to the closing forceps. The ring is introduced into the AC over the iris with no attempt at this stage to engage the pupil. Once the PX ring is inside the anterior chamber, a crocodile forceps is introduced from the right side port, and the distalmost flange is held at the center and tucked underneath the pupil. A similar action is taken with the third flange with the right side port itself. But for the fifth flange, one has to change one's hand to the left hand and then tuck the fifth flange underneath the pupil, completing the circle. Once the IOL has been implanted, the PX ring is disengaged from the pupil using a Coughlin's hook or a crocodile forceps, and then removed from the anterior chamber using the crocodile forceps. Iris hooks are one of the most versatile, easily available, and cheap devices to attain a pupillary dilatation in a small pupil phaco case. They are made up of polypropylene with silicone stoppers. After filling the anterior chamber adequately with viscoelastic, 4 or 5 side ports are made, depending upon the number of hooks to be used during the surgery. The hooks are inserted one by one into the anterior chamber from the side ports, turned to engage the pupillary margin, and loosely pulled back till all of them are in their respective places. Finally, all the hooks are retracted back one by one to prevent excessive stretching of the pupil at one place. The retracted hooks are prevented from sliding back by the silicone stoppers hinged at the limbus. Once the cataract is removed and eye implanted, the hooks are loosened one by one and removed from the anterior chamber to the side ports. The surgery is then completed in the usual manner. Shantanu, I hope all of you could see it.
Yeah, very well. Those were all very good videos.
Thank you very much.
And I just had a few questions for you, Dr. Goswami.
Please.
You know, amongst all the rings, which ones do you feel in your experience are the best ones to handle and, you know, with minimal manipulation of the anterior chamber structures?
I think the Malugian ring is the safest. I mean, in most hands, it will be most comfortable to work with because it's sturdy enough to be handled by the instruments inside the eye, as well as thin enough to be comfortable in putting it within the pupillary area. Because BX ring is a good modification. It's cheaper too, but it's a little flimsy in terms of its architecture. So it's difficult to handle it inside the eye unless it takes a lot of manipulation. Sometimes it collapses on itself, and it's not very good for very rigid pupil. You'll have to expand the pupil nicely with a Coughlin's hook before a BX ring can be put in it, you know. Whereas with the Malugian ring being a more sturdier structure and thicker structure, it works better with these eyes. So I think if all the instruments are taken into consideration, I am most comfortable with the Malugian ring.
Malugian ring. Okay, so that takes the cake. Malugian ring takes the cake. And also, I saw the dilatation which you could achieve with Malugian ring was better as compared to the other ring.
Yeah, absolutely.
So, but I must say again, all very good videos, Dr. Goswami. It takes a good surgical skill to come up with these good results finally.
Thank you very much.
So can we go on to our next speaker if there are no more questions?
Sir, I'm sorry. Should I play my video through YouTube?
Yeah,
Because,
just a moment.
Yeah, you can.
Any more questions for Dr. Goswami? Amongst any more questions for Dr. Goswami? Okay. So so is Dr. Lalit ready now?
Yes, sir. So Dr. Goswami, have to stop sharing the screen.
Yeah, I'll have to stop sharing, right? So I'm
Yes,
trying
sir.
to do that, you know, but again, at times we can be very technically challenged. That's the problem. Just give me a moment, please.
Sure, sir.
It's on the right side, is it?
Yes, sir, on the right side.
Where there's more written, right? Just a moment. How do we stop sharing? I mean, I'm unable to find that,
सर मैंने स्टॉप शेयर कर दिया है.
Okay. Thank you very much. God bless you. Thank you.
Dr. Lalit Kumar, please put it in full
Yes,
screen
yes.
mode.
Full screen.
The next speaker is Dr. Mohammed Shah. Is he ready? Can you confirm that for me?
Is it on full screen?
Dr. Mohammed Shah Zaki, can you just unmute yourself or?
Yeah, I'm here.
Okay.
Are you ready with your video, Dr. Mohammed?
I am ready with the video, but
Yeah, so this is after this Dr. Lalit's video. You have to play your video, Dr. Mohammed.
okay. I will try that I can play.
Be ready with your video, please. Dr. Lalit,
Sure,
you
I'm
can start.
ready with the video.
Full screen
So
now.
I have started sharing, but it's not coming full screen. I think even on YouTube. Is it full screen now?
No,
Let me
it's
share
not.
it again.
Dalit is not full screen.
Full screen. It's showing full screen over here. Can anything like on the back end can be done from
Can the
there?
technical team help with this? Dr. Lalit, you can play your video. Even if it is not full screen, you can play your video.
Sure, sir.
Yes, sir.
Is my video visible now?
Yeah, very much visible.
It is visible.
Thank you.
It was visible earlier. Now it's not visible.
So, it's
You can go back what you were doing earlier and then play it. Not
Sure,
go
sir.
full screen then.
Is it visible now?
No. It's still playing, but it's not visible. So you can go back to your, you can exit the full screen, and it was playing earlier before that.
Sure, sir.
Yeah, you can play here. That's fine. Absolutely fine.
Is it visible now?
Yeah, very much. Go on, please.
Dr. Lalit, is there an
Yes.
audio as well in it?
Yes, ma'am. It's having audio.
What you can do is you can mail it to us, the YouTube link and your name. Maybe
Sure,
we can
ma'am.
play it for you later on. Till then, the next candidate can play.
Sure, ma'am. Sure.
Yeah.
Dr. Mohammed,
The,
please unmute yourself first. Dr. Mohammed, unmute yourself. You're not audible.
Am I audible?
Yes.
Okay, just give me a second. I'm okay.
Priyadarshini, you please request the technical team to mute all others because simultaneously 5-6 people have kept their mic on, so that's why this disturbance.
Yes, sir.
Priyadarshini, I think they muted the speaker too. Tell them the name of the speaker and to unmute the speaker.
Am I audible?
Yes, you are audible.
But I think my screen is not. It is
You can
playing
see
in-
your screen, but I think there is a lag or delay. You can click on your video, just wait for a few seconds, and I hope that video starts playing.
No, it's playing in my screen. Just a second. Just a second. Give me a bit of time. At times we are actually technically handicapped.
That's true.
Just give me a second. If I can start it. It's playing in my screen. It's not.
If you are sharing your entire screen or a particular window,
I'm sharing particular window.
then it should have come. I don't know.
This
why
is the
it's-
dramatic cataract basically.
Okay, now we can see something.
Just can you see my screen, sir? Or is it not visible?
We can see a pixelated screen. I don't know if it is from your laptop or what.
Okay.
I think you can just close this window and then start the video again. I think that can help.
Okay. Just a second. Problem. No, sir, it's not coming actually. It's playing in my laptop screen, but not here.
In that case, can we have the next speaker, Dr. Ifat?
Doctor.
Are you ready?
Yes, good morning, sir.
Good morning.
Dr. Mohammad Shah, can you please send us the video? We can play it for you maybe. In the meantime.
From where, ma'am?
I'll just send you the mail ID. You can send it to us.
Okay. Sure.
Yeah.
So, Dr. Ifat Nasir, you can play your video, cataract surgery in ocular albinism. If you're ready with it.
So my screen is not showing the sharing option. I think the previous speaker needs to turn it off.
Yeah, Dr. Mohammed, you have to stop sharing and then.
Okay. Sorry. Okay. Just. I have stopped. Okay.
So should I start?
Yes.
Yeah,
please.
sure.
Good morning, everyone. I'll be presenting of phacoemulsification and ocular albinism. Talking about history in brief, A 48-year-old male presented to us with the chief complaint of diminution of vision, both eyes since childhood, which increased for past 1 year. It was more in right eye than left eye. And complaint of photophobia and to and fro movements of both the eyes were present since childhood, and complaint of glare was present in right eye for 3 to 4 months. On general physical examination, generalized hypopigmentation of the skin and hair was present. An ocular examination, bilateral high myopia was present, and the best corrected visual acuity in right eye was 618, and in left eye it was 612. Lids and adnexa bilaterally showed hypopigmentation. Bilaterally jerky nystagmus was present, and iris bilaterally showed diffuse atrophy with presence of transillumination. And the maximum dilation was about 6.5 millimeters only. Right eye had IMSC with nuclear sclerosis type 2 with posterior subcapsular cataract, and left eye had IMSC of nuclear sclerosis type 1. Bilaterally, fundus showed temporal crescent with diffuse tessellations and foveal atrophy. So the diagnosis of oculocutaneous albinism was made with bilateral IMSC, right more than left, with bilateral nystagmus. So the patient was planned for right eye pupil-emulsification surgery with the PCIOL implantation under guarded visual prognosis under local anesthesia. So here's the video of the same. The initial steps of MBR entry and dyeing of bag had already been done. This is starting from capsular excess. So in this video, we can see the exaggerated fundus reflex, and we can also see the hypopigmentation of iris, this diffuse atrophy of the iris. And the dilation of iris is not very much, just 5 to 6 millimeters only.
अच्छा जीबी होगा कम से कम.
Now the main port was extended, and it was the triplanar incision which was made in spherotemporal quadrant.
मैं अभी तो नहीं हुआ, हो जाएगा. कर दिया तुमने?
Now the dye is washed and hydrodissection and delineation was performed. We can see the billowing of iris. And iris has prolapsed from the main wound. It was then reposited back into the anterior chamber by using iris repositor and by putting little bit of viscoelastic over it. So here we are putting some viscoelastic over it, and then phacoemulsification was performed. We can see that there is further narrowing of pupil, and the iris is trying to come out again of from the main wound and from the side port. And this narrowing of pupil has left very small area for surgeon to perform maneuvers. Again, we can see iris billowing here. So further phacoemulsification was performed by a direct vertical chop technique. Now, to overcome this prolapse of iris, the bottle height was decreased and also the flow rate was decreased. So again, we can see that the iris came out from the main port. And this time it was deposited back by using high density viscoelastic, and the same was used to maintain capsular bag and to maintain anterior chamber. Now foldable IOL was implanted into the bag. So one haptic is still over the iris plane, but it was dialed, and we were successfully able to place the IOL into the bag. Then the viscoelastic was washed. Then hydration of ports were done, and then the anterior chamber was maintained by leaving air bubble into it. So the challenges that we saw in the surgery was the nystagmus, which was dampened by using local anesthesia and by holding the eye with the second instrument. And there was exaggerated fundus reflex, which caused glare to the operating surgeon. So to overcome this, intensity of illumination of microscope was decreased, and there was insufficient pupillary dilatation like we saw. So which decreased the operating area to even 3 to 4 millimeters also. And there was repetitive iris prolapse. So to overcome this, bottle height was decreased, flow rate was decreased, and iris was inserted back by using iris repositor and by putting viscoelastic over it. So despite of these challenges, it was a successful surgery with this post-operative result. The vision on day 1 was 6/18, and the rest of the findings were absolutely within normal limit. So the take-home message in this case is that there were many challenges due to ocular albinism, but it was effectively managed by complete preoperative evaluation and taking appropriate measures during surgery. So this was an uneventful surgery with good post-operative results. Thank you.
Is there any questions?
Thank you, Yukta. What was the viscoelastic that you were using to reposition the iris?
So we use high density viscoelastic for it.
High density or high specific gravity?
Sir, high viscosity.
High viscosity.
Yes, sir.
Okay, can you name that? Which brand that was used? Is it Hilon?
Yes, sir. Hilon, yes, sir.
Okay. Okay, good presentation. Priyadarshini, I think we can move on to next speaker.
The next speaker is Dr. Pratibha Sesema. Dr. Pratibha, are you ready with your presentation?
Yes, ma'am.
Can you share your screen?
Yes, ma'am. Yes, ma'am.
She will be speaking on, she'll be sharing the video on surgical video presentation by left-handed trainee resident.
Priyadarshini, I think you can request Dr. Mohammed to mute himself. I think his mic is on and he has forgotten, I think.
Dr. Mohammed Shah, please mute yourself.
Is my screen visible?
Yeah, your screen is visible.
Okay. Good morning, all. Today I'll be showing a video on phaco surgery by a left-handed trainee surgeon. Myself, Dr. Pratibha Sesema, and I'm the left-handed trainee surgeon, and I'm currently working as second-year PG resident in University College of Medical Sciences and GTB Hospital. Dr. G.K. Das is my co-guide, Dr. P.K. Sahu is my co-guide, and Dr. Nitish and Dr. Manpreet Chugh are the senior residents. Being one of a kind is good, but everything has its own pros and cons, and definitely it becomes more imperative when you become a surgeon, and especially when you perform microscopic surgeries that require more of precision and skills. And globally, 10% of the population is left-handed population. So as a beginner, while doing phaco, it becomes really very hard, both for the guide as well as the trainee. Guide, who is almost always a right-handed person, has to be really patient enough to teach you through the surgery and the fine skills. and the movements, the way of handling the instruments, everything differs and thus require a lot of support and guidance to take a grip upon. So why not superior position? Being a beginner, there is always a risk of eventful surgery, and for completing the surgery in any problem, the senior has to come and take over the surgery. So the orientation of ports has to be according to the senior surgeon, which will be opposite for a left-handed and a right-handed person. So keeping in mind all the points, temporal position has to be chosen for a right eye patient. Starting with the phaco steps, the temporal position has to be chosen as in superior position, nasal bridge creates hindrance while a right-handed person chooses superior sitting position. And side port at 7 to 8 o'clock position in contrast to the right-handed person who chooses 1 to 2 o'clock position. And main port is made at 10 to 11 o'clock position. Sitting on temporal position, there is no support on the left hand. So while on superior position, head support is always there for a right-handed person. In continuous curvilinear capsulorhexis, there occurs a little difficulty as the left-handed surgeon does not have any support as compared to the superior position for a right-handed person, and a little irregular movement can disrupt the rhexis. After hydro procedures, when phaco is started, the similar problem, that is the lack of support on left hand, cause a little problem. An imbalance in amount of pressure with phaco tip during the trench making on cataracted lens can lead to an eventful surgery. So starting with the video, this video shows this is the right eye of the patient and the surgeon is on the temporal side of the patient. This is the right eye of the patient, and I'm sitting on the temporal side of the patient on right side. Side port on 7 to 8 o'clock position. Main port on 10 to 11 o'clock position, sitting on the temporal side. Hydro procedures done. This is a grade 1 cataract, phacoemulsification and aspiration. This is a second side port on 1 to 2 o'clock position. This is the irrigation and aspiration cortex removal. This is the foldable IOL implantation in the bag. Removal of the viscoelastic. And here the surgery ends with wound hydration. So coming to the conclusion, proper guidance and patience of the seniors and persistence of the juniors for learning makes the learning curve a little easy and exciting. Thank you for your kind attention.
Thank you, Dr. Pratibha. That was a good video.
Thank you, ma'am.
Dr. Pratibha, have you ever tried by shifting your position?
So on
Because I
superior
can see you are
position,
sitting exactly along the 180-degree axis of the patient. Have you tried to shift little bit toward the patient's foot end?
so usually I only sit on the extreme on the temporal side only. I haven't tried changing the position. Like
Because
in
if you
left
sit
eye,
exactly in the temporal position, the upper eyebrow that may give you some difficulty. I think that was the problem you were facing in that surgery, but you can try, you can give it a try.
yes, sir. Sure, sir. Actually, I'm not getting opportunity because of this the COVID pandemic.
And that is
I'll
same
surely try this.
for everyone. It's okay. It was a good video. Thank you.
You
Thank
can
you so
also,
much,
Dr. Pratibha, you can also, get in touch with people, left-handed surgeons.
Yes, sir. Sure, sir.
I'm sure on the panel there is no one who's left-handed right now. No.
So I think only I am the one.
You are special then.
Thank you, sir.
That was a nice video. Do we have the next presentation, next video ready?
Dr. Navonil Sav. Is Dr. Navonil Sav there? I don't think he's here.
Okay.
Dr. Salil Kumar Mandal, are you ready with your video?
Yes, yes. Yes.
He'll be playing a video on the lost world gained again.
The lost world gained again. In this case series, all the patients had a clear vision after successful phacoemulsification surgery. Few years after, they complained of a gradual onset of diminution of vision. On examination, they were found to have an ossified eyewell. The only option for them to regain the vision of a lost world is eyewell exchange. History surgery just 4 years back. A 2.8 millimeter clear corneal incision was made. Foldable eyewell intimately adhere to a capsular bag. Difficulties to remove the eyewell from the capsular bag. Due to capsular phimosis, careful separation of eyewell from the capsular bag was attempted, but failed attempts to separate the optic from the phimosed anterior capsule with a cystitome or by manual sharp chopper manipulation prompted me to incise the anterior capsule with a sharp knife, that is, side board. A repeated attempt the knife is used to cut the capsule haptics are cut from the optic and kept in situ to prevent the bag dialysis. Ultimately, the bag is opened in sharp knife or side poke. Try to lift the optic from the bag with minimum manipulation and cut the haptic and kept in situ to prevent the bag dialysis. Traditional IOL unfolder is cut above and below for molding of IOL during explantation. Guitar string was used to make the snare loop, which was passed through the unfolder, that is the trap. Drawing inspiration from common wildlife videos to catch the trapped cougar, that is the most dangerous animal, catch easily. A pre-sterilized fine guitar string was used as a snare to expand the ossified IOL through the 2.8 mm incision. The optic is centered into the trapped loop. With gentle pull, foldable IOL mold and pass through the unfolder. After that, triamcinolone acetonide was injected to detect any vitreous thread in anterior chamber, and also the vitrectomy done to remove the vitreous thread. A new foldable IOL exchanged, replaced, and inserted into the sulcus. The IOL is placed into the sulcus gently and carefully. Try to rotate the IOL over the sulcus and center it. Anterior vitrectomy was done to remove the fine vitreous from the disc. In case 2, here is the approach somewhat different. It's a temporal approach because the haptics were vertically placed and both the haptics were cut from accessible different angle with minimum manipulation. Again, the snare is made by guitar wear. IOL is strapped into the loop. Here the material of the IOL was so rigid, while pulling the snare it was transected into 2 hubs. Probably there is a biochemical changes due to long-standing staying in an anterior chamber. Its loses is molding property of a foldable IOL. A new foldable IOL again placed to the sulcus very gently and carefully. So here is entry and exit is the same route without modifying the old architecture, that is 2.8 mm incision length. This is the new methods and the devices applied here in our series, all the patient get excellent vision with minimum change of pre-operative refractive error. The astigmatism is a minimum, not much of change of astigmatism. This is the third post-operative day of the right eye. And this is the third post-operative day of the left eye. So the patient gained vision, the lost world gained again. Thanks to RIO for making this video and present in front of you. Thanks.
Yeah, Dr. Mandal, both excellent videos, I must say.
Thank you.
Both excellent videos you presented, very, very good videos, both of them. My only question, were you able to easily explant from a 2.8 using that snare of yours? Were you easily able to explant through a 2.8 size incision?
Actually, we are using the unfolder, which is cut, and we are trying an experiment that how this remove the optic of the foldable IOL. The haptic is kept in situ in the bag, and just the optic diameter is almost 6 millimeter, and it is removed through the unfolder, which is 2.8 millimeter. But it has, the video has been seen that the biochemical changes, all the operation done after 3-4 years, when the rigidity of the foldable IOL is there. So it is not molded all the time. So that is the first case. It is molded inside the unfolder and comes out with the snare. In the second video, it is not molded. It is cut through and through, and that is how it removed. And we take the advantage of 2.8 millimeter incision, and without making a larger incision. So phaco effect is there. That means the astigmatism is almost minimal. That is why our effect, but this is not a authentic procedure. I say this is an experimental procedure. The IOL cutter is there. Most of the people are using IOL cutter. Don't use this procedure. It's not a choice, but this is our experiment. We are success that the same entry and same exit in this, the route is same, and without modifying the own architecture. That's all.
I think that's a good innovation with a good result. And so you
Yes.
see pretty eyes post-operatively is very nice to see. And also you finished your
Yes.
video very much in time, and it was well timed, well presented, and a good content, I must say.
Thank you.
All right. So can we, is the next video ready? Is the next presenter ready?
Dr. Sohail Irfan Mohammad Khan. Is Dr. Sohail Irfan Mohammad Khan there? I think Dr. Prashant Girish is there. Dr. Prashant.
Yeah.
Can
So,
you start your video? And
yeah,
I am a cataract surgeon with an intraoperative OCT.
Yeah, thank you. I'd like to thank those for giving the opportunity. A very good morning to everybody. I'm be sharing my video now. My screen is visible?
Yes, sir, your screen is visible.
Yeah. Thank you.
An eye of a cataract surgeon with an intraoperative OCT. The authors have no financial interest in this presentation. Use of technology in ophthalmology has grown leaps and bounds. The invention of optical coherence tomography, OCT, has led to a revolution in the diagnosis and monitoring of numerous anterior and posterior segment pathologies. The introduction of OCT into the operating room OR, called as intraoperative OCT, IOCT, provided new insights into the surgical management during ophthalmic surgeries. The DISCOVER and PIONEER study have been evidence of applications of IOCT in the field of corneal and vitreoretinal surgeries, including lamellar keratoplasty, ILM peeling, molecular hole surgery. Little did we know that utilization of IOCT in cataract surgeries had varied applications and additional information in several surgical maneuvers impacting surgical decision making. Now get ready to view from the eye of a cataract surgeon through a variety of cases performed using an IOCT. Scleral corneal tunnel in manual small incision cataract surgery, MSICS. In this case of corneal buttonhole, IOCT was instrumental to confirm the adequate depth of new tunnel without disturbing the superficial plane. Clear corneal incision of keratome. Intraoperative OCT has been used to assess morphological features of the wound like length, breadth, and the number of planes in real time. Maximum incidence of wound site DMD has been observed during the step of final stromal hydration. Ragged morphology of proximal opening of CCI is the most important predictive factor for incision site DMD. Clear corneal incision femto. Here we see the plane of entry of a femto wound with a spatula, and adhesions or laser uncut areas can be identified, and IOCT can guide the surgeon prior and plan ahead. There was a cavitation or gap between the corneal surfaces even before the manual opening. This also correlated with less resistance offered by these wounds at the time of opening as compared to the well-opposed wounds. Femtosecond laser wound have less incision site DMD as compared to keratome-assisted incision. IOCT provides real-time assessment of CCI morphology and DMD. Sclerotic anterior lens capsule. In this case of sclerotic calcified anterior lens capsule, we can observe the extent and depth of ALC plaque, and IOCT aids in visualizing for any adhesions and stability of capsular bag. Nucleus management in MSICS. Before delivering a large dense nucleus in MSICS, IOCT helps confirm adequacy of viscoelastics between nucleus and corneal endothelium, hence ensuring corneal protection and corneal endothelial integrity. Posterior polar cataract. Phacoemulsification in PPC is a challenge to anterior segment surgeons. PPC with intact capsule is assessed by IOCT. Here we can appreciate in real time the physical separation between the epinucleus and the endonucleus. Following hydrodelineation, phacoemulsification is performed safely with clear visibility. Separation between the posterior polar plaque and the capsular bag with safe viscodissection, the epinucleus is separated and the aspiration of cortex is done, ensuring no PC dehiscence. Phacoemulsification. Learning curve in phacoemulsification. With the MIOCT, novice surgeons can visualize the exact depth of trenching in context of its distance from the posterior capsule, which will be of utmost importance in cases where red reflex is not visible. A case of traumatic cataracts. In this case of traumatic cataract with 4 to 5 clock hour zonular dialysis, CTR is guided safely into the bag, and the weak bag with folds becomes stretched back to normal after CTR insertion as seen in the IOCT, and stability and centration of IOL was confirmed. Iris hooks. Small pupil in cataract surgery. Synechial release is performed with spatula, making 4 side ports at parallel to the iris plane and about 1 mm posterior to the sclerolimbal junction to achieve a more physiological retraction. The proper placement of the iris hooks and gradual enlargement results in a pupil size of 6 mm. The iris raised, iris platformed is assessed. IOCT helps to visualize and assess the challenges faced with improper positioning. In a case of resurgery following complicated cataract surgery with PCR-IOL in sulcus and residual cortex beneath the IOL. As seen in the video, with the IOCT, we were able to assess for remnant cortex seen as hyperlucent areas behind IOL and ensure complete removal with the vitrectomy cutter. IOL centration and stability were confirmed with IOCT. Corneal capacity obscures visualization for cortex aspiration, and few areas of capsular fornix are not visualized clinically. IOCT aids in identification and removal of remnant cortex in this difficult situation. Loop technique. Using micro-thin superelastic, self-expanding nitinol filament technology, it fragments the nucleus. The challenge lies in injecting the filament loop under the anterior lens capsule. Here we can visualize the filament passing between the cortex and posterior capsule as a hyperintense shadow moving across just above the posterior capsular plane, and churning of the cortex is noted. Conclusion. As every new invention or innovation has its own limitations and boundaries, IOCT technology also has its own, such as shadowing from instruments, lax eye tracking systems. But we just witnessed that it is imperative to realize intraoperative OCT, IOCT is an emerging modality with the potential to revolutionize the surgical techniques of cataract surgery by improved individual surgical management and patient care. Thank you. An eye of a cataract surgeon.
Yeah.
Thank you, Dr.
Thank you.
Prashant. Is Dr. Navonil Sao or Dr. Sohail Irfan Mohammad Khan there?
Priyadarshini, just check if any of the speakers are there. How many more left, Priyadarshini?
So two of them were skipped because they were not there before.
Okay,
And
I
two
think
of them
ma'am is
weren't
there.
able to play the video, so they are mailing it.
Okay, fine.
Ma'am,
How many
can
are
I
left?
play it now, if possible?
Is it a 10:30 session? Sorry, good morning, everybody.
Yes, ma'am. There is a 10:30 session. I think this is 9 to 10:30 session is still going on.
Yeah, so
We'll
is it,
try to wind it up as fast as possible.
okay. So I have a video at 10:30, not before. It's okay.
Ma'am, can I try playing because the time is still there, like, if you allow me.
Priyadarshini, you did the last
Yeah.
presentation.
So the last is over. Two people are absent, and
Okay, fine. Then yes,
yeah.
let him play his video. We still have 6 minutes.
Dr. Lalit, please go ahead.
Yes, ma'am. Yes. Share.
Easier and simpler technique of performing phacoemulsification.
My video is visible?
Yeah, it's visible. Yes, it's good.
In cases
Continue.
of forming capsulorhexis, here I am mechanically dissecting epinucleus from nucleus. This is mechanical delineation I am performing over here, and that's separating nucleus and dividing it into two halves, and then aspirating nuclear fragments to the phaco tip. So after completing my core phacoemulsification, I am trying to aspirate epinucleus from the opposite clock arcs, thereby creating a cleavage between epinucleus and capsular, and now mechanically dissecting epinucleus from capsule. Here I'm using blunt tip chopper for nucleus and epinucleus separation. Now epinucleus is free and can be easily aspirated. Similarly, in another case, after performing capsular excision by using a 26 gauge bent tip needle, after engaging nucleus, I am performing mechanical denudation and then engaging nucleus with blunt tip with the blunt tip chopper and fecoemulsification probe, and thereby dividing into two halves and then further dividing and aspirating into smaller fragments. Then aspirating epinucleus from the opposite clock hours with Wewel depth fecoemulsification, and after getting a cleavage, mechanically dissecting epinucleus from capsule. After loosening whole of the epinucleus into the center and aspirating simultaneously, so in this technique there is no hydroprocedure was used, and all these postoperative cataracts can be managed by using these simpler techniques. Thank you for kind listening.
Thank you, Dr. Lalit. I think Priyadarshini, this is the end of the session. Okay. Thank you everyone for participating. And I think we can wind up and let the other session people come in.
Thank you, sir.
Yeah, all right. Bye-bye. Nice one. Nice session. Bye, everyone.
Thank you. Bye.
Dr. Priyadarshini is there?
Yes, sir, I'm here.
Yeah, so I don't know if you have my, I'll just share my sheet with you.
Yes, sir. You can just send a picture of it to me, or you can send a picture of it directly to the DOS secretary, Dr. Namrata ma'am.
I'll send it to you.
Yeah, okay, sir.
Because you will have to also go through the other videos.
Yes, sir.
Which you will get by mail. I probably we have 1, 2, 3, 4. We have had 8 presentations, right?
Yes, sir. We have had 8 presentations, and one Dr. Mohammad Shah Zaki would be mailing it, and
Yeah.
2 people were absent. So
Dr. Zaki will be mailing it. And absent कौन hai?
Dr. Navonil Saw and Dr. Sohail Irfan Mohammad Khan.
So I've cut them out. Okay. So what I'll do is I'll WhatsApp you the sheet, okay?
Yes, sir.
Can I have your number, Dr. Priyadarshini, please?
Yes, sir. I'll just send it through chat.
Okay. Right then, thank you.
Yes, sir. Sir, I've sent you the number. You can just send your results.
Yeah, I'll just send a missed call. 9650.
Yes, sir, I've got your call.
Okay. Fine. So I'll just send it over to you on WhatsApp. All right.
Yes, sir.
Right. Thank you so much.
Thank you, sir.
Okay. Bye bye.
So can we move on with the next presentation? Next set of participants. I think we can move on with the next session. Dr. Devang and one of our judges is here.
Yeah. Hello, am I audible?
Yes, ma'am.
Yeah, so who's this? You would be be coordinating. Who's this?
Yes, ma'am. This is Priyadarshini.
Yeah, Priyadarshini, you have the names of the people?
Yes, ma'am. I have the names of the people. Dr. Subodh is the first, but I think he's not logged in yet.
Okay. Then?
Dr. Kirti Singh, are you there? Dr. Kirti.
He's also not there. And after that?
Dr. Sahiban Sethi. I think
Okay.
she's there.
She's there, okay. Then? Thereafter?
Thereafter,
Yeah.
there are two videos of Dr. Sahiban Sethi.
Okay, and after that?
Anirudh Kapoor, Dr. Anirudh Kapoor.
And there's another speaker, no? Dr. Julie also is there?
Yes, ma'am. There's Dr. Julie also.
Yeah, so like we would be starting the session at around 10:45 because we have an overlapping session in hall F also. So I was just I've just wrapped that up, and two of our judges would be joining within 15 minutes. So we'll
Okay,
start
ma'am.
at exact.
Okay, ma'am.
45 we'll start. Till that time, if the people join us, otherwise whoever is available according to that list, it would be
Dr. Subodh first, and if he's available.
yeah, but he has not joined, no?
No, ma'am.
Yeah, so
The first one would be Dr. Julie, according to the people
then,
we
then
have.
we'll start with Dr. Julie. Okay. We'll start with Dr. Julie first.
Okay, ma'am.
And then as per the list, we'll go, and when people join, as per their joining, we'll do that. Okay.
Okay, ma'am.
Priyadarshana?
Yes,
Hello,
ma'am.
Priyadarshana.
Yes, ma'am.
Any marking sheet from ma'am?
Ma'am, can I mail it to you? I have the
Yeah.
sheet.
We need to mail to all the judges, three of the judges, Dr. Bhalla and
Sunita is also there.
Sunita Dubey. You have to mail all of us.
Okay, ma'am. I'll just, ma'am, can you just send me your mail ID? I'll send it.
Yeah, I'm sending it. And you can, in the meanwhile, you can just contact the DOS office, no? The person who has mailed you, tell him to mail
Yes,
all.
ma'am. I'll mail the. I'll ask them to mail the others.
Yeah, tell them to do it immediately because the session is starting, no? They should have mailed it before only. So I've just sent, just see the chat box, I've sent my mail ID, okay?
Okay, ma'am.
Do we have to mail our video presentations to you?
Not
That
now.
is not necessary, ma'am. If you can play it from your end, it is not necessary to mail it to us.
Yes, I can play it from my end. Yeah, thanks.
Hello.
As veins with time, most common.
Is Priyadarshini there?
Yes, ma'am.
Hi, I just wanted to test my mic. Am I audible well? Because
Yes, ma'am, you're audible.
audible. Okay, can I also just dry run my video to see if the voice is working? Because I think there was some issue that I just fixed. I wanted to check if it's working properly.
Ma'am, you have just, you can just play it for 1 minute and see.
Okay, I'll
Because
just,
we'll be starting shortly.
sure. Could you hear the video?
Right now, we're not able to hear it.
Okay, so I think
May I help you?
yeah, so I'm actually connected through my AirPods because
Yes.
my computer mic is not working.
When you share the video, you have to click on the share computer sound.
1 second. I have to put on the share with.
Stop share and share it again.
Stop sharing. Right now, when I select.
Now click on share.
Okay, share screen.
When you click on the share screen, you must see the share computer sound and optimize screen sharing video clips on your screen.
Yes.
Lower left corner. Share computer sound.
So,
Okay. Okay. When you share the video, you must click on the share computer sound.
okay, only share computer sound. Not
Yes. Only share computer sound.
okay. Let me just run this.
Yes, please. Yes. Okay.
Could you hear it?
Plate.
Because it's playing on my.
Yes. So please remove your Bluetooth device or AirPod. You have to connect it.
So I should remove my AirPods when I'm playing the.
Yes. You must remove your AirPods. Disconnect your AirPod from the systems, laptop or whatever you have. Okay, sir.
Sorry, I didn't get that.
ना मैम एक बार रिमूव कर दीजिए लैपटॉप एयरपोर्ट रिमूव कर दीजिए.
Can we do a demo run of the video's connection, please? I asked that before also.
Yes, ma'am. You can try it. Ma'am, if possible, please, the dry run will be going on the green room. So if anyone has a issue, please join in the green room. The dry run for your video checking and all that thing. Yes, Balla. I'm Sarah Desi Barma. Sunita Dubey. Yes, Sunita.
Good morning, sir. I welcome Dr. J.S. Balla, one of our judges for today.
Yeah, good morning, ma'am.
Green room is not opening up. They are busy in doing something.
Ma'am, you can try it.
I'll just take a minute to see if it's working. That should be okay.
Very good morning to everyone. We are running late, so it's already 10:45 and Dr. Bhalla has joined. So first, as decided, Dr. Julie will start her video. Dr. Julie, please. Dr. Julie is there?
Yes, I'm there. Can you share my screen?
Please start here.
Yeah,
Please
please.
share your screen.
Yes. Can you see my screen?
Yeah, we can.
Yes.
Just let me know if you can hear the audio also. I'm just playing that now.
This video demonstrates ways to enhance success of trabeculectomy in secondary glaucoma. Secondary glaucomas are difficult to manage as a high intraocular pressure perpetuates a vicious cycle of increased inflammation, increased ischemia, and the medications don't work. This vicious cycle can be broken by normalizing the intraocular pressure that would cause a reduction in the ocular stress, decrease in the inflammations, and the medications also start to act. In the early stages of neovascular glaucoma, a timely PRP or injection of anti-VEGF would cause the vessels to regress and IOP usually gets controlled. However, in the late stages of neovascular glaucoma, the medications are usually not effective. Also, the high intraocular pressure and decreased corneal clarity makes PRP difficult. So in this scenario, you may go ahead and choose to do a trabeculectomy if you have a mobile conjunctiva. Preoperatively, it is important to give anti-VEGF injections 1 to 2 weeks before the surgery to cause a regression of the NPI, to control diabetes and hypertension, and to continue with the anti-inflammatory cycloplegic and the anti-glaucoma medications. After the watertight connective should on the 0 micron, hydrate the paracentesis site, and 1.25 mg of Avastin is put into the anterior chamber as a last step, and also 1.25 mg is injected just away from the bed. All the maneuvers should be done from the host cornea with a touching the graft. In extensive peripheral synechia, the iris may be stuck to the cornea and needs to be gently pulled out and then cut it. Paracentesis site should be sutured with N0 nylon. This patient was a one-eyed patient with advanced glaucomatous damage and uncontrolled intraocular pressure with vision of 6/9. She had already undergone a trabeculectomy elsewhere that was not functioning. After dissection of the scleral flap, we noted that the ciliary region was extremely thin. The scleral spur was marked out and sclerostomy was done anterior to it. Rest of the surgery was done in the usual way. After the surgery, her pressures were well controlled and her vision was maintained at 6.9. Most of the glaucomas following VR surgery are controlled with anti-glaucoma medications. In patients in whom the superior conjunctiva is spared and is mobile, a trabeculectomy can be planned as usual in these patients.
Good morning. Good morning.
However, in certain circumstances where the eye is filled with silicone oil and cannot be removed because of protective parties, you may have to do a TACBC, which can be a graded one. And also in circumstances where there's extensive conjunctival scarring, as in eyes which had undergone an RT surgery with an upper implant. In these patients, a tube implant procedure can be planned with an Ahmed glaucoma valve. Scarred area can be gently dissected away and the plate of the AGV can be placed over the buccal. Last but not the least, the visual rehabilitation of these patients are very important at the end of the day. With the help of spectacle magnifiers, the near vision of these patients can be markedly enhanced.
ये थोड़ा सा ये ओवर है मैम
वेरी गुड
ये नहीं पसंद में आ रहा हमको
इसके ऊपर
ऑफ कमेंट्स
Others, please mute your videos,
is
audios.
selected है ना
ठीक है. Patient and the patient's family were related when the patient was able to dial numbers and was able to do. अच्छा भी dial कर
I have stopped the share now.
Yes, ma'am. So, Dr. Julie, that was a very good presentation. Judges?
उस पे जाएंगे तो देखो आप मेरे पास ये ऑप्शन
Dr. Balla?
Yeah, I think now we can invite the next presenter to present the video.
Dr. Balla, as per the program sent to me, mine was second. Is it possible? Can I do it? I'm having net connectivity problems.
Yes, ma'am. You can go ahead with the video.
Yeah, you can go ahead, Kirti,
Thank you.
please.
Thank you.
Please. Okay.
Because the candidate's already waiting.
Is it visible?
It is visible. Please go ahead.
Please start the timer as the video rolls. Dr. Kirti, is there a problem in your video?
Are you able to start, Dr. Kirti?
I think she's left. I think we can go ahead with the next video.
Yeah, Dr.
Dr.
Sahiban,
Sahiban,
please.
Yes, ma'am. So good morning, everyone. This is Dr. Sahiba Sethi. I'll start my video on phacoemulsification and nanophthalmic eyes now.
Dr. Saivan, has it started? It does not have any audio.
Yes, ma'am. I'm keeping track of the time. I've started the timer.
Okay, okay.
No. I'm telling the video is not running. Dr. Saiban's video is not running. Yeah.
It is started now. It does not. Yeah.
Its clinical features are short axial length of less than 2 standard deviation of the general population, shallow anterior chamber of less than 3 millimeters, abnormally thickened sclera and choroid of more than 1.7 millimeter, and high lens to eye volume ratio. This shows us the difference between a normal eye and an anophthalmic eye. With marked reduction of the axial length and progressive shallowing of the anterior chamber, but a constant lens size, increases the lens to eye volume ratio from a normal of 4% to 10 to 30%. What are the dangers of operating on an anophthalmic eye? Intraoperatively, the most threatening and visually debilitating complication is choroidal effusion with subsequent hemorrhagic choroidal detachment. Let's see how choroidal effusion occurs in these eyes. An abnormally thickened sclera impedes outflow from the choroidal vessels through the vortex waves and causes choroidal congestion. The sudden drop in intraocular pressure when the eye is opened leads to reduction of tissue turgor, which leads to exudation of proteinaceous fluid into the suprachoroidal space, causing choroidal effusion, and if severe, may lead to the dreaded complication of kissing choroidals, which looks like this. Hence, we stress the need for the use of prophylactic sclerotomies in these patients. In spite of an uneventful surgery, one must not lower one's guard in the early postoperative period. Progressive anterior chamber shallowing leads to development of peripheral anterior syndicate with subsequent intractable glaucoma, which has to be carefully looked out for. Late postoperative complications include late choroidal effusions associated with non-reticulomatous retinal detachment, which explains the need for lifelong follow-up of these eyes. Before embarking on phacoemulsification in non-ophthalmic eye, one must do a thorough surgical planning, which includes proper patient counseling, adequate control of intraocular pressure with oral acetazolamide and IV mannitol to debulk the vitreous volume. A careful biometry must be carried out, including documentation of the axial length, anterior chamber depth, lens thickness, laser thickness, and pachymetry. A detailed investigation of the eye to rule out any associated comorbidities should be done. Ultrasound biomicroscopy B-scan will help pick up any pre-existing choroidal effusion. A careful gonioscopy can reveal any pre-existing angle closure. Specular microscopy can be done to rule out Fuchs endothelial dystrophy, which coexists with these eyes commonly. So let's throw some light on a few aspects that often pose dilemmas as researched through literature. First dilemma is as to what type of anesthesia to be used. General anesthesia is preferred to reduce upthrust and to keep the eye as soft as possible, and also as the operative time may be prolonged in such cases. Next question is whether to do a preoperative peripheral iridotomy or not. So, if a pre-existing angle closure glaucoma is diagnosed, preoperative PI must be done at least 2 weeks preoperatively. This may also marginally deepen the anterior chamber. However, definitive management of the angle closure glaucoma will be lens extraction itself. One must remember that glaucoma filtration surgery has high chances of malignant glaucoma in these cases. A debatable question is whether to do a prophylactic sclerotomy or not. Well, firstly, if there is a pre-existing uveal effusion, sclerotomy must be done followed by cataract surgery at a later date. Secondly, if patient is going to have a bad follow-up, also sclerotomy becomes imperative. Thirdly, to prevent dreaded complications like choroidal effusion, suprachoroidal hemorrhage, we suggest the routine practice of making prophylactic sclerotomies during phacoemulsification. Next, which IOL formula to follow? The third and the fourth generation IOL formulas like Hoffa-Q, Holiday 2, or Hygus give more consistent postoperative results compared to SRKT or SRK2 in small eyes. Which IOL to select? Select the IOL of the highest power available for that patient. There are single-piece hydrophobic acrylic IOLs available with powers of up to +40 diopters. Any residual refractive error can be corrected using spectacles, contact lenses, corneal refractive correction, or piggyback lenses. Next, how many IOLs would be needed? Well, aim for a single IOL of the prepared with our surgical armamentarium to tackle suboptimal dilatation, increased positive pressure, iris prolapse, which are not very infrequently encountered. Even a successfully done surgery left us with post-operative issues to deal with, one of which was refractive surprise or retinal refractive error, which in this case was tackled by prescribing spectacles to the patient. The refractive outcome is more predictable using off-the-cue formula in our experience. Second issue we had to deal with was the post-operative inflammation, which was treated using intensive post-operative steroids and cytotoxics. In our experience, pre-operative use of NSAIDs may have some positive effect on the post-operative outcome. All in all, despite medical planning and execution, patient may be left with suboptimal vision, which can be attributed to cystoid macular edema, corneal decompensation, amblyopia, etc. Or even if nothing seems to be wrong, foveal underdevelopment seldom does occur in these patients. Conclusively, a lot still needs to be done in this area. A few projects underway in India might in the future give us customized IOLs of more than 40 diopter power, be able to predict change in the anterior chamber depth after sclerotomy with mounted OCT. Familiar genetics and potential biomarkers within the sclera are meticulous planning, careful technique, and thorough lifelong follow-up will ensure safe and successful outcomes.
Think
The video quality was really, it was uploaded from DOS or it was presented from your side only, Saiman?
Can I do my video share, please, this time, Dr. Angmo? I'm sorry.
Yes, ma'am.
Yeah.
There's a huge problem.
Yeah.
We understand, I think.
This we'll just let you do. Dr. Saiban, the video quality, as Dr. Sunita has pointed out, as well as the sound quality was very poor. Half of the things we could not even hear.
Yeah.
Okay.
Did you upload from your side or it was done by this thing IT
No,
people?
from my side only, sir.
Okay.
Did you check it previously? Because everybody checks it the evening before. And
Yeah. Yes,
So
I did. I logged in on the 16th and I checked it. In fact, we did a dry run just right now also while we were waiting for the sessions to start.
It was okay during dry run.
Priyadarshini will be able to say right now. Was it working?
Ma'am, initial part it was working. We just heard it for like 15 seconds around.
That time there was no problem with the audio video quality?
Audio quality was also okay. Video,
Maybe
we could just
put our videos off because it, I think, affects the bandwidth.
Okay.
Okay, and Priyadarshini, are we is the timer on? Because now the timer is not showing.
Ma'am, here they're not keeping the timer on, but I am keeping the timer on from my
Yeah,
side.
so you have to tell us. You have to tell us that it's well in time.
Yes,
or
ma'am.
over time,
Yes,
okay?
ma'am. Yes,
Yeah.
ma'am. It was just 8 minutes, so I didn't interrupt. It was just 8 minutes up.
No, at 7 minutes now, if you can just say 1 minute remaining and then 8 minutes time up.
Okay.
If that could be done, I think that is going to help us.
Yeah.
Okay.
So
we can
we'll
start with
switch
Dr.
off.
Yeah,
Okay.
we'll switch off our video and this thing.
Yeah. And Dr. Kirti,
should I
think
go?
Yeah, I'm ready.
Yeah. We'll just ask Dr. Kirti to present because her bandwidth is not good. Yeah.
Sure.
Thank you.
Sure. I'll wait. I'll wait.
Is it visible?
Yeah, it is visible. Go
Yes,
ahead.
yes. Thank you.
Please.
I think again sound is not clear.
For me, it's coming very clearly here.
No, I am not very sure. What about Dr. Bhalla and Devang?
No, sound is very, sound volume is very less.
Yeah, it is very
Ma'am, I
less.
think you can increase the volume a little.
Mine is maximum here.
You're doing it from your desktop, okay?
Mine is maximum here and from a desktop. Yes.
Yeah, so that's why the sound is not coming. If you're using a desktop, you're supposed to use an earphone for the sounds.
Yeah.
Can you increase the volume of media player, please? Media player volume is low. Increase that.
Yeah.
No, the slider you have to move. Yeah, increase that.
Is it better?
Better.
It's better.
Yeah, better.
At end of needling, conjunctival entry site is sealed with viscoelastic. Another case where the bleb is walled off is being subjected to needling. As you can see, similar sweeping and puncturing movements are done. Remember to balloon out the conjunctiva intermittently with fluid containing the antimitotic drug solution. At all times, needle tip visibility is required to ensure that no conjunctival buttonholing occurs. Improvement in bleb morphology and function begins from first day onwards. Modified needling by internal revision is done in bleb failure caused by blocked spherostomy. Iris tissue blocking the spherostomy is the usual culprit. This can only be diagnosed by gonioscopy. Therefore, gonioscopy is mandatory in bleb failure management.
Thank you.
Thank you, Dr.
Trap veins with time. Most common.
Do you want me to show it again? I have time. If it was not audible before, or I should call it quits, as the judges say.
Maybe I think the initial part you can show if there is time.
Cause being subconch fibrosis.
Yes, ma'am, there is enough time.
Attempts to revive these failing blebs by lysing the fibrosis. Needling can be analogous to CPR to revive a failing bleb. Decision to perform needling is dictated by time of bleb failure. It is definitely indicated in intermediate bleb failure within first year of surgery and in late bleb failure. Signs of bleb failure are encapsulation or rolling, reduction in size, vessel corkscrewing or straightening, and increased vascularity. Frequently, it is accompanied by increase in IOP. Now, we will show 4 case vignettes revived by needling. Needling is an ab externo procedure performed in aseptic conditions under topical anesthesia using 26-gauge needle or tuberculin syringe loaded with antimitotic solution containing mitomycin or 5-fluorouracil. Scar tissue is lysed with to and fro and sideways movements. A gritty feel indicates fibrotic bands and a give its release. Bleb is approached from nasal side 2 and procedure repeated. Cutting of scar tissue can result in subconch hemorrhage. At end of needling, conjunctival entry site is sealed with viscoelastic. Another case where the bleb is walled off is being subjected to needling. As you can see, similar sweeping and puncturing movements are done. Remember to balloon out the conjunctiva intermittently with fluid containing the antimitotic drug solution. At all times, needle tip visibility is required to ensure that no conjunctival buttonholing occurs.
improvement in their morphology and function begins from first day onwards. Modified needling by internal revision is done in cleft failure caused by blocked sclerostomy. Iris tissue blocking the sclerostomy is the usual culprit. This can only be diagnosed by gonioscopy. Therefore, gonioscopy is mandatory in cleft failure management. Thank you.
Thank you.
Dr. Kirti, there's one question. Can we ask the questions?
Please, please.
Yeah.
So, which cases, how do you decide whether needling will be effective or not, looking at the bleb? Do you perform any tests, additional tests, or some investigation?
Yes, so I do IVAX classification, and each time a patient comes back to me, if I find that the bleb height and the extent are reducing, IOP may or may not be increasing, because over time I found the earlier I intervene with needling, the better the success rate. This paper was spoken yesterday, so I'm not repeating the same one. And so when I decide, whenever this bleb extent reduces or the height reduces, I go ahead with the needling. I don't wait for the IOP to rise.
Yeah, so basically it is mostly effective if there is subconjunctival fibrosis. Okay, so if there is subscleral fibrosis, then you do something additional?
Yes, yes. This is not part of the video, yes, but I do that. When I do when I movement, when the bleb is localizing, with the swab stick, you check it out on the table. And if it is if the movement is there, then you realize that it's subscleral fibrosis. Then and I do needling always in the OT. I don't do it in the OPD, unlike other people. So when I take it up in the OT, in that case, we have done a gonioscopy always beforehand. In that case, I convert the procedure from an extraocular to an intraocular procedure, and then I make a paracentesis, insufflate the anterior chamber with visco, and then with the same simple straight rod instrument which I have, I go up to the sclerostomy site, analyze the fibrosis there also, going between the subscleral, superficial flap and the deeper flap. So with the lysing movement, you enter from the sclerostomy site. And after that, I close the anterior chamber, and I always do an external needling also, because moment the aqueous doesn't come out, anyway, the subconjunctival fibrosis is going to happen. So I combine the two procedures then.
So can we ask questions to Dr. Sahiban also? Because I think it was, we have enough time.
Yes. We have
Yeah, my
sufficient
video was
time.
very short. You have time, I think.
Yeah,
Yeah.
sure. So Sahiban, yeah, you discussed about nanophthalmos.
Yes, ma'am.
So do you always perform sclerectomy like for all cases of nanophthalmos, or what are the
Ma'am, actually, the thing is that this is an extremely rare phenomenon. So I've seen it just once in my life. So in that case, yes, I did do a sclerostomy. And when I did a thorough literature search, there is actually quite a lot of controversy. There is one report which says that now with the advanced microincision phacoemulsification, it may not be required. See, on certain conditions that it's absolutely mandatory is if you have a pre-existing choroidal effusion. In that case, of course, you have to perform a sclerostomy and then do a cataract surgery at a later date. Another situation where if you feel that the patient might have a bad follow-up, because these patients can develop choroidal effusion anytime in their life in the future. So if the patient is going to have a bad follow-up, then also a sclerostomy is indicated. In all other conditions, it's actually a patient's choice. So just to be safer, we did a sclerostomy in this one case.
And what percentage of cases do you, or according to the literature, mention doing anterior vitrectomy also? Because you mentioned that also if the AC is very...
So anterior vitrectomy, it's not so much about the percentage of cases as much as it's the clinical presentation of the case as such. So if there is an extremely shallow AC with an iris bowing, when you feel that even maneuvering of the surgical instruments in the anterior chamber will be difficult, that is the time when you can do a little bit of anterior vitrectomy to just fall the AC back, so that the iris falls back and there is a little space in the anterior chamber. We did not do it in our case because if you have like an anterior chamber depth of say about 2 millimeters or so, it's easy, which is what happened in our case.
Okay, thank you.
Saiban, for like if there's only a choroidal effusion per se, I don't think so. We do, like the literature doesn't do sclerostomies for that cases. If there is a hemorrhagic one, then only those are drained.
Ma'am, but if
And-
you have to embark on a phacoemulsification in a case of pre-existing choroidal effusion, in that case, would you not?
No, normally we don't drain. If you leave the choroidal effusion, if you give them oral steroids and leave them for 2 or 3 weeks, it settles on its own if it is not hemorrhagic. And we have seen like a couple of cases in which they have resolved on its own. Without
And phaco in an anophthalmos following that will not cause it to happen again.
Yeah, no, we didn't have. After 3, but you have to give them time of 3 to 4 weeks for it to settle down.
And after that, I think you need to do a very slow decompression.
Yeah.
Intraoperative precautions are very important in such eyes. There should not be sudden decompression of the eye.
Even fluctuation should be avoided.
Fluctuation, so anterior chamber depth should be maintained all the time.
Absolutely right.
Yeah.
Dr. Kirti, I have a question for you. What is your success rate with these needling patients that you're doing?
A very high success rate. In fact, I presented this study of ours in 54 eyes, which we've completed, which we actually documented, not complete. We've done many cases, but we documented, and the success rate was very high. It
How
was
much
almost 60% patients we could. Our success rate was, we defined it as a 20% reduction in IOP was a success rate criteria, and going by that criteria, almost 57% of our patients succeeded. Okay. And only in the 54 eyes, I think only 8 or 9 eyes required a resurgery. And the second part is that when we do the first needling, it may have a partial response. So it is also literature documents that after wait for 6 to 8 weeks, you can repeat the needling. So I go up to 2 needlings. I don't go the third needling. I go up to 2 needlings. And if the second needling also doesn't work, then of course I go on to a repeat surgery. And another thing I want to highlight, since you asked, is initially we were.
I think light chali gayi.
Yeah.
So I think
Okay, I think can we go ahead with the next presentation, and if time permits, can I have Dr.
Dr. Saiban is next. Yes. Can you start your next presentation, Dr. Saiban?
I think we can have, if we have time, we can have Dr. Julie's video again.
Yeah, we can have.
I think all the judges can see all the videos, no?
Yeah,
And
we can
other-
do that at the end. Once everyone finishes, then we can.
Then we can redo it.
Yeah, Dr. Priyadarshana, please note that, okay?
Yes, ma'am.
Yeah, please start the timer. And Subodh and Anirudh are also there?
Dr. Subodh has not come yet. Dr.
And Anirudh?
Anirudh is here.
Yes, sir.
Okay,
I'm here.
okay. Okay.
Okay.
Start the timer. Yeah.
Yes.
Again, we are not
Sound.
able to hear Saiban. I think you have to make it more clear for us.
Sound is not there.
Saiban,
Please.
Sound
Dr.
is not.
Saiban, can you connect with your earphones? I think.
The volume is maximum.
Ma'am, can you just unshare it, and when you share the video, you click on share computer audio. It's sharing the screen. On the pop-up screen there is an option which you need to
Yes,
select.
share
Share
computer
computer
sound.
sound. Yes.
I did that.
Yeah. Now click on share and start the video.
Implant with intravitreal ranibizumab and the Manitowoc was planned for the patient.
Should I talk while?
Now, in the area of the spared conjunctiva,
Yeah, volume is still not
I think you can
Sir,
present.
should I give a voice
You can
over?
talk yourself.
Please give voiceover. You stop your
Yeah.
Okay.
audio of the video and to start.
So I'll just restart. I'm so sorry.
Do.
Okay. So this video is basically about 3 mistakes that I made in my life, and this has taught me lessons that will stay with me for life. Now, the first case I want to discuss is a case of a 62-year-old female.
I think
who,
please play the video also.
Video is not there. Start the video
Just
also.
showing thank you. Yeah.
this is my audio video. Is it showing now?
No.
No, not yet. It's showing started screen sharing, but it is not showing the video.
Yeah.
But
It is the first one.
this is the first one, small eye, big dilemma.
And otherwise, we can have Dr. Anirudh's video. If there's some problem, she can sort it out.
Yeah.
Yeah, Dr. Anirudh. Is it?
Please start sharing your video, please.
Yes, ma'am. I'll start my screen share.
Yeah.
Yeah.
Okay, is my screen visible?
It is visible. Please go
Yes.
ahead. Start the timer.
Yes,
Good morning,
sir.
everyone. I'll be starting with my video.
Management of hypotony maculopathy post-trabeculectomy with scleral patch graft and conjunctival overlay. This video demonstrates a case of a 53-year-old male who underwent right eye trabeculectomy with cataract surgery 4 years back and who now presents with a complaint of diminution of vision in his right eye over the past 1 month. On examination, he had a best corrected visual acuity of 6/18 in his right eye with an intraocular pressure of 4 millimeters of mercury. Anterior segment evaluation showed a thin cystic bleb with the ASOCT showing the same and presence of intrascleral cystic cavities. And the patient was found to have hypotony maculopathy on posterior segment evaluation. The patient was planned for a bleb revision. A 6/0 vicryl superior corneal traction suture was used to infraduct the globe, increasing the exposure of the surgical site. The conjunctiva over the bleb was stained using trypan blue dye, and the epithelium was scraped off using a lamellar dissector and subsequently using a crescent blade. The thin and necrotic conjunctiva over the bleb is removed using a Vanna scissor. A side port entry is then made using a microvitreoretinal blade and air is injected into the anterior chamber. The surrounding conjunctiva is undermined and a fornix-based conjunctival tenon flap is dissected just behind the leaking bleb. Intraoperatively, the scleral flap was found thinned out due to scleral necrosis. The ostium was found to be patent by observing air leaking out of the anterior chamber. A 10-0 nylon suture was used to try to close the existing scleral flap, but due to tissue necrosis, the suture cheese wired. A decision to proceed with a scleral patch graft was made and the necrotic scleral tissue was removed. The exposed trabeculectomy site was measured using a Castroviejo calipers, and from the donor sclera, a partial thickness scleral allograft is fashioned. The graft was sutured in place using 6/0 vicryl sutures at each of the 4 apices. Additional 10-0 nylon interrupted sutures was used at the limbus to securely fix the donor sclera anteriorly. The conjunctiva was then advanced to close at the limbus using 60 vicryl sutures at the two edges.
Dr. Subodh, please unmute your video.
हाँ।
Mute your video, please.
वो उसको अभी ही भेज दूं, अभी जाएगा इतना जल्दी?
Additional 10-0 nylon circumferential sutures was used to anchor the conjunctival flap at the limbus. Balanced salt solution was then injected into the anterior chamber and the bleb was found to be functional. Post-operatively, the patient had good IOP control with resolution of hypotony maculopathy on second post-op day and with the best corrected visual acuity of 6/9 at 2 months follow-up.
Thank you.
I just want to ask, why did you use 6-0 vicryl to close the conjunctiva?
Ma'am, we use 6-0 vicryl at the two edges and then additional.
So any advantage of using 6-0 vicryl? Like, why not 8-0 vicryl? Because it will cause more irritation and foreign body sensation and some reaction post-operatively.
No, ma'am, no advantage as such. We just use a 6-0 vicryl at the flaps, two flaps of the conjunctiva.
Did you cover the entire width of scleral flap with the scleral patch graft?
Sorry, ma'am?
Did you cover the entire width of the scleral flap with the scleral patch graft, or some width so that filtration can happen later on post-op?
So what we used, like we measured the initial tunnel, the dimension of the initial tunnel with the Castrovisio, and then we just like no undersizing, only that much size we measured and sutured the flap at that.
So
size.
if you completely cover it, then do you expect filtration post-operatively? If you completely cover it with scleral patch graft?
But at the two edges and at the posterior end of the patch graft, we didn't put any sutures. So the two edges of the graft and the posterior end of the graft there were no sutures. Only at the edges we placed the suture. So it just added as a guarded tissue over the.
Thank you.
So you're suturing only the anterior edge and the side edges, lateral edges, not posterior. That's what you want to say?
So the four corners and the anterior edge. We left the two side edges and the posterior edge unsutured. So that acts as a way for the aqueous to flow.
Because there are chances that it may get fibrosed.
Yeah.
So
Because the size was such that it may completely block the prior filtration side. Okay. And how early do you decide to intervene when you find that the patient is having hypotenuse maculopathy?
So, sir, for this case, he presented us 4 years. It was a late onset bleb leak. He presented us 4 years after. And since he had a complaint of diminution of vision, we straightforward went for a bleb revision. But intraoperatively, we found that the existing scleral flap was all necrotic. So we decided on the table to proceed with a patch graft rather than just a normal bleb revision.
Okay, so can we have the next presentation?
Yes.
Yes.
Ma'am, are you able
Through
to
this
see?
video, I would like to share with you 3 cases through my glaucoma practice that have taught me valuable lessons that will stay with me for life. The first case is that of an old lady that I had diagnosed to have pseudophakic neovascular glaucoma, status post central retinal vein occlusion. She was put on maximally tolerated medical therapy, followed by 3 sittings of pan-retinal photocoagulation, 4 days after which I started seeing regression of the NVI. However, since the IOP was still uncontrolled, trabeculectomy with Ologen implant with intravitreal ranibizumab under mannitol cover was planned for the patient. This is the video of the procedure. Now, in the area of the spared conjunctiva, supranasally, trabeculectomy is being done with 0.04% of mitomycin C for 1 minute, followed by a thorough irrigation. Routine trabeculectomy with a triangular flap was made.
Dr. Sahiban, your sound has gone.
At the end of which the scleral flap was closed with a loose apical suture. An Ologen implant was placed under the conjunctiva with careful conjunctival closure and placement of wing sutures. However, to my dismay, the intraocular pressure on postoperative day 9 shot up to 47 millimeters of mercury. On careful examination, I noticed a vascularized bleb and blamed the high intraocular pressure on the ongoing episcleral fibrosis and so planned an early bleb needling. Postoperatively, the IOP did come down, however, not satisfactorily. This time I tried another shot on minimal bleb needling on the slit lamp with a 5 fluorouracil injection on the trabeculectomy site. I see that after the injection, a small air bubble trickles into the anterior chamber. I thought to myself that this ought to be a sign of patent sclerostomy and was happy to know after an hour that the IOP had come down within the target range. Little did I know that the very next day, the patient will come back with a severe anterior chamber reaction, corneal edema and DM folds, and worse still, a reduced visual acuity. So what I was looking at was something I had never seen before. I had caused a 5-FU toxicity due to entry of 5-FU into the anterior chamber during injection. To sum up, I would say I made the following mistakes. Number 1, planned a trabeculectomy only a week after the last sitting of panretinal photocoagulation. Number 2, used Ologen implant along with trabeculectomy in a neovascular glaucoma case. Number 3, probably chose the wrong primary procedure. Number 4, caused an entry of 5-FU into the anterior chamber. The valuable lesson number 1 I learned was to keep at least 2 to 3 weeks gap between the last PRP session and glaucoma filtration surgery to allow for proper regression of NVI and inflammation preoperatively. Lesson number 2 was that the use of Ologen in neovascular glaucoma was a bad choice since it precludes any visualization of the scleral flap and its sutures and makes bleb modulation or bleb needling a blind procedure. Lesson number 3 was never to inject 5-FU directly onto the bleb site. It should be either done lateral to the bleb or better still 180 degrees inferiorly. Then there was a question of the right surgical modality in this case. Well, both the surgical techniques share poor outcomes in neovascular glaucoma and no clear evidence exists towards one or the other. However, experience proves that primary glaucoma drainage device to have more consistent results. The second case I want to discuss is that of a patient with advanced glaucoma with macular split needing a second glaucoma filtration surgery. Preoperative visual acuity of this patient was 6/9 in that eye. So I planned a retrabeculectomy with mitomycin C in the area of the spared conjunctiva. Postoperatively, the patient had a good bleb with good control of intraocular pressure and I was feeling quite proud of myself. But to my horror, the patient's vision had deteriorated to 6/12 and I found myself being blamed for the worsening of the patient's condition instead. However, even on thorough clinical examination and investigation, I failed to put a finger on what was the cause. That got me thinking that although the incidence is as rare as 0 to 7%, wipeout syndrome is for real. Here the mistake I made was inadequate patient counseling and learnt thereon the importance of explaining even the rarest of complications to the patient beforehand and to take a proper high-risk consent when required. However, at the same time, one also needs to deliver hope, not fear, to the patient, which is what they come looking for to us. The third case was interesting for the fact that I got saved quite accidentally. Here was a young lady with a unilateral secondary open-angle glaucoma that I had started on beta blockers a while ago and had come for a follow-up. Just by chance, the patient happened to mention an appointment with the gynecologist and on further probing disclosed that she was 3 months pregnant. Since this pregnant lady was on beta blockers, I panicked and immediately discontinued the medication and followed her up without anti-glaucoma medications. There was no progression noted, thankfully. I learned a valuable lesson to always ask every woman of childbearing age for pregnancy before instituting any treatment. On searching, I realized that the ignorance of this problem is so huge that 1/3 of the doctors confessed that they did not know how to manage the patient's glaucoma medications during pregnancy. So briefly, let's look at the choices of anti-glaucoma medications we have during pregnancy. Brimonidine is safest. Past organogenesis or after the first trimester, beta blockers and topical carbonic anhydrase inhibitors can be used. Prostaglandin analogues, oral carbonic anhydrase inhibitors, and pilocarpine should be avoided. During lactation, prostaglandin analogues and carbonic anhydrase inhibitors are safe. Beta blockers and brimonidine are contraindicated. Thank you for your patient listening. This was Dr. Saiba Sethi, a part of Team Arunoday.
Thank you, Saiba. I think that was nice presentation, very good video quality also. We could hear.
Okay, thankfully.
And I think every glaucoma case teaches us something. And learning from our mistakes, I think, is the greatest thing which we can have. So I think you're absolutely right. And after PRP, as you rightly said, one can either give injection Avastin or wait for 2 to 3 weeks for the neovascularization to regress, because it takes time to regress the neovascularization. So I think our routine practice is to give injection Avastin before taking up the patient for surgery. So that was nice. And I think we have just 15 minutes left. And
ma'am, we have Dr. Subodh. He was the first presenter. I think he's logged in now.
Oh, so I think quickly, I think.
Is he the last speaker?
And
Yes,
I think
ma'am,
we can have
that is the
Dr.
last
Julie,
video we have.
Julie,
Yes,
Dr.
Subodh.
Bhalla, you were there during Dr. Julie's.
Ma'am,
Yeah, I
then
was
we
there.
will take-
I was there. I saw Dr. Julie's presentation.
Yeah, ma'am, we can take Dr. Subodh's, and then if time permits.
Yeah. So Dr. Subodh, please share your screen.
Yeah, yes, ma'am. Yeah, sure. Ma'am. Is it audible, visible?
No.
No, you have to share your screen. There's a green icon at the bottom. You have to share your screen first.
Click on that and then click on your video.
So on the right hand side, you have a green icon above.
Bottom
You
of the
can-
screen. Yeah, now it is, yeah, visible.
Yeah.
Volume is there? Is there a sound over, or would you be speaking?
Yeah. Yeah, there is a sound over.
Okay. Start the timer, please then.
So your sound, we can't hear your sound right now.
So you can keep the volume to the maximum. It's
Just you need to play the video from the beginning and maximize your volume.
Okay, ma'am. Yeah, sure.
Hello.
Maximize the volume of your laptop plus your this player.
Okay. I'll log.
Yeah.
Dr. Subodh, your volume is not coming. If you can just,
You can just speak. Yeah. Run the video
speak
and start speaking, please.
Something we can't hear.
Subodh, we cannot hear anything.
Still.
Yeah, maximum. Yeah, we can't hear you. Just run the video and you can just speak.
Speak on your own. I think instead Yeah, please run the video and start speaking.
Yeah.
Else we can't mark you, right?
Okay. Yes, ma'am.
I think these should have been checked before the dry
Yeah,
run.
that's what.
Is it audible now?
No.
Yeah, yeah. You can speak.
You
Your
are
voice is
but
audible.
your voice is no. There is no sound in the video, so you just play the video from the beginning and just start speaking.
Okay. These are the
Yes.
parts of ECP machine.
You have to start. You can start from the
Start
beginning.
from the beginning. So both start from
So
the
that-
very beginning.
so that we do. Otherwise, it's not. From here, you can start talking. Yeah.
Yeah, we'll speaking and coagulation and adjunct us. So not finance. Endocyclophotocoagulation is a minimally invasive procedure in which an endoscope is used to visualize directly using guided laser delivery system. And here the laser energy is precisely delivered to the ciliary process without any it mainly decreases by reducing aqueous inflow with least complications. Basically, we have two types: transcranial cyclophotocoagulation and ECP. So basically, ciliary epithelium, whereas transcyclophotocoagulation, it destructs ciliary body and it uses less laser energy back to it and
It is stopped. Yeah.
And yeah, there are less complications in ECP, whereas transcyclophotocoagulation has more complications. So there are parts of this ECP machine. There is a video display, a control unit, and an endoscope, which has a video camera, laser system, and an imaging system. So this ciliary body. So we have two case scenarios. One is a patient with a presenting with a HiOP 48.
Dr. Subodh, are you there or?
Subodh?
I'm there.
Yeah. Please continue talking, no?
Yeah. We used to photocoagulate ciliary. Usually a field of process when it should done.
I think that's fine. Can we have Dr. Julie's video now? Because there's 12 minutes and we can ask question to Dr. Saurabh in the end.
Yeah.
Dr. Julie, can you just play?
Yes,
Dr.
ma'am.
Julie?
Yes.
Please play quickly.
Yeah.
This video demonstrates ways to enhance success of trabeculectomy in secondary glaucoma. Secondary glaucomas are difficult to manage as a high intraocular pressure perpetuates a vicious cycle of increased inflammation, increased ischemia, and the medications don't work. This vicious cycle can be broken by normalizing the intraocular pressure that would cause a reduction in the ocular stress, decrease in the inflammation, and the medications also start to act. In the early stages of neovascular glaucoma, a timely PRP or injection of anti-VEGF would cause the vessels to regress and IOP usually gets controlled. However, in the late stages of neovascular glaucoma, the medications are usually not effective. Also, the high intraocular pressure and decreased connectivity makes PRP difficult. So in this scenario, you may go ahead and choose to do a trabeculectomy if you have a mobile conjunctiva. Preoperatively, it is important to give anti-VEGF injections 1 to 2 weeks before the surgery to cause a regression of the NPI, to control diabetes and hypertension, and to continue with the anti-inflammatory cycloplegic and the anti-glaucoma medications. After the watertight connective approach with anti-zero hydrate the paracentesis site, and 1.25 milligram of Avastin is put into the anterior chamber as a last step, and also 1.25 milligram is injected just away from the bed. All the maneuvers should be done from the first cornea with a touching the In extensive peripheral synechiae, the iris may be stuck to the cornea and needs to be gently pulled out and then cut it. The paracentesis site should be sutured with N0 nylon. This patient was a one-eyed patient with mass locomotor's damage and uncontrolled intraocular pressure with vision of 6.9. She had already undergone a trabeculectomy elsewhere that was not functioning. After dissection of the scleral flap, we noted that the ciliary region was extremely thin. The scleral spur was marked out and sclerostomy was done anterior to it. Rest of the surgery was done in the usual way. After the surgery, her pressures were well controlled in maintains, and her vision was maintained at 6.9. Most of the glaucomas following VR surgery are controlled with anti-glaucoma medications. In patients in whom the superior conjunctiva is spared and is mobile, a trabeculectomy can be planned as usual in these patients. However, in certain circumstances where the eye is filled with siliconol and cannot be removed because of rectal arteries, you may have to do a TACBC, which can be a graded 1. And also in circumstances where there is extensive conjunctival scarring, as in eyes which had undergone an artery surgery with an upper implant. In these patients, a tube implant procedure can be planned with an AMET glaucoma valve. Scarred area can be gently dissected away and the plate of the AGV can be placed over the buffet. Last but not the least, visual rehabilitation of these patients are very important at the end of the day. With the help of spectacle magnifiers, the near vision of these patients can be markedly enhanced.
ये थोड़ा सा ये ओवर है मैम
वेरी गुड
ये नहीं पसंद में आ रहा हमको
इसके ऊपर
ऑफ कमेंट्स
हाँ फिर
इज
हाँ
selected है ना
ठीक है patient and the patient's family were related when the patient was able to dial numbers and was able to
I think we have seen this part. Rita, if we can stop it because time is almost up now.
Yeah, I think Julie, it's okay.
Yeah, you can stop screen sharing now.
Yes, I've stopped that.
Right.
Did I stop screen sharing?
Yeah.
Yeah.
Thank you, Julie.
Dr. Julie, I have one question. You have told use of anti-VEGFs in trabeculectomy. So when do you use it?
If the in case of neovascularization, where it is evident, then you use Avastin at the end of the surgery. So whenever it's at the end of it, when I'm about to close it, then I put 1.25 milligram per 0.5 ml in the anterior chamber, and also you can give it close to the bleb. I mean, just a little away from the bleb area, and it actually works very well. I mean, the bleb survival actually increases with the Avastin.
Okay, so intracameral we do understand, but giving near the bleb, does it work?
Yeah,
half of the literature says that it doesn't work.
Yeah, so just to take it as an additional precaution, so that so that in any way if we can improve the bleb survival, so that is the reason. But actually,
so you put the same dose.
Yes, put it in aqueous humor or chamber.
Tell them that you exceed our time, and you tell us because for our marking they need to know how much.
So I think putting
the time is almost over.
Yeah.
So can we ask
wrap up
participants to log out? I have not received the sheet as yet.
Ma'am, if you can send me your email ID, I'll just make.
I have sent on the group, hall and group.
Yes, ma'am. I'm just sending it forward.
Dr. Bhalla, please mail your mail ID in the group, and they will send you the score sheet, and then all of us can mail them.
Okay.
Okay.
What time should we mail them?
Ma'am, right now you can mail me. I'll just forward you the sheet, the separate sheet.
Sure. Okay.
Or can I do after some time? I have to go to other session to judge. Can I do?
Yes, sir. I can. Yeah.
By evening, I think evening they have to compile. No, by evening they have to compile, so we can send it.
Before we'll do that. Right.
Is it okay by evening 4 o'clock?
Yes, ma'am.
Yeah.
Okay.
Thank you very much.
Thank you, everyone.
Yeah.
Okay, ma'am.
Nice presentations. Thank you.
Okay.
Okay.
Hello.
Yes.
Hello.
So are we gonna start this session?
Yeah, we'll just start it.
Sure.
Yeah, hi.
Good morning, ma'am.
Thanks.
Good afternoon.
So, are we starting the session now?
Yes, ma'am, we can just start it. I think the participants are just logging in. Dr. Vikram Vinayak is there.
Yes.
And Dr. Nitin Kumar is there. Is there any other participant who is there? Ma'am, I hope you got the score sheet for the session.
No, I haven't.
Ma'am, if you can just send me your mail ID in chat, I can forward you the score sheet.
Okay. I sent to everyone. I mean,
ma'am, you can
You
just
are?
personally, Priyadarshini.
Okay, Priyadarshini, right. I'm just sending.
Okay, ma'am.
Wait.
Good morning. Okay.
Here, I've sent you. So, you're going to mail me the score sheet?
Yes, ma'am.
So, do I need to keep a paper and all also?
Ma'am, it's in Excel format. You can just enter the scores and click a screenshot or something and send it to us. Forward it.
How do I send you? Through WhatsApp?
Ma'am, you can mail it to the DOS secretary. I will send you the mail ID of her along with it. Or you can mail it to me. I can forward it.
No, फिर से बताओ मुझे. I mean, the Excel sheet you're sending me, you're mailing me. I make the score there and then itself. Then
Yes, ma'am. That scores can be added in there, and you can
Okay.
send a screenshot of it to me or to the DOS secretary, Dr.
इतना
Namrata.
complicated मत बनाओ यार. Can I write it in a paper? Just take a picture and
Yes,
WhatsApp
ma'am. You
you.
can send it. Yeah, you
Then
can
send me
WhatsApp
your
it.
phone number also, no? Or send me
Yes,
a
ma'am.
hello message on WhatsApp. Huh? You have my number, no? Hi, ma'am. Hi, Dr. Sarita. Hi. Unmute. So, Priyadarshini, are you just
Yes, ma'am.
send
I'm
me on
just sending
WhatsApp?
you my number.
Okay. Okay, fine. 1 minute.
You can just click a picture of it and send it to me. I'll forward it. I'll forward the scores. Sarita, ma'am, should I send
Dr.
you also my
Sarita,
number?
ma'am, you must have got a notification on your screen to unmute yourself.
I have unmuted myself. Can I be heard now?
Yes.
Yes, ma'am.
All right. Priyadarshini, a question to you regarding the e-poster results on Retina. Should I also WhatsApp to you?
Yes, ma'am. You can WhatsApp that as well to me. I'll forward it.
All right. So kindly send me your like WhatsApp message to me.
Yes, ma'am.
Right. All right. So,
Ma'am, I've just sent you my number. You can check in the chat.
chat should I check? Okay. 965086.
Yes, ma'am.
So I will send you both the results, right? And then you will compile, or should we all three of us compile and then send it?
Ma'am, I can compile it and forward it. It's not a problem.
All right. So we will send our individual marks.
Ma'am, can we start with the participants who are available?
Yeah.
So Dr. Amarjeet Kadam has not yet logged in, I believe. Dr. Pushkar Dheer, are you there? Dr. Vikram Vinayak?
Yes, I'm here. I'm audible, right?
Yes, sir.
So I'll share my screen.
Yes, sir. You can go ahead and share your screen. He'll
Hi,
be
good
presenting
afternoon to all
on
the
Pellet
judges.
Wars, A
Yes,
Tale of Two Brothers.
yes. So good afternoon to all the judges and all the co-contestants. Hi. So I will be starting my video. I'm sharing the clinical history of two brothers from Kashmir who presented to our clinic with history of pellet injury. The elder brother was a 25-year-old male. He had undergone primary tear repair in Kashmir and was referred for further management. On examination, right eye showed a sutured limbal tear at 5 o'clock. On this examination showed vitreous hemorrhage with intraocular foreign body in supratemporal quadrant. A pars plana lensectomy was performed. Core vitrectomy was done and IOFP was visualized. Careful vitrectomy was performed around the IOFP to free it from the vitreous. Posterior vitreous detachment was induced. PVD induction was performed very carefully all around the impact site as there was a risk of iatrogenic retinal tear. Laser was performed around the impact sites. The IOFP was still attached to vitreous by a small tentacle. The adhesion was cut with cutter. Suddenly, as the adhesion was cut, the IOFP bounced from periphery to the posterior pole. LPFC was injected to protect the macula. IOFP was grasped with the forceps and was removed successfully to a corneal bomb. Fluid air exchange was performed and silicone oil was injected. At 1 month post-op, visual acuity improved to 6/9 with well-attached retina and a retinochoroidal scar. The younger brother also presented 5 days after the injury and he had also undergone primary tear repair in Kashmir. He was a one-eyed boy as he had already lost his right eye to a similar pellet injury 2 years back. On examination, his right eye was pre-thusical and had no perception of light. Left eye had brisk PL, but his PR was inaccurate. A sutured limbal tear was seen with early traumatic cataract. There was no view of fundus due to dense vitreous hemorrhage. Ultrasound of the left eye showed total retinal detachment with plenty of subretinal echoes. A posterior globe dehiscence was suspected, although no definite IOFP was noted. A CT orbit showed an intra-orbital foreign body with discontinuity of the sclera, suggestive of a posterior globe perforation in left eye. The major concerns prior to the surgery were whether to intervene or not in such a case. If yes, then what should be the ideal time to intervene? How to tackle the posterior globe perforation? And what if the globe collapses during the surgery? After discussing with seniors and colleagues, I took up the patient for surgery after 9 days had elapsed since injury. A scleral patch was harvested in addition to a sponge piece and also kept a silicone oil ready to rescue just in case the globe collapses. A pars plana lensectomy was performed. Vitrectomy was performed. Posterior vitreous detachment was induced. Vitrectomy was completed. The perforation site was sealed by a large blood clot with plenty of subretinal heme all around. The clot was manipulated and trimmed very carefully so as to clear the fovea as much as possible. The clot required a careful handling as there was an imminent risk of a globe collapse. During this maneuver, the media got hazy due to dispersed heme and FAX was performed to clear the media. Near the end of fluid air exchange, luckily the subretinal heme started to drain from the perforation site. It was a welcoming sight, although the process was slow and took a long time. I decided to stop once the fovea was cleared of subretinal heme. Inferior subretinal heme was left as it is. Laser was done around the perforation site and 360 degrees to peripheral retina. Silicone oil was injected. On postoperative day 1, patient had a vision of 3/60 in his left eye with attached retina and subretinal heme inferiorly. At 1 month, his BCVA had improved to 6/60 and the subretinal heme had resolved with a macular scar. This case taught me an important lesson that no matter how hopeless a situation might seem, we must never give up. I am reminded of this every time this boy comes up for a follow-up, walking in himself with a cheerful smile. Thank you.
Thank you, Dr. Vikra Vinayak.
Thank you.
Judges?
From Dr.
Yes.
Acha. So you had harvested a scleral.
Yes. But
So did you use it? There it was not required.
Yes, it was not required because the clot itself had completely, I did not remove the clot. So it was, the perforation site was quite well sealed with the clot itself. So that is why I did not try to remove the clot. So otherwise there would have been hypertony and it would have been very difficult to manage. So I left the clot as it is, as it was sealing the perforation site. So I thought that
Because your CT scan had showed a large amount of perforation.
yes.
So you think it's sealed by the clot itself because later on.
Or ma'am, the healing process, because the CT scan was performed just 5 days or 3 days after the trauma, and we post-operated. I read a lot of and I discussed the case. So there were reports that you should wait for 7 to 10 days minimum. Minimum 7 days one should wait if there is a posterior globe perforation, so that there is some sealing and you can proceed with the surgery. So we waited for 9 days. On 10th day, I took up the case, and luckily there was no globe.
So did you repeat the CT scan after the surgery after some months?
No, I have not received. No.
And the IOP is well maintained, as you said, and the vision is also.
Silicone oil failed. I have not removed. I mean, I did remove the oil, but the surgery is almost 2 years now, and the boy is doing good.
So, what was your plan? With the scleral flap, what would have you done? Like, what was your plan?
So the thinking was, if at all, if there is a leak, and I will try to plug it with that. I don't think it would have worked, but I saw a few cases where sponge was also have been just plugged in there. So I thought I will put this and the sponge and try to, maybe it will seal it. Just a hope. Yeah.
Yeah, that was, very nice. One more thing, I had one question in mind. Do you expect some kind of choroidal effusion in such cases?
Because of
Because of so much of trauma and
right.
And plus you waited also, like you said, you waited for 10 days.
We waited for 9 days.
9 days, okay.
There was no, 10 days. So luckily there was no effusion, but yes, there can be. Maybe the heme, because of the heme, the choroid could not, there can be, but luckily there was no, we repeated the ultrasound. So there was no.
Okay, so you did ultrasound also. Okay. Yeah, so that is also important. You need to do ultrasound also in such cases.
Preoperative also. So we did ultrasound like 5 days prior to CT scan. And then on that day also, there was no choroidal effusion. Even on the day of the surgery, I always like to do little ultrasound just to know if my trocars can go subchoroidal or anything. So
on the chat box, there's one question from Dr. Ashish Mitra. I'll ask that question. He says it's a nice presentation. And why was silicone oil injected? Was there any detachment? That is his question. Why did you put silicone oil in the first case?
So there was in the first case.
Yes,
so
in the first case is asking.
Yes, because there was breaks, there were retinochoroidal tears, there was no detachment, and the boy, they are from Kashmir. One of his another cousin had been operated, and they live at very high altitude, so they did not wanted gas or oil. My plan was C3F8, but they did not want it. That they were like, no, we don't want C3F8 because the pressure gets high. We live in very high altitude, so they were very insistent on that. So ideally, I could have left it without oil also, just fluid fill. But since there were those tears, there was tears.
So I agree. So you gave them positioning also for a week, 10 days?
Yes, yes.
All right. So I
So
think
with oil also you would need positioning.
For some days I did give him.
Okay, yeah, fine.
Because there is a risk that there is a tear until the time the
After
scar.
there's a tear.
And there was a full thickness retinochoroidal defect. I did not. But
You didn't want to take a chance.
Yeah, in the first case, I could see the sclera. So I could touch the sclera there. There was no choroid in that maybe one disc diameter area below the disc. There was no choroid. So there was no retina also, of course, there. So I did not want to take a chance.
all right. So
But
nice.
in the hindsight, I do feel that it could have been left. But that was a surgical choice I make. You make decisions at that and time. So I thought that was best for the patient at that time.
All right. So that was a good presentation. So should we go to the next presentation? If there are no more questions. All right. So the next presentation is Dr. Amarjeet Kadam is there? Dr. Amarjeet Kadam. Dr. Pushkar Dheer is also not there?
No, Dr. Amarjeet and Dr. Amarjeet and Dr. Pushkar will not be joining.
All right. So Dr. Shamay?
Dr. Shamik?
He's not answering his phone.
Dr. Nitin Kumar then?
Yes.
All right. So we'll have a presentation from Dr. Nitin Kumar.
Can I share my screen?
Sure.
Dr. Vikram, please mute your audio.
Primary vitreoretinal lymphoma is one of the greatest masquerade syndromes. It can present as vitritis, subretinal mass lesion, and other presentations.
So we are not, sorry to interrupt, we are not getting your slides. Dr. Nitin?
1 minute, ma'am. I am just.
So just stop and first share your slides before you start, please.
You need to start your video. Your video is not started.
Minimize the screen. I can see your folder, so better minimize it.
1 minute, ma'am. Can you see now, ma'am?
No, we're just seeing your folder.
Minimize your folder, Nitin.
Primary vitreoretinal lymphoma is one of the.
Just wait. No, it's still not visible.
Is it visible now, ma'am?
Yes. No, but we can just see your name. The video we cannot see.
Share your
I
screen.
think your screen sharing has stopped, I guess.
1 minute.
Then you also need to have the video already opened.
Yes, it should be already open on your desktop and then you share.
And you share that screen.
Yes, you just share and it'll automatically go to whatever is opened on the desktop.
Yes, ma'am. I'm just working on it, ma'am.
Yes, now we can
Yeah,
see.
now, yes, yeah.
Now you can
go
proceed.
ahead.
Yes, ma'am. It's having
Primary
voiceover.
vitreoretinal lymphoma is one of the greatest masquerade syndromes. It can present as vitritis, subretinal mass lesion, and other presentations which can mimic uveitis. It appears in waxing and waning phase, thus difficult to diagnose. Classical appearance of leopard skin is seen where multiple hyper and hyperpigmented lesions are seen, which are better appreciated on autofluorescence imaging. As confused with uveitis, ophthalmologists initiate corticosteroids, which are lympholytic and further delay diagnosis. Even steroid leads to disappearance of B cells prior to vitreous biopsy. Biopsy is the gold standard for diagnosis, but vitreous biopsy often comes out to be negative, while retinal biopsy is cumbersome and has its own complication rate. PVRL cells are located mostly anterior to Brooks membrane, as shown in this OCT image, invading vitreous, retina, subretinal space, and space between RPE and Brooks membrane. Thus, access to subretinal space logically appears to improve the cytological diagnosis. A 66-year-old male was undertaken for diagnostic vitrectomy. After making sclerotomy ports, vitreous biopsy was taken under air at 600 cut rate per minute, followed by diluted vitreous sample, which was taken by infusion on, following which core vitrectomy was completed after posterior vitreous detachment. Site of minimally invasive subretinal biopsy was chosen away from the macula. Retinotomy was made at the edge of the lesion and 25 gauge soft tip was inserted in subretinal space and moved in all directions to increase the yield. Fluid air exchange is done and endolaser is applied to the retinotomy site. Ports are sutured. The 6-year-old female is undertaken for diagnostic vitrectomy. The vitreous biopsy is taken as per steps previously highlighted. A retinotomy is made at temporal edge of large subretinal lesion using 25 gauge soft tip. Minimal invasive subretinal biopsy is taken. The tumor cells are displaced using this 25 gauge soft tip towards the retinotomy site. These repeated movements help in debulking of the tumor cells and their aspiration into the soft tip. Fluid air exchange followed by laser around the retinotomy is done. Case 3 highlights the use of intraoperative OCT in minimally invasive subretinal biopsy. IOCT shows CME and location of lymphoma cells between RPE and Brooks. As this lesion is at posterior pole, we choose another lesion for MISB located superiorly. IOCT shows the lymphoma cells going into the lumen of soft tip cannula. In pre and post biopsy OCT picture, we can see flattening as well as decrease in the width of the lesion. Endolaser is done. Biopsy from vitreous mirror showed scanty lymphocytes, while subretinal aspirate shows plenty of lymphocytic cells. We had 7 cases of subretinal biopsy, of which 2 were diagnosed on vitreous, while all 7 cases showed lymphocytes in minimally invasive subretinal biopsy. All 7 cases were CD20 positive, while 2 cases had CNS involvement. Subretinal biopsy helped in early diagnosis and reduced delay in the initiation of treatment.
It is a good study, Dr. Nitin. What was your pressure while you were aspirating from the subretina?
When pressure was kept at the normal 30 millimeter of mercury, the normal range. There was no, because we had turned on the samples initially were taken on the air infusion. So there is no risk of hypotony. Initially, before the diluted samples are taken, the undiluted samples are always taken under the air infusion.
All right. And you used a separate syringe while you were aspirating, or how did you collect the sample?
When basically the assistant has to hold on the sample, the part of the cutter which is in the aspiration mode, we attach a 2 cc syringe. Multiple syringes are used, and the assistant applies the suction for the collection of these samples.
So it means it is a controlled pressure, no? The pressure is given by the syringe itself, even if you keep it at 30 mm.
Yes, ma'am. Yes, ma'am.
All right. So it's a good study, and I think early diagnosis always helps, and all your patients did well.
Yes, ma'am. All the patients did well. There was no complications, no retinal detachment or vitreous hemorrhage in any of the patients. And also, as we have highlighted, this subretinal biopsy helped in the good yield of the cells, because we are just dislocating these cells. As we have seen previously, also studies shows that there is only 30% yield from the vitreous biopsies. So in all the patients in which the subretinal biopsy was taken, they showed good yield of cells from the subretinal space.
All right. Thank you. Any more questions, please?
Any other investigation you had taken, like any
Yes.
systemic investigations?
Ma'am, systemic investigations we are doing for these patients, MRI of brain and spinal cord for all these patients. But in patients who are just presenting with the symptoms in the eye, they are having just lesions in the eye, the vitreous biopsy is the clincher. And also we generally do IL-6, IL-10 ratios for these patients also, in which the IL-10 ratios, as seen in many studies, will be high in cases of the patients having malignancies rather than any other infections, as these are always a masquerade syndrome masquerading the other forms of uveitis.
So you found low IL-6, IL-10 ratios in
IL
these patients?
Yes, ma'am. IL-6 was less, IL-10 is higher.
Okay. You need to stop sharing your screen.
Sure.
Hmm.
So we can go into the next candidate.
Dr. Rohit Lambati.
Who's next?
Yes, ma'am. Yes, ma'am, I'm available.
He would
Shall
be
I speak?
presenting on a novel approach for non-magnetic intraocular retained intraocular foreign body.
Okay. All right.
Shall I start, ma'am?
Yes, yes.
Good afternoon, respected faculty. I am Dr. Lohit from RP Center AIMS. I am presenting the case regarding the retained, how to remove the retained intraocular foreign body. It is a case of 24-year-old male suffered an open globe injury in his right eye during alleged fight 14 days before our presentation. And primary closure was done immediately at the local hospital. An intraocular foreign body was directed on ultrasonography in the posterior segment. He was referred to higher center for further management. The patient presented to casualty with visual acuity, right eye finger contact close to face with intraocular pressure 9 millimeters of mercury. On examination, anterior segment, there is a total cataract. Posterior segment, there is a vitreous hemorrhage with intraocular foreign body and ultrasonography B scan. We have done the lens restoration with posterior chamber IOL in the sulcus with passplan vitrectomy with foreign body removal and silicone oil injection. Postoperative visual acuity in the after 1 week was right eye 6/18 with intraocular pressure 15 millimeters of mercury. Now I am showing the video. Sorry for the interruption. Now I'm showing this is the ports. After cleaning dripping the eye, I'm making the ports. Three ports are made, and infusion is started. After making the MVR entry, 2 MVR entries are made. After injecting dye, I have started the capsular rhexis. We can see that the needle capsulotomy, but it was very difficult to make the rhexis. Even I'm trying for. I was trying for 2-3 minutes. It was difficult, and I started doing the capsulotomy. From all the quadrants. Then I found a membrane over the capsule. I was trying to remove that membrane. You can see the white membrane over the capsule. After that, I had removed the anticapsule and the membrane with the help of inverted limb forceps. You can see the membrane removing, and after that, I have started the lens aspiration with irrigation probe. The corneal perforation was repaired immediately in the local hospital, but I have augmented the sutures. You can see over the cornea, and the lens was very soft. I was trying to remove from all quadrants. After that, I have done the postcapsular rhexis also with the rupture with the help of the cutter. I kept the infusion low, about 15 millimeters of mercury. After getting the PCC, and I have removed the remaining cortical matter from the left out capsule, and I have started the vitrectomy. Due to the corneal edema, it was very haze. I started vitrectomy, anti-vitrectomy. After that, I was going to the core. You can see appreciate the vitreous, and I was inferior vitrectomy. I was doing on the inferior quadrant. PVD, posterior vitreous detachment, is already present. Still, I was doing the vitrectomy, removing the adhesions of the organized vitreous blood clot over the disc along the inferior temporal area. We can see the foreign body appreciate inferiorly to the disc, and I was trying to releasing the foreign body from the vitreous adhesions. It was a inferior quadrant. I was doing vitrectomy and also shaving the vitreous periphery, but there is still vitreous hemorrhage still attaching to the posterior pole of the retina. I was trying to remove the traction also. After that, removing the traction, I was relieving the foreign body from the traction remaining adhesions. You can appreciate the foreign body here. I was continuing the peripheral vitrectomy. Along the nasal quadrant, I was doing the vitrectomy along the nasal quadrant. trying to relieve the traction around the foreign body. We can appreciate the foreign body there. Inferiorly. Now the foreign body moved from the inferior quadrant towards the posterior pole, touching the posterior layer of the posterior pole. I was completing the remaining vitrectomy. Along the inferior peripheral vitreous. Airport areas cleared. Some of the cataract fell down accidentally. So I was trying to remove the cortical matter. It is a superior vitreous. I was removing the superior vitreous peripherally. After removing the cortical matter, I was clearing the peripheral vitreous along the superior quadrant. After clearing the cataract matter and the vitreous, I have put PF cell for the temporal tamponade. I have made a 2.2 entry, which is extended to remove the foreign body. With the help of iLM forceps, I have tried to remove the foreign body, but it was large enough. Then I introduced the extrusion. With the help of wire vectors, I removed the foreign body through superior root. After putting the IOL, suturing the cornea, I'm trying to suturing the wound. Three sutures, three T10 MFN. I have made it in the superiorly. We need a tight closure for the adequate antechamber so that we can start the fluid air exchange in the next step. I have done the inferior laser so that at the area of the impact of the foreign body, and on the superior quadrant also, because of the suspicious lesions I have seen intraoperatively. We can see the laser augmentation along the superior temporal quadrant and superior nasal quadrant. After fluid exchange, I have injected the silicone oil by checking the IOP. I left in the silicone oil with adequate intraocular pressure. Thank you.
Thank you, Dr. Lohit. I thought you also said that you put a PC IOL.
Yes, ma'am.
You didn't show in your video.
Yes, ma'am. Due to the time limit, I haven't shown the IOL. But
And
actually,
that was your complete management. And
Yes.
also, did you do a CT scan and an ultrasound before you started with your case?
Yes, ma'am. It was already done outside in the local hospital ultrasonography. It was made. They have detected the foreign body in the ultrasound, and I have repeated here and done the ultrasonography.
And the CT scan?
CT scan I didn't do because of I'm sure about the foreign body in the ultrasonography, so I didn't advise the foreign body. Actually, the patient had a fight. He had LH trauma, and he medical legal case was put. So I was not able to do other investigations.
No. But to see what foreign body did from your history or something, you had an idea what type of a foreign body was it?
I thought of due to the mode of injury, I thought of only magnetic foreign body, but intraocularly it was non-magnetic because I tried many extraocular magnet, intraocular magnet also for the removal of the foreign body, but it's unfortunate to remove the foreign body, so I removed with extrusion and wire vectors through the.
No, that is fine. But
Yes,
what was the foreign body material? You have still not told us. What was it?
It is a rubber pellet, ma'am.
It was a rubber pellet.
Rubber pellet.
Acha. Okay, so it was a rubber pellet which pierced the cornea. It
Cornea.
must have gone with. So it was with a air gun or something.
Something like a patient was not able to give the proper history, but properly it is a air gun only, because it is a corneal perf is also there, and it was repaired.
This you
in
could,
the,
you can always go back and ask. The air gun is a big air gun, so it can be
uh,
easily taken a history for that.
Actually, unfortunately, patient was in prison due to some medical legal case. So I can't do the SOR now till now. So I was still I cannot do the silicone removal also.
So you remove the foreign body with the help of a, not with the forceps, but you did it with the
Extrusion on the from the posterior segment to the anterior segment. After the anterior segment, I removed it through the wire attachment.
So how much pressure did you use for the extrusion?
Extrusion, I used only 14 mm because the wound is widely open, so that
So
if it
with
is more
14
pressure,
mm, you were able to bring the pellet from posterior
yes,
segment
ma'am.
to anterior segment. 14
Yes,
mm.
ma'am. 40 mm, I have
40.
kept the 14.
No,
I
no,
kept
14
the pressure,
is
but I mean the extrusion. 14, I kept the infusion, ma'am. But with the
Okay.
extrusion vacuum, I kept 450.
Because it won't come.
Yes, ma'am.
otherwise.
Yes, ma'am.
Okay.
Is that
All right.
Is that? Thank you.
You could have improved the quality of your video. It
Yes,
was
ma'am.
not very clear. So
Yes, ma'am. It's
you're
a
doing
good
so.
Yeah,
point.
even that's what I
Next
was
time,
wondering. RP Center, I'm sure you would be having some better.
a little better
videos.
video could have helped you.
But unfortunately, I had corneal edema, and it was a difficult case.
All right.
Okay.
Thank you.
Thank you, ma'am.
Dr. Sandhya, you'd
Thank you.
like to ask something?
No, thank you.
So we can go on to the next candidate if there is Dr. Ashish is around.
Thank you, ma'am.
Yes. Can you hear me, ma'am? Am I audible?
Yes,
Yes,
so
you
you're
are
audible.
Dr. Ashish, are you there?
So,
Yeah. Can I share my screen now?
Sure, please.
Is it okay now, ma'am?
yes, we can see your screen.
Okay. So should I start?
Yes, please.
So, good afternoon, judges, and I'm presenting on giant retinal tear, the stiff retina, since it's a video presentation. So, I already had a voiceover in it. So, I'll be presenting giant retinal tear, the stiff retina.
Go on. Yeah.
Hello, friends. Today I'm presenting a giant retinal tear with extensive PVR changes, and there was minimal choroidal detachment. This was a giant retinal tear extending for almost more than 4 clock hours, and you could see that retina is all crumpled up and thrown into folds. You could see that the retina is quite stiff, and this is not a retina which would just open up easily. See, I am inspecting that retina with the help of the cutter. This retina, it appears to be quite stiff, and now one has to see whether it's the pre-retinal membranes that are there which are causing the contraction of retina, this stiffening of retina. So after doing a bit of core vitrectomy and some peripheral vitrectomy without indentation, I tried to inspect this retina again. I injected PFCL to check whether it is getting flattened with PFCL or there is still some amount of stiffening present. So see, I am injecting PFCL. The superior retina is getting flat, but the inferior retina is still stiff and thrown into folds. Now, the question in my mind was whether it's the pre-retinal membrane. Now what? How I have to proceed further? Then there was something that came in my mind. I thought that there could be some subretinal fibrosis also, which could cause contraction of retina. So I went behind the retina to inspect and see I was right here, and I could see some subretinal fibrosis, some subretinal membranes which were there. So with the help of serrated intravitreal forceps, I removed these membranes, and you could see I will be removing them now. And this is one part of the membrane which I am removing. So this is the membrane which one has to inspect in such cases. In such cases of giant tear, there might be some subretinal membranes which are causing contraction of retina. and see this was a part of membrane which I removed. Now I'll be going back again. I would be lifting that retina gently so as not to create any break. And now this is the membrane. Again, you could see this was a bigger membrane than the one I removed earlier. And this was the main culprit behind that stiffening, behind that contraction of retina. And one has to go behind and inspect gently without causing any damage to the retina. Are there any subretinal membranes which one has to remove to cause flattening of retina? And see, this was a bigger chunk. And once this membrane was removed, this was eaten with cutter. And once this membrane was removed, I injected PFCL further, and this retina was now not stiff. You can see that now the retina appears mobile, and it doesn't appear that, that crumpling is not there. So further injection of PFCL caused flattening of retina. Now my intention was to search for any pre-retinal membranes, if there are any, to remove them as well. So with further injection of PFCL, now the retina got flattened easily, and now what I have to search was for any pre-retinal membranes, because they could be a source of PVR later on, and maybe a source of redetachment, because these cases they carry a high risk of redetachment. One can see now the retina is flattened under PFCL. Now, see here, I am removing those pre-retinal membranes which were there, and at times in detached retina, it is easy to peel such membranes under PFCL. So after removing this membrane and inspecting the retina for any other membranes, it is very crucial. One has to remove all such membranes which are present to prevent any post-operative PVR changes. ILM was also peeled under PFCL. Now, a meticulous base dissection was done, especially around the edges of GRT, which is very important because these are the sites from where the PVR occurs post-operatively most commonly. So one has to do a meticulous base dissection covering every clock hour. The 240 band was tied . And finally, PFCL oil exchange was done. Thank you for watching this video. You can subscribe
So the fight may be tough at times, but it is worth rewarding. And in such patients, we have to actually look for any subretinal membranes, because these are the membranes which make prevent retina from settling. And more importantly, you have to look for any pre-retinal membranes, and at times, if possible, peel the ILM also. Thank you.
All right. Any questions? There is one question on the chat box. I think it asks by Dr. Nitin. It is asked by Dr. Nitin that what is the role of band placement in giant retinal tear?
I was expecting this question actually, because we generally don't put a band in giant retinal tear. Although if we put a band, we give a shallow indentation. I agree with him, but in routine, in bad detachment, in bad cases, sometimes we do put a band, but the idea is to give only a shallow indentation, and one can avoid this step also. I agree.
So you put the band before the PPV or after the PPV, because you didn't show that before the PPV.
No. The normal process that we follow is we put the band before PPV.
But in this case, I didn't see, like your video didn't show that band in the first part.
I think that was not an important step to show. Probably I wanted to highlight more things like the subretinal bands, the peeling of membrane.
All right.
And
but you could have just spoken. All right.
You could
fine.
have, yes. And you tied the band in the end, right? You tied the band. You must have put it at the first step.
Actually, in Chitrakoot, we always used to follow the same protocol. Band was almost tied at the end. Although some surgeons do prefer to tie band before endo laser, but like we've been trained in such a way, like we always tied the band at the end. In some cases, I don't remember, in just 5% of the cases, maybe I tied before the endo laser.
Can you please tell us the follow-up of this patient also? Like you didn't mention anything about the follow-up.
This patient actually was refused surgery from 2-3 centers. And this patient we took up, and he was till 6 months he was with us, and the vision was 618. Actually, it was quite rewarding. This was an old video, and I haven't shared it in any platform. This is the first time I'm sharing this video. And this patient was refused surgery, as I said, in 2-3 centers, and we had this patient till 6 months. The vision was 618.
Okay. Thank you, Dr. Ashish. Any more questions?
Like you rightly said, that you have to look for small membranes also. So even it's a good idea to, to stain it with probably triamcinolone also,
Right.
just so that you don't miss any subtle small proliferations or membranes.
But generally, in such bad cases, I always peel ILM also. So when you are after peeling the membranes, when you're removing the ILM, the point is you do remove those pre-retinal membranes as well. And at times when I don't get an edge, suppose there is a pre-retinal membrane and don't find an edge. So most of the times I do put this BVG to stain the ILM, because then it becomes easy from that end to peel the ILM, and you just lift that pre-retinal membrane. And the whole process actually becomes easier. So what I, in my short experience, have seen that even after peeling membranes, you just peel the ILM. So whatever membranes have been left, so they can be dealt along with ILM as well.
All right. Thank
Okay.
you. Are there any more
Thank you.
questions from anywhere? The chat box, I'll just check the chat box also.
Meanwhile, you can stop sharing your screen also.
All right. So I think that is the end of our session 2. Thank you all. Thank you, Dr. Sandhya. Thank you all.
We had only
presenters.
4 videos in this session, right?
Yes, ma'am.
Yes,
Only
4
4 videos. 3 of them were absent. So.
So we can leave, and as decided earlier, we will WhatsApp the.
Okay, ma'am.
Thank you all.
ma'am.
Thank you all. Thank you.
I thank all the participants. Thank you.
Thank you.
Thank you, ma'am. Thank you all.
Good afternoon. It's 1:30 and we'll start this session. So, yeah, I request all the participants to mute their mics. So, good afternoon and welcome to this cornea and ocular surface video presentation session. On behalf of the Delhi Ophthalmological Society, I welcome you all. The judges for this session will be Dr. Hemant, Dr. Pooja, and Dr. Devang. Our judges have not joined us yet, but to the participants, this session is being recorded and the judges will have access to the recorded session and they will mark you accordingly. So don't worry. You have 8 minutes to present your video. Please try not to exceed the time limit. And at the end of the presentation, there'll be 2 minutes of discussion if the judges join us. You will be marked on your presentation and presentation skills, the quality of content and originality, and the impact or the clinical message which your presentation gives. So without wasting more time, our first participant, Dr. Asif, is with us. So Dr. Asif, could you please share your screen and start your presentation?
Yeah,
And
thank you, Arjun. I'll just share my screen right now.
good luck to all the participants. And please keep your microphones muted. Dr. Asif, please unmute your mic. Your video has no audio.
Oh, sorry. Is it audible now?
Had come to our clinic.
Yes, it's audible now.
For the last 10 years. Visual acuity was perception of light in both eyes, and on slit lamp examination, both eyes revealed total leukomatous corneal opacity with band-shaped keratopathy. B-scan ultrasonograph revealed posterior dislocated nucleus in both eyes, and right eye temporary keratoplasty with pars plana vitrectomy and phaco-fragmentation with optical penetrating keratoplasty was planned, as right eye was the better eye with PR accurate. The patient was taken under general anesthesia. 3 standard 25-gauge pars plana ports were inserted. We can see the gush of fluid from the port, which was attributed to the liquefied vitreous. The port was checked and infusion started. The supratemporal and supranasal ports were then placed. The diameter of the cornea was measured using Castro-Vecchio calipers and the center was marked. A 7.5 mm disposable corneal trephine was then used to cut the host tissue. An MVR entry was then made at the host tissue and at the limbus. Host tissue was cut using curved Vanna scissors. Viscoelastic was injected intermittently to stabilize the globe. The temporary keratoprosthesis was fixed over the cornea using 4 Weichel sutures. Anterior vitrectomy is being done. Core vitrectomy is then being carried out. Triamcinolone acetonide is being injected for tagging the vitreous and inducing PVD. We are able to visualize a pale disc with sclerosed vessels and chorioretinal degeneration. We can also see that the vitreous is degenerated with very few vitreous strands. The hardness of the Brunison cataract was assessed and retrieval of the nucleus was attempted by bringing it to the anterior chamber using the cutter. One of the Weichel sutures was cut to provide space for the nucleus to come out. However, the lens dropped back into the vitreous cavity. Now an MVR is used to impale the nucleus and it was brought to the anterior chamber. Further, 2 Weichel sutures were cut and lens delivered to the anterior chamber. The keratoprosthesis was removed. An optically grade donor tissue of 8.5 mm was used for the penetrating keratoplasty. Superior 10-0 nylon suture was put to stabilize the cornea, followed by the other 3 cardinal sutures. After passing another 4 sutures, we went in again to remove remaining cortical matter that did not come out along with the nucleus. Some were removed with the vitrectomy cutter, whereas the others, which were calcified, had to be removed through a space in the graft host junction. Fluid air exchange was done, and the pars plana ports were removed and massaged to prevent air leak. The remaining nylon sutures were put, and after completion of 16 sutures, the sutures were buried and the donor tissue was tucked in at the graft host junction.
Thank you.
Thank you, Dr. Asif, for that presentation. It made a complex surgery look very easy. We have one of our judges with us, Dr. Hemant. Good afternoon, sir. I welcome you. You have 2 minutes for discussion if you have any questions for Dr. Asif. And this was the first presentation.
Yes.
It's been recorded. So in case you missed any part of it, you can access the video presentation as well. Over to Dr. Hemant.
Hi, Asif.
Hi, sir.
Hi. So just one question that I had for you was, why didn't you use a scleral ring or something just to, your globe was actually collapsing a lot.
Yes, sir. Actually, this was the first case we were doing with a temporary K-Pro, where there were like 4 and 5 cases of the following case series were done.
Yes.
And in the rest of the cases, we used the scleral ring for globe stabilization. It was really useful, sir.
Yeah, it makes a lot of difference actually.
Yes, sir.
Otherwise, suturing with the globe collapsing is very difficult.
It was very difficult. Initially, we thought like the scleral ring might interfere with the pars plana port that is being made, but later we got a larger size, and then it was much useful, sir.
Right. Great presentation. Thank you.
Thank you, sir.
Okay, so I'll call upon the next participant now. Our next participant for today is Dr. Garima Chaudhary. She is with us. Dr. Garima, you can share your screen and start your presentation. All the best.
Thank you. Am I visible? Is my screen visible?
Yes, your screen is visible and your timer has started and you're audible as well.
Okay, thank you. Good afternoon, everyone. Today I'm presenting a case which is a corneal surgeon's nightmare. So it is a case of a 65-year-old female who had a diffuse leukomatous opacity for which a PK was being done. So here the Fleringa ring was put, trephination was done for her. Then we went ahead and refined the AC entry was made, visco was injected, then host tissue was dissected. So just a brief about the case. In this female had bilateral diffuse leukomatous corneal opacity. So for the right eye, the eye had undergone PK and the BCVA was 6/18 after the operation. And this was the second eye which was being operated in which a cataract was also present. So we removed the cataract and we had implanted a lens in this patient. So the IOL was implanted and dialed inside. Then the ledge that can be seen was dissected when the IOL popped out, which was the first indication of a positive vitreous pressure that was being experienced by the surgeon. So over here, we had explanted the IOL And over here, we can see that the PC was being tented up because of the positive vitreous pressure. At this point of time, the first mistake that we did was that we put a nick over the PC and sort of created a sudden change in the IOP. And then we went over and did anterior vitrectomy for a very long time. As the anterior vitrectomy was being done, in the later phase, we started realizing that a retinal detachment was appearing. The whitish hue that is coming, which is because of the retinal detachment that is occurring. And consequently, the brownish detachment was the choroidal detachment that was being noticed. At this point of time, the cut tissue, dissected tissue was put and suturing was started. But unfortunately, the intraocular substances were being protruded out, because of which the graft had to be removed and the intraocular tissues or contents had to be removed. So after the excision of the intraocular contents, the graft was again put back and suturing was started when the suprachoroidal hemorrhage started. And there was a profuse bleed, but still we, at the end of the surgery, managed to suture back the graft on it. So through this video, I would like to highlight that it's very important to pick up the subtle signs of positive vitreous pressure. And when we see that, we need to immediately close the eye and abandon the surgery as soon as possible, because in such cases, speed is the vision for the patient. And because in this case, as we gave a nick over the PC, then we did an anterior vitrectomy for a long time, and the hypotony was there in the eye for a very long duration. This led to the expulsive hemorrhage, the expulsion of all the intraocular contents, and the patient eventually didn't have any vision in this eye. So thank you.
Thank you for that presentation, Dr. Garima. You can stop sharing your screen. And I call upon Dr. Hemant for any questions he may have for the participant.
Hi, Garima. I don't have any questions as such, but what I feel is that having a, when you do a PK, you remove the anterior cornea, the eye, it's an open sky.
Yes.
In an open sky, the quickly you are going to close the anterior chamber, you're going to form the anterior chamber, the better it is going to be.
Yes, sir. Yes, sir.
It was a, it was a good video.
It was a massacre.
Yes. Thank you, Garima.
Thank you, sir.
I call upon our third participant for today, Dr. Isha Chaudhary. Dr. Isha is there with us. Ma'am, you can share your screen and start your presentation.
Good afternoon. I'll just share my screen.
Yeah, sure. You're audible.
Yes. Okay. Thank you. Are my slides visible?
Yes, your slides are visible and audio is on too. You can start.
Okay. Good afternoon, everyone. I'm going to be presenting a video called Double Whammy. It's a case of a 42-year-old male presented with left eye pseudophakic bullous keratopathy 5 months after a cataract surgery elsewhere. The right eye had the features of Fuchs endothelial dystrophy with cataract. And patient also gave a typical history of early morning blurring of vision in both eyes prior to surgery. So on presentation, both eyes had a visual acuity finger counting at 2 meters, both the PBK eye and the Fuchs eye. And there was a well-centered posterior chamber IOL in the bag. Although the retinal details were not clearly visualized, the glow could be seen. Hence, the patient was advised the left eye Descemet's membrane endothelial keratoplasty to replace the non-functioning endothelial cells. So we mark for the descemetorhexis, and from a side port that we've created, we do a descemetorhexis with the reverse Sinskey. And just as when we are completing the descemetorhexis, we inadvertently pull out the iris. Which leads to bleeding in the anterior chamber. On washing the blood with BSS, we realize that there is a iridodialysis here, as we can see. So at this stage, we can consider converting the process to a DSEC. However, we decide to first repair the iridodialysis. We use a 26 gauge needle as a guide to pass a 10-0 nylon straight needle. It's a little tricky here. And we've created a scleral, small scleral tunnel where we'll eventually bury the knot. The suture is tied and buried, and the blood clots and Descemet's remnants are cleared from the anterior chamber. At this stage, we feel that we can actually go ahead with the DMEC surgery. So air tamponade is done to stop any bleeding. And we stain and load the tissue into the Guder's cannula. And inject it from the temporal side port. The wound is sutured before any other further manipulation, and by repeated tapping and injection of BSS gradually inside, we open the scroll. We check the orientation of the graft with the handheld slit lamp. The graft seems to be in place. And we inject air. There's no leak. So we close the eye and we bury the knot and we close the eye. So on post-op day 1, the lenticule was well attached. The iridodialysis suture was in C2 and the iris was deposited well. The patient had a visual acuity of 636. At 1 month post-operative day, the patient had a visual acuity of 612. So to conclude, that we believe that a DMEC surgery is best avoided in eyes where there's a large iris defect due to chances of a tissue loss or a failure to achieve adequate tamponade. But with this video, we just want to highlight that a good iris repair can increase the chances of a successful DMEC despite an inadvertent iridodialysis. Thank you.
Thank you, Dr. Isha, for that interesting presentation. You can stop sharing your screen and over to Dr. Hemant for any comments or questions.
Isha, nice video. But do you actually use a AC maintainer or something while scoring the?
No, sir. Usually we do it under air or under BSS. We don't usually use an AC maintainer, but sometimes.
Yes. Okay. Thank you. It was a nice presentation.
Thank you. Thank you so much.
So we'll move on to our next participant, Dr. Garima Maan. I don't think Dr. Garima Maan is with us. So we'll move on to the next participant in the list, Dr. Lalit Kumar Singhal. I don't think even he's there. Both of them can join us in the end if they join. So we'll move on to the last participant of the list, Dr. Rahul Bafna, for his presentation on corneal ulcer management. Sir, you can please share your screen and start your presentation.
Thank you, Dr. Arjun. I will be sharing my screen.
U-tool for assessment of corneal
Okay, screen is now visible. You can start.
consultation. U-tool was constructed using 3 Sherman strip and glue. 2 strips are pasted perpendicular to the horizontal strip at its 2 ends. Our U-tool is now ready, which is a lightweight, economical, easily constructible tool and can measure lesions of dimensions up to 2.5 to 3 centimeters. The U-tool is placed on the orbital margin and an image is captured using a smartphone. A photo editor software was then used to draw 2 rectangles across the ulcer to measure its size. In this case, the size of the epithelial defect is 4 into 4.5 mm. Similarly, epithelial defect is measured without fluorescent stain and is about 6 into 5 mm as shown. In this child, the corneal ulcer was initially 2.5 into 2 mm and then subsequently improved to 2 into 1.5 mm after 48 hours of treatment. In this COVID era, when surgeons are facing a paucity of availability of corneal tissues, we suggest an interim technique to preserve the globe integrity in perforated corneal ulcer. The perforation site is first dried using Miracle sponges, and 2 mm of its adjacent epithelium is peeled with the help of a McPherson forceps and iris repositor. We have used 2 contact lenses. First one is refined with an oversize of 2 mm and is placed on the perforated site. Subsequently, freehand customization was done according to the configuration of the defect. BCL margins were dried using Miracle sponges, and then cyanoacrylate glue was applied along the margins of the BCL using the blunt end of a Sinskey. Air is injected into the anterior chamber using a 30 gauge needle, and the anterior chamber was formed as shown. Now the second BCL is placed over the first glue BCL complex. Advantages of this technique are that it provides the tectonic support in developing countries where there is a paucity of tissues, can be performed by any general ophthalmologist, and can be used as an interim measure in cases of perforated corneal ulcer of sizes 3 into 6 mm.
Thank you for that presentation, Dr. Rahul. It was very interesting. And I call upon Dr. Hemant for any questions or comments on this end.
Thank you, Dr. Arjun.
Hi, Rahul.
Okay.
So this should not be used for, a perforation which is less than 3 millimeters, right?
Sir, actually, it is an interim measure just to maintain the globe integrity.
So yeah, I mean, if the perforation is less than 3 millimeters, you directly put a cyanoacrylic glue on. If it's more than 3 millimeters, then you'll have to go in with this method. But it's a good, innovative method. I think I've seen it for the first time. I hope you guys are, thinking of publishing about this and everything.
Yes, sir, it got accepted in contact lens and eye.
Congratulations. Nice video, Rahul.
Thank you, sir.
Best of luck. Thank you.
Thank you, sir.
So two of our participants who couldn't join us, Dr. Garima Man and Dr. Lalit Kumar Singhal, I think they still haven't joined us. So we can conclude this session. We finished with all the other participants. For those who joined late, this session has been recorded. So the other judges can grade you as well. They can access the recorded session and grade you. And I thank Dr. Hemant for joining us and taking out time. Okay, Dr. Lalit is here.
Yes, sir. So can I present my video?
Sure. You can share your video. You can share your screen and you can start your presentation. Don't worry, you can share your screen. Don't rush. You can share it aram se and start.
So just a second. Let me open my presentation.
Sure. Not a problem.
So is it visible?
Yeah, your screen is visible and you're audible. You can start your presentation.
Okay, sir. So my topic is eye tattooing simplified. I'll be presenting what is actually corneal tattooing is actually keratopigmentation, which is used from last many centuries to improve the cosmetic appearance in corneal scars and licomas. And these are all indications can be used in corneal scars, licomas, anhydria, polychoria. And recently I have seen one article where they're using pseudophakic bullous keratopathy also. So this is one short video where this is you can say a kind of jugaad which I have assembled and from here and there.
Hi friends, today I am showing you
pen.
Equipments required for
So this pen is available on
corneal tattooing.
Many
So this is power supply,
sites like Amazon,
foot pedal, tattoo machine, ink and tattoo needle.
So this
So
is
we
tattoo pen.
require these 5 equipments for corneal.
And along with this tattoo pen, there is one power supply which I have procured from another company, and this comes with foot pedal, and these are tattoo needles.
First, I have to insert power supply, foot pedal into the power supply.
Basically, mechanism after inserting the foot pedal, and then inserting this needle.
Fit into
needle available. These are available in different kind of options with round tip, single tip, or a bunch of tips also available with these kind of needles. These are single-use sterile ETO needle and can be used in every patient.
The
After
tattoo machine.
This needle.
Now our tattoo machine is ready. We can adjust the tip of the needle by moving clockwise and anti-clockwise direction. So my tip is just like 0.3, 0.25 millimeter anterior to the hub. You can check by pressing the foot pedal how much depth you are achieving. So you can have a look that if I'm pressing the foot pedal, this needle is like going up and down, and we can adjust the depth according to the requirement. For cornea, we have to keep this depth around 0.5 millimeter. Hi, friends.
So this is my patient, pre-op picture of this patient having like a scar at covering almost 2 clock hours, and it's quite old scar, and she was having like cosmetic problem with this scar. So we have planned this surgery. That tattoo machine, that tattoo gun is not sterilized, so I have kept that machine into a surgical glove, and by cutting the tip of the finger, only the tip of that tattoo gun is exposed, and then needle part is sterile. Here I'm using skin ink, carbon ink, which is water soluble and easily available on Amazon. So this is a procedure under topical anesthesia. In between surgery, we can assess how much depth we have, how much ink we had already infiltrated into the stroma, and whether it is in the right plane. As you can see that over here, there's quite sufficient amount of ink is in the stroma for covering entire opacity. As this is water soluble, we can wash and we can check after, before completing a procedure, whether all the white area was covered or not. And then, and last, we can implant, we can put one bandage contact lens and a drop of antibiotic. So this is first post-op day picture, and this is my patient after having corneal tattooing. Thank you.
Thank you for that presentation, Dr. Lalit. You can stop sharing your screen.
Yes.
Over to Dr. Hemant for any questions or comments.
Hi, Lalit. So this is the same gun which is used for skin tattooing, right?
Yes, this is the same gun. Skin tattooing guns come in different kind of things, like they're having different kind of concept. Majority they are using long needles. Those are not sterile or very tough to sterilize. But these handmade guns are easily available on any of the platform, and we can purchase them. And needles, but we have to customize, because these needles are they come in different kind of like shapes and sizes. And another thing is like these are line needles. So once if you have some idea about tattooing, then these tattooers use line. First they line the graphics on your part of the skin, and then they fill. So there are different kind of needles for filling, and there are different kind of needles for lining the part. So these are liner needles, and if we have to cover the entire cornea, then we can use those filler needles. Those comes in bunches of 16 or 24 needles.
Okay, so they will be quicker then.
Yeah.
Yeah. Thank you. Thank you. Nice presentation.
Thank you.
Okay, so Dr. Garima Man, I think she's not joined yet, and all the other speakers have finished. So we can conclude this session with the permission of Dr. Hemant. Sir, can we conclude this session?
Conclude. Thank you, Dr. Ashish, and everyone here. Dr. Arjun, thank you. Thanks a lot for
Thank you for coming, sir. Thank you for taking time out to be with us.
Thank you. It was a pleasure.
The participants and your videos have all left us clinically enriched, and we'll close this session now, and the next session will start at 3 p.m. Thank you.
Thank you.
अजन फिर से तेरा आ गया।
Hi, good afternoon. I'm Dr. Fairuz here. Do we have anyone from the DOS backend?
Tell me.
Yeah, hi. So I have got, I'm the judge for the session and I have got the Google form for the judging. Hello.
Yeah, tell me.
Yeah, so what is the mark is expected to be given out of?
Out of 10. Out of 10.
Out of, all right, perfect. Yeah, thank you. Generated. 72 minutes. Check. Hi, everyone. Good afternoon. So I'm just checking on the speakers. So we have 12 free papers which will be presented today. So we are expecting 12 speakers to be here. I can see Dr. Ankit Agarwal. Hi, Ankit.
Hi, ma'am.
Hi. Dr. Manpreet. Dr. Manpreet Kaur. All right.
Hello. Yes, ma'am. Good afternoon.
Hi, Dr. Manpreet. Dr. Sonali is here.
Yeah, good evening, doctor.
All right. So, so we don't have Dr. Soumya Ketaki Rajurkar. Ketaki Rajurkar is here. Dr. Ketaki Rajurkar? No. Dr. Golhait Priyanka Vijay Kumar? Not there. Muhammad Uzair Zakai. Dr. Muhammad Uzair Zakai? Not there. Dr. Namita Kumari? Absent.
Yes, ma'am.
You are here. Okay. Hi, Dr. Namita.
Good afternoon.
Good afternoon. Dr. Sunita Sabarwal? Not
Good
yet.
afternoon, ma'am. I'm here, ma'am.
Khushbu Chauhan?
Yes, ma'am. I have entered from Khushbu Chauhan's ID.
That's Sunita is here. All right. Dr. Isha Sharma? Doctor.
Ma'am, she was there a couple of while ago. I guess she has logged out or maybe some technical issues.
Okay. Dr. Akul Raj Gupta? Dr. Akul Raj Gupta? Not there. I can see Dr. Nuithe Lomi and Dr. Khan,
Yes, yes.
but I don't find your name in the list of the speakers.
Hello? I am on the part of the chat.
Sorry. I'm so sorry, Dr. Lomi.
It's okay,
Sorry,
ma'am.
Dr. Lomi.
Ma'am, I'm the moderator for the session.
Acha, Dr. Khan. Okay, fine. I couldn't.
Okay, Tanvir.
Dr.
Hi.
Seema, are you there?
Yes, Feroz, I'm here.
Okay, perfect. Hi, Seema, how are you? You're muted. You're muted, Dr. Seema.
Yeah, good to see you.
Same here, same here. So, Dr. Khan, since you're a moderator, do you want to check on the other speakers who are missing?
Yeah, ma'am. Yeah.
Yeah, thank you.
Dr. Soumya Yadav, she was the first speaker.
Dr. Soumya Yadav said that she won't be able to join. I mean, she just, yeah.
Okay. Dr. Ketri, yeah.
Yeah, can you hear me?
Yeah, yeah, we can hear.
You can hear me. Okay, thank you.
Dr. Priyanka Vijay Kumar, she was there.
Dr. Seema, do you think we go ahead according to the time scheduled and
I think we should start, Feroz, because
Yes,
it's a
yes.
tight schedule. I think let's start.
Yes, yes. So, Dr. Khan, over to you. You can take over.
Yeah.
We'll just be silent judges here.
Okay,
Yeah.
ma'am. Good afternoon, respected faculty members who are judges today, Dr. Seema Das, Dr. Feroz PM, and Dr. Nevete Lomi. These three are the judges today. And we have this afternoon session on ocular oncology and interesting cases. This is a free paper session. So we have 12 speakers today. First speaker would be Dr. Sonali Kumar. So now I think Dr. Sonali can start her presentation. We will have 6 minutes for the presentation part, and that 2 minutes will be for the discussion.
Okay. Is my slide visible?
Yeah, it is visible.
Okay, and am I audible?
Yeah.
Okay, thanks. So very good evening to all of you. I'm Dr. Sonali, working as an associate prof at Army Hospital Research and Referral. And I would like to thank DOS for giving me this platform to present my work. So the title of the study which we did at our center is How Effective is ISE as a Primary or Secondary Treatment Modality in Retinoblastoma. So retinoblastoma is a malignant tumor of the retina and which usually presents typically before 5 years of age. And enucleation and EBRT were the management option for the advanced intraocular RB few decades back. In mid-90s, the use of chemotherapy was introduced with good response. And in recent years, there has been a trend towards targeted therapy like ISE to manage retinoblastoma with minimal side effects on surrounding normal retina. So this study was conducted at our center to assess the effectiveness of intraarterial chemotherapy in terms of regression. So it was a retrospective analysis of clinical data of all the patients who presented at our center between Jan 2018 to March 2020. The clearance was taken from ethical committee and a total of 29 sessions in 11 consecutive patients with RB who underwent ISE were included in this study. So the clinical data of these patients, pre-procedure fundoscopic MRI findings, ISE procedure details, and post-procedure fundoscopic and MRI findings were evaluated. All the procedures were done under general anesthesia, and in our study, we used triple drug therapy, means we used melphalan, topetocan, and carboplatin based on the body weight of the patient. The patient were then again followed up by repeat fundoscopy, MRI after a month, and a repeat session were done based on the regression pattern. So a total of 29 sessions of ISE were done in 11 patients over a period of 3 years and 3 months. There were 7 males and 4 females in our study group. The mean age group at the time of ISE was 2.3 years. Range was from 1 year to 4 years. Most of the patients had unilateral disease and 1 patient had bilateral disease at the time of presentation. In 10 patients, ISE was recommended as a primary treatment modality, whereas in 1 case, which was a case of bilateral RB, ISE was advised as a secondary therapy as retinoblastoma recurred due to inadequate response to systemic chemotherapy. The median follow-up period was of 13 months. The group of the tumor at the time of presentation in our study was group D and E and C. And so we could achieve regression of the tumor in 9 cases out of 11. In one case, initially the response was good, but during the course, the child developed vitreous seeding. So in that, we have to inject periocular topitocan. And in one patient, there was a partial regression. So the remaining tumor was ablated with a diode laser. So this is a photograph showing group E retinoblastoma. And in this patient, the tumor got regressed with 4 sessions of ISE. So this is a photograph showing group D retinoblastoma. And in this case, the tumor got regressed with 2 cycles of ISE. So intraarterial chemotherapy has been effective as a primary therapy for retinoblastoma and also as a secondary therapy after previous failed treatment. It's a very highly localized treatment modality with lower systemic effects compared to systemic chemotherapy. Though it is a costly procedure, skill intensive and technical expertise is required, still it is a precise and effective technique that helps in reducing the doses of chemotherapeutic agents. So in our study, we could achieve regression of tumor in 82% of the cases, and which is comparable with other studies which got published worldwide, where they also reported globe salvage rate between 60 to 80%. The Schill et al., they reported 100% globe salvage rate in C and D, and in group E, they reported globe salvage rate of 33%. So the limitation of the study was small sample size, which is partially maybe because of low incidence of the disease. So to conclude, intraarterial chemotherapy has emerged as a promising therapeutic option and should be offered in all the indicated cases. It is possible to give intraarterial chemoperfusion in almost all the cases with good results. Thank you.
Thank you, Dr. Sonali.
Dr. Seema, do you have any questions?
Yeah, just one question, Dr. Sonali. You mentioned 13 months as your follow-up. So is this the average follow-up you're talking about, or is the maximum follow-up in your group?
It's
Since
the
you
average.
had recruited from 2018 to 2019 end, if I got it right.
Normally, few patients are still under follow-up, but few cases like the tumor got regressed and all those. So after some time, they didn't report. So
Okay,
like few cases which are still, like we advise follow-up like till 5 years, like till the time the tumor get regressed and till the time we don't find any recurrence. We keep on calling them every 2 months or 3 months. But in some cases, like most of the cases which reported at a center are referred cases. They are from far peripheries. So most of the time they do report, but in between, like few cases, they don't turn up and they take local advice in their hometown.
Okay, and do you have the, like you have done for group C to group E? So do you have the group-wise regression rates?
Like we didn't come across any group C and group B. Group A and group B, we didn't see in our study. Like in most of the cases, the patient had group D, E, and C. So the regression pattern was better in group C compared to D and E. But in group E also, like the photograph which I have shown in the presentation, it was a group E. The tumor was endophytic and it was completely occupying the whole vitreous. But after 4 cycles of ISE, we could see the optic disc was visible and the tumor also got regressed.
Okay, thank you.
Dr. Sonali, it was an excellent presentation. Thank you for sharing your data with us. So the group E eyes that you had, what was the percentage of regression? How many group E eyes you had and how many eyes regressed?
Like in like out of 11 patients, we had only we had 2 patients who had group E because the total patients were very less in our study.
That's okay. And both the cases regressed group E?
Yeah, both the cases regress. One patient is still under follow-up, and every time we have to do this diode laser also,
So
because
the
the whole
treatment is not complete.
yeah. So we are keep on doing, and like that eye has become little bit thiazical also.
Because of
Yeah, so but parents, they want ki globe salvage, they are not in favor of enucleation. So the tumor has got regress, the disc is also visible, but the eye has become small. So we are keep on doing this diode laser.
So that means there is a recurrence post IAC.
Yeah.
All right. Yeah. So just to correct you, Sonali, regarding the Shields data, which I was also part of.
Yeah.
So group D is not 100% regression. It is 95% regression that we have reported.
Okay.
And group E was, 33%.
33%.
Correct. Yeah. Thank you so much.
Okay.
Dr. Khan, over to you.
Thank you, Dr. Sonali. May I now request Dr. Kirti?
Yeah.
And I request Dr. Kirti to please start her presentation.
Yeah. Thank you. You can see me?
Yeah, we can see your slides.
Okay. I can start?
Yeah, you can start.
Okay, thank you. Good afternoon, everyone. My presentation is on a large foreign body mimicking as an intraorbital tumor, which was a diagnostic dilemma for us. And I'm from Guru Nanak Eye Center. So intraorbital foreign body may lead to a variety of symptoms and clinical findings according to size, location, and composition. And the patient may not recall a history of foreign body penetration also. And often the entrance site of an inorganic foreign body is small and self-sealing, and quiescent period of days and years may pass. Injuries caused by metal and glass are well tolerated, may be left in situ for asymptomatic, but wood triggers an intense inflammatory reaction and needs urgent removal. And despite modern imaging techniques, sometimes it is difficult to identify these foreign bodies. So in this report, we present an interesting case of a large orbital foreign body, which was retained for 2 years and eventually presented as a biopsy-proven granuloma. The 35-year-old female presented to us with a gradual decreased vision, progressive limitation of movement of left eye since 1 year with associated pain and redness. There was no history of diplopia. And there was history of trauma to the forehead with a wooden stick 3 years back, for which no medical treatment was taken. And there was no history suggestive of any other systemic illness. On examination, right eye vision was 6.6 on Snellen's. Ocular examination was normal. Left eye, best corrected visual acuity was finger counting 1 meter, accurate PR, with a 30-degree hypertropia on Hirschberg and marked limitation of movements. As you can see here, there is a marked limitation of movement, especially in up gaze, and it is restricted in all the gazes with conjunctival chemosis and congestion. And there is no other sign of injury. On palpation, there was an ill-defined firm tender mass which was present in this in the inferotemporal quadrant, which is not very obvious from outside. And finger could not be insinuated between the mass and the orbital walls. And skin overlaying the mass was freely mobile. On slit lamp examination, other than the congenital findings, everything else was normal. The pupil was also normal. Direct and consensual reflex were present. Fundus examination, both eye disc and macula was normal. Left eye marked choroidal folds were noted in the inferior quadrant. We could not capture the photograph because of the marked limitation of the ocular motility. And post-duction test was tight for left eye inferior rectus and lateral rectus. On systemic investigations, only ESR of 85 mm was noted. Rest all systemic investigations were within normal limit. And CECT brain was normal. CECT orbit was suggestive of a mass lesion in the posterior orbital fat, measuring 22 by 14.5 mm with mild proptosis of the left lobe. And on incision biopsy from inferotemporal quadrant showed inflammatory infiltration, no evidence of granuloma or malignant cells. So we made a provisional diagnosis of inflammatory orbital disease and started the patient on prednisolone tablets. And 4 weeks later, conjunctival chemosis and lid swelling subsided. A well-circumscribed hard mass could now be palpated in the inferotemporal compartment. So we went ahead with the MRI of the patient. And as you can see, there was this lesion in the inferotemporal quadrant, which measured 1.1 centimeter by 3.7 by 3.6 centimeter in the posterior inferior aspect of the left orbit involving the intracornal as well as the extracornal compartments between the lateral and the inferior rectus. And the findings suggestive of likely foreign body granuloma were present. And based on local examination and MRI findings, we did orbital exploration. And as you can see, we did an inferior conjunctival approach, and as you can see, there was this large foreign body, wooden foreign body, which was removed, which was 3.3 by 1 centimeter by 0.3 centimeter in size, and it was abutting the surface of the globe with dense fibrosis involving the inferior rectus and the surrounding structures. We started the patient on broad spectrum antibiotics, corticosteroids, and topical antibiotics, and 1 month later, the patient's visual acuity was 6 by 6. And this is the postoperative picture. You can see that the conjunctival chemosis has reduced and the movements have improved. However, in superior gaze, still the movements continued to be less. There was no complaint of diplopia, and because of the dense fibrosis of the inferior rectus, the eye remained in hypertropia. The patient declined any further surgery for correction for cosmesis. So she has been kept on follow-up. So the orbit can host a foreign body for significant length of time without any symptoms. And within foreign bodies, due to the porous and organic nature, provide a good medium for microbial agents and can lead to infection. So we need to surgically remove them. And possibility of foreign body should be considered following history of trauma with persistent signs of inflammation, limited eye movement, and delayed healing or diplopia. Our case had a history of trauma to the forehead, but there was no definitive history of ocular trauma, and there were no signs of ocular trauma like an entry wound or a scar. CT scan is a standard imaging technique in these cases, since MRI is contraindicated if it is a metallic foreign body. However, in our case, CT scan showed no evidence of a foreign body, since wood is not detected on CT scan because it has similar radio density to the ocular structures. So MRI scan is a better imaging modality for recognition of wooden foreign bodies. And in setting of ocular trauma, after the CT scan and metallic foreign body, when it is ruled out, we can go ahead with MRI. And our case was difficult because of the patient gave an unreliable history, and the ocular examination also did not give any clues. And corticosteroid therapy was beneficial. So we conclude that intraorbital foreign body should be suspected if there is a suspicious history of trauma or unreliable history, and we can give corticosteroid as a temporary management. And it has been accepted for publication also. Thank you.
Thank you so much, Dr. Ketki. May I please request our respected faculty members for any comments or any questions?
Yeah, thank you, Dr. Ketki. So just one question. When you say it was mimicking an intraorbital tumor, which tumor you had in mind? What were you suspecting?
It was orbital inflammatory syndrome kind of a picture, not a proper tumor, because her age group, she was a young patient. So
so if you had some suspicion of intraorbital tumor in mind, which was mimicking an inflammation in a young patient, what do you have in mind?
It could be a secondary tumor from a breast, is because she's a female patient. It could be a secondary.
Okay. And when exploring, did you find any conjunctival entry wound during the time of surgery? Or
No, there was no conjunctival entry wound. It was probably from outside, because she said that when there was some kind of trauma, she said I fainted. That's why she doesn't remember anything about the trauma.
Okay. Thank you.
Hi, Dr. Ketaki. Nice presentation and a wonderfully managed case. So most of the time when we have a foreign body, especially like, a foreign body granuloma due to wooden foreign body inside the orbit, there is usually the entry side, there would be a sinus, there would be a scarring. I didn't find you mentioning anything about it, like,
There was
in the
nothing.
lid margin.
No, there wasn't. I showed you the picture. There was nothing.
Okay, yeah.
Maybe it healed because she was a young patient.
no
That's what.
ectropion, no cicatrization, because usually it's there is a sinus which is formed, and the skin, the telltale sign in a wooden foreign body which is long standing inside as a granuloma will be like the surface, kind of a sinus kind of an appearance there. Surprisingly, that it was not there in that.
Yeah.
That would have been a clue. All right, thank you so much. Dr. Lomi.
Yes, ma'am. No question. Okay, fine. You can go ahead here.
Thank you, Dr. Ketki. May I please request Dr. Priyanka Golek to please start her presentation. Dr. Priyanka.
Am I audible and is my screen visible to everyone?
Yeah, you are audible. The screens are visible.
Okay, can I start?
Yes, you can start.
Okay, a very good afternoon to one and all attending this session. I am Dr. Priyanka Gulhait from GNEC, New Delhi. And I'll be talking about a case on recurrent skip ulcers of the socket post-radiation. Destructive ocular procedures like enucleation, evisceration, and exenteration cause a permanent disfigurement, leading to an altered lifestyle, psychological, and functional compromise. Orbital exenteration is one of the most radical procedures performed for the treatment of potential life-threatening malignancies. Hence, it's a life-saving and not a destructive procedure, which eventually results into an altered orbital anatomy, leading to aesthetic and emotional impairment. Cosmetic rehabilitation by surgical reconstruction may not always be feasible because of the large defect size in patients of exenteration, along with multiple post-op visits and added costs. Other cosmetic rehabilitation options include prostheses retained by spectacles or adhesives or magnetic buttons. Orbitofacial prosthesis has been recently developed with the use of dental implants using the DICOM technology, that is digital imaging and communications in medicines. The design and placement of these type of implants required a combined approach of oculoplastic surgeons and maxillofacial prosthodontists. So we had a 26-year-old male presenting with a left-sided orbital and maxillectomy defect. He had undergone extended exenteration with maxillectomy 2 years back for chondroblastic osteosarcoma of the left maxilla, followed by intensity modulated radiotherapy. Cosmetic rehabilitation was planned for him in the form of magnetic orbitofacial prosthesis using dental implants. For this, a 3D reconstruction of the patient's anatomical defect was done using DICOM technology, followed by surgical placement of the metallic implants in the supraorbital rim. And during this course, the prophylactic course of antibiotics was given, and hyperbaric oxygen therapy was given in divided doses to ensure adequate healing and osseointegration of these metallic implants. This is a surgical guard which was designed for implant placement, and this is a 3D reconstructed anatomy where we plan the sites for implant placement. This slide summarizes the surgical steps involved in placing the implants. Basically, these implants would act as a platform on which we will place the prosthesis later on. So the image shows that we are placing 3 surgical markings along the superolateral orbital rim, which was the strongest and the most intact part of the orbital wall available in this patient, followed by drilling 3 holes in this superolateral orbital rim with the help of this surgical guard. And in this final image shown by the yellow arrow, we can see 3 intact metallic implants well placed in the orbital rim, which will be later covered with the soft tissue and skin. 6 months were allowed for osseointegration of these implants, followed by second stage, in which titanium abutments were placed. These abutments would basically promote healing and allow growth of the soft tissue around them. These abutments would correspond with the magnets that will be placed later on in the prosthesis that will be customized. However, within 10 days of this second stage procedure, the patient developed diffusely scattered necrotic ulcers in the socket walls and around the abutments, for which systemic workup was done, which was normal. Antibiotic therapy was given based on antibiotic sensitivity, along with local betadine cleaning. There was temporary relief of these ulcers. However, there was recurrence at new sites in the socket walls. So a contrast enhanced CT scan was done, which was suggestive of sclerotic changes around the orbital walls, suggestive of post-radiation changes. However, there was no evidence of any tumor recurrence or osteoradionecrosis or radiation-induced osteomyelitis. So we enhance the nutritional status of the patient in the form of high protein diet, fish oil supplements, omega-3 fatty acids, and antioxidants like vitamin A, C, and E. The healing abutment were removed and the implants were submerged to accelerate the healing process. Antibiotic therapy and daily saline irrigation were continued. Prior hyperbaric oxygen therapy was an added advantage in accelerating the healing process. The patient responded well to our treatment and currently under observation. These are the images comparing the ulcer status before starting our treatment and after completing our treatment.
कह रहे थे मैम आपको पेंशन मिलती रहेगी, मैंने कहा हमें तो पेंशन मिल ही रही है.
Can others please mute their mics other than the presenter?
Okay. So compromised wound healing is a challenging problem in irradiated patients.
नहीं तो हमको ये आइडिया आया, हेलो,
Because
हमको ये आइडिया आया कि जैसे कि एक आध
Vinita Singh, please
Dr.
unmute
Vinita
yourself.
Singh,
है ना.
Backend team, can you please mute the others?
उनको ही दे दें, वो अपना पेंशन उनको लाइफ लॉन्ग मिलती रहेगी, कुछ पैसा उनको.
Dr. Vinita Singh.
हाँ.
Dr. Vinita Singh.
Ma'am, may I continue?
Yes. Dr. Vinita Singh, please mute yourself.
समझा देना यार, या इस टाइप का कोई और चीज हो तो वो भी बता देना.
Do we have anyone from the back end helping us here? Dr. Khan?
Yes, ma'am, we have.
कल समझा देना. एक्चुअली ये
Can we mute everyone, please?
Yeah, ma'am, I'm asking.
ठीक है, थोड़े परिचित हैं. अगर देखते हैं, अगर नहीं होगा तो कुछ थोड़ा सा उनके साथ कर देंगे. पहले तुम हमको कल पहले समझाओ.
Hold on, Priyanka.
Okay, ma'am.
I'm
Sorry,
asking.
dear.
Please
So
hold on.
sorry.
थोड़ा ठीक से समझाना पड़ेगा. तुम जानते हो हम कितने होशियार हैं. क्योंकि मैं काफी बेवकूफ हूँ और रुपए पैसे की बात सुनने से पहले ही मैं थक जाती हूँ. सुन.
Dr. Vinita, can you hear us? Dr. Vinita, I think
Does
she can't
anyone
hear.
have a phone number if you can contact her?
Can you just inform the backhand to please mute her? You can just inform the backhand maybe. If
अभी तो इधर तो सर की बीमारी में हम बहुत फंस गए. अभी हमारा एक दो जगह पैसा जो फंसा है वो भी अब निकलवा लो. पता नहीं कितना है. तो कोई एक बार निकला था ना, तुमको बताया था, देखना पड़ेगा हमें. हमें याद कुछ रहता नहीं है. हम चाहते हैं बिल्कुल सीधा सीधा इन्वेस्टमेंट हो, बात खत्म हो हमारी.
DOS backend, please help.
Okay, Priyanka, please continue. I think we should give her some extra time.
Yes, Seema, agree.
Thank you, ma'am. So we know that compromised wound healing is a challenging problem in irradiated patients because radiation causes soft tissue loss and compromises the local blood supply and healing capacity. Hyperbaric oxygen therapy has been reported to have added benefits in radiation ulcers by promoting angiogenesis, fibroblastic proliferation, and improving the local tissue oxygen. So to conclude, radiation therapy is invariably associated with compromised wound healing. Hence, it needs a proper patient selection, especially if you are planning for orbitofacial prosthesis, because these patients need to have an overall optimum health to avoid to have an uneventful post-op period. Nutritional enhancement as an adjunct to hyperbaric oxygen therapy is especially helpful in early recovery of radiation ulcers and can also be used as a mainstay in the management. In fact, it can be adopted as an additive in the management of post-radiation cases to avoid the sequelae like in our case. Thank you.
Thank you so much, Dr. Priyanka. Sorry for the interruption in between. May I now request our respected judges for any comments?
Thank you, Dr. Priyanka, for sharing your case. So for your patient, what was the final status of your, what was the final outcome?
Ma'am, as of now, we are observing the patient for any recurrence of the lesions, and for now, he is being planned for conventional orbitofacial prosthesis.
Okay.
So Dr. Priyanka, I have one question for you.
Yes,
After how long you would like to consider for the orbital facial prosthesis after this procedure?
So we waited for 1 year for complete healing and complete recovery after the radiation therapy, and then we planned for the
So
prosthesis.
minimal time is your minimal time is 1 year.
So we did 1 year. I'll have to go back and read in the reports like what is the ideal time for waiting. I'm not sure, but we waited for 1 year.
Dr. Fairuz, any comments on it?
No questions, Dr. Priyanka. Nice presentation. Thank you very much.
Thank you, Dr. Priyanka. We will now move on to Dr. Manpreet Kaur ma'am. I'll request Dr. Manpreet Kaur ma'am to please start her presentation.
Good afternoon, everyone. Are my slides visible?
Yes.
Yes. So I will be presenting a case. So recurrent squamous cell carcinoma of the conjunctiva, a case report. So squamous cell carcinoma of conjunctiva is the end stage of spectrum of disease referred to as ocular surface squamous neoplasia, an umbrella term that encompasses dysplasia, carcinoma in situ, intraepithelial neoplasia, and squamous cell carcinoma of the cornea and or conjunctiva. So it is a most common malignant tumor of ocular surface. The incidence varies from 0.02 to 3.5% per lakh population according to different geographical areas. The common site of origin is limbus. The squamous cell carcinomas arising from palpable conjunctiva, they are rare, and it is a locally aggressive with low metastatic potential tumor. Etopathogenesis, the commonest etopathogenic agent is ultraviolet B radiations, and others are human papillomavirus 16 and 18, cigarette smoking, chemicals like arsenicals, beryllium, exposure to petroleum products, vitamin A deficiency, light pigmentation of hair and skin, HIV, ocular surface injury, and xeroderma pigmentosa. The clinical presentation usually it presents as a growth on the ocular surface, typically in the limbal region within the interlabial zone. And if there is involvement of the cornea, it would have a opalescent and a ground glass appearance. The patient may have a foreign body sensation, redness, irritation, itching, or sometimes pain. The morphological appearance, it may have a gelatinous appearance, a papilliform appearance, leukoplakic appearance, or it may be nodular or diffuse. And when the cornea is involved, it has a grayish frosted appearance or a fimbricated appearance. And classical to note is that squamous cell carcinoma on the conjunctiva is usually it is immobile, more raised, and there are presence of large feeder vessels. So among the differential diagnoses, we have pinguicula, pterygium, vitamin A deficiency, pyogenic granuloma, papilloma, benign intraepithelial dyskeratosis, pseudoepidermolysis hyperplasia, keratoacanthoma, malignant melanoma, nevi, and a panus. So preoperative diagnosis can be made by the help of exfoliative cytology, impression cytology, anterior segment OCT, confocal microscopy, high frequency ultrasound or UVM. And treatment is the surgery remains the gold standard with complete excision with healthy margins, and adjuvants can be used to reduce the recurrence that are cryotherapy, chemotherapy, and immunotherapy by means of mitomycin C, 5-fluorouracil, and interferon or radiotherapy. So today I will report a case of a 60-year-old female who presented with the history of slowly growing paleness mass in the right eye lower lid inner aspect from last 1 year. It was associated with the foreign body sensation, watering, and occasional redness. She underwent excision of the mass without any adjuvant chemotherapy 2 months back at some other place, but had the recurrence within 20 days. The medical records which were available with her showed the biopsy report to be squamous cell carcinoma. On examination, it was a solid raised mulberry-like mass 10 into 6 mm in size on the lower palpebral conjunctiva, extending to the fornix and to the lid margin, 4 to 5 mm inside the lateral canthus. The lid margin was distorted and thickened. There was loss of cilia, and there was upper lid tylosis with cicatricial entropion. So these tylosis and cicatricial entropion, they were present in both eyes. It was a sequelae of trachoma. She had a heel trachoma, and consequent to that, she had a cicatricial entropion. So this is the pre-op picture of the patient. So visual acuity was 6/24 in both eyes with grade 1 nuclear sclerosis, and there was an epithelial haze secondary to the chronic trachomatis scarring. The IUP was normal, fundus was normal. There was no regional lymphadenopathy. Chest X-ray and ultrasound abdomen were done, and they were normal. The excision of the mass was done with 2 mm healthy margins of the lid and conjunctiva. Cryotherapy was applied to the conjunctival margins. Lid was sutured with 6-0 vicryl and silk, and conjunctiva with 8-0 vicryl, and tissue was sent for histopathological examination. So these are the operative pics. So this is the first post-op pic of the patient. The sutures can be seen. The post-operative treatment comprised of oral antibiotics, amoxiclav with serratiopeptidase in combination with the NSAIDs. Topical antibiotic steroids, lubricant eye drops were given. Antibiotic ointment was given for night application. At the first follow-up after 1 week, the sutures were removed. The biopsy report came out to be moderately differentiated squamous cell carcinoma, and hence mitomycin C 0.02% eye drops were started after 1 week. So it was given in the dose of QID 4 times a day for 1 week, then 1 week off cycle, and 4 such cycles were given. So this is a histopath. This is basically a low magnification pic. So the microsections examined showed a tumor arising from the conjunctival epithelium and invading into the stromal underlying stoma. So we can see the abrupt change of the conjunctiva and invading into the underlying stoma. The high power view showed histopathological features conforming to moderately differentiating squamous cell carcinoma. So this is the follow-up pic after 5 months. Apart from this thin symblepharon, so there is no recurrence. So the patient was on follow-up till 5 months, and after that, because of the lockdown period, she didn't report back, and after extensive searching for her, I could find out, and she talked to us on phone. She had no recurrence till date. So discussion is, the squamous cell carcinoma is the end stage of the spectrum of diseases referred to as ocular surface squamous neoplasia, and the most lesions occur in interpalpebral region, and palpebral conjunctival involvement due to squamous cell carcinoma is rare. Surgical excision under microscope is the most commonly used technique. Recurrence after primary excision can be frequent. Surgical excision alone is associated with the recurrence of 3.2% to 67% at an average of 32 months. So to conclude is, incomplete initial excision may lead to recurrence. Complete excision with healthy margin should always be performed, and supplementary chemotherapy with mitomycin C 0.02% eye drops, it helps in preventing recurrence. So these are my references. Thank you.
Thank you so much, Dr. Manpreet Kaur ma'am. I would now request our judges for any comments or questions, please.
Yes. Hi, Dr. Manpreet. Thank you for sharing the case. I have a few questions to you. So in a histopathology of a squamous cell carcinoma, what are the things that you would look into?
Pathologist report only, since we are not trained to look into the slides on our own, so we rely only on the pathology.
No,
so
not
basically, ma'am, the cells
in the report, Dr. Manpreet. What would you want to know in a?
Okay.
Yeah.
So in squamous cell carcinoma, ma'am, basically we have to look for the aggression. I mean the mitotic index of the case. So how many cells they are? What is the nuclear cytoplasmic ratio? How many mitotic figures they are seeing? So the kind of whether it is poorly differentiated or it is well moderately differentiated, and ma'am, and important is to differentiate it from sebaceous cell carcinoma. Since the site is more preferable for sebaceous cell carcinoma, but the histology, it appeared or it came out to be only squamous cell carcinoma. So we have to rule out sebaceous cell carcinoma here. So there were no appearance of vacuolated cells or in a lobular pattern. So the histology, which is specific for the sebaceous cell carcinoma, was not seen here.
Okay, so we will go on to what I wanted to tell you. I have the second question for you. So what are the risk factors for recurrence in conjunctival squamous cell carcinoma?
Ma'am, increasing age, so inadequate, I mean, when the tumor margins are not free. So if the tumor is excised and the margins come out to be positive, it again is a risk factor. And there's an index high expression of Ki67 if it is a proliferation
So
index.
you gave me the answer here. All right. So you said if the margins are free, there is less recurrence. If the margins
Okay.
right. So in histopathology, you would definitely want to know in a report whether there is a margin positivity or whether there is a base positivity. That is very, very important.
Yes.
Apart from the diagnosis that we make, which will actually help you to predict whether it will recur or not. You gave a range from 3.2 to 67%. So there are certain risk factors. Now, the third question related to the same question. What are the indication of topical chemotherapy after surgical excision?
Again, ma'am, if the margins are positive and if you are suspecting that, if you're not sure your tumor is completely excised, like if you have a multifocal tumor, not related to my case. So if you are suspecting the tumor to be present in other locations also, if you are not sure of the complete excision, then topical antimetabolites, they can be used. Sometimes if the tumor size is small, some people they can directly go for chemotherapy, or if the tumor is larger in size, to debulk it. So chemo reduction can be done in larger tumors before surgical excision.
So in your case, what was the indication of topical chemotherapy?
So the margins, to me, I may have excised the margins clearly 2 millimeters, but maybe some tumor cells, if they are not completely excised, so this
How do you know it?
chemotherapy.
How do you know that maybe how do you precisely know whether your margins are negative or positive?
So the pathologist will
Correct.
tell, I mean, the lid margins, they were clear, they were not free. But since the fornix was involved, the extent was up to the fornix, so I could excise whatever I could see.
So your margins were
cells
positive? Your margins were positive?
margins were negative. Margins were negative.
So
But since it was
pardon,
because it was a recurrent tumor, so I mean, didn't want to take any risk, so I put her on mitomycin C. So by any chance, if some tumor cell is left, so it would be taken care of. So mitomycin C, ma'am, to me, it's a wonderful drug. So since it is a very cheap drug, so in our rural population, it is easily available. So we can easily reconstitute that and give it to them. So on a safer side, to be on more safer side, we can always use this mitomycin.
So the cheapest drug is 5-FU,
5-FU, but we are not, approachable to us. I mean, in my area, we have only mitomycin C.
Yeah. So there are certain indication of starting topical chemotherapy after surgical excision. If you are histopathologically sure that the margins are negative, probably there is not much of an indication for topical chemo. I will hand over to Dr. Seema if she wants to contribute more on this.
I think, Feroz, you have actually pointed out most of the things. Just one point, Dr. Manpreet. So when you started the patient on mitomycin, for whatever you felt was the indication, what are the things you need to explain to the patient, and what are the things you need to monitor in the eye, other than the tumor recurrence?
Okay, ma'am. One is, it is to be freshly prepared, and we instruct the patient to keep it in the fridge. So it has
mitomycin
to be refrigerated, and we have to ask the mitomycin C.
Okay.
Hello, am I audible?
Yes, you're audible.
So, okay. And then for the ocular side effects, we have to explain to the patient, you may experience redness, watering, irritation, blepharospasm, and the patient may have a constant irritation. By the time the patient uses this drug, it causes a redness, watering, and all those surface problems. So we have to instruct the patient, these problems, they may happen, and for that we also prescribe lubricating eye drops along with that. And some patients may develop punctal stenosis, but that is on prolonged use. So basically, and we have to instruct the patient, after putting the drop, they have to occlude the punctal area, close the eye for 3 minutes, so that this drug doesn't get into the nasopharynx, and that side effects of that systemic absorption, nasopharyngeal irritation will not happen.
Okay, so despite everything, out of all the topical chemotherapy and immunotherapy medicines which are available for ocular surface neoplasia, mitomycin is supposed to be the most toxic one because it can potentially cause a stem cell deficiency. So in your setup, if you feel that somebody needs a topical therapy and probably a more safer medication might be a better alternative. And a 5-FU is something which is actually readily available in case you have to give a topical therapy. If maintaining the cold chain and cost is an issue, sometimes interferon becomes a problem. So mitomycin is actually not that innocuous out of all the topical medications which are available. That's the reason we have very precise indication, and you only give it to the patient only if it is indicated, as Dr. Feroz pointed out. There are certain specific indications. Okay.
Thank you, Dr. Manpreet. Thank you, respected judges. I think Dr. Mohammad Uzair is absent, so I would move on to Dr. Namita Kumari. I would request Dr. Namita Kumari to please start her presentation.
Good afternoon, everyone. Is my slide visible?
Yes, it is visible, and audio is also audible.
Good afternoon, everyone. I am presenting a clinical case of a young male, 30 years old, who presented to us with a chief complaints of a painful, progressively increasing red mass for the last 3 years. He was a known case of the VHL disease. The both eyes are PL negative. He is a smoker for the last 8 to 10 years. He is hypertensive. The age of onset of VHL disease is 10 years and age of diagnosis is 16 years. There is no significant history of any abdominal pain, dysuria, hematuria, difficulty in hearing or tinnitus. Coming to the local examination, in the right eye, there is a visible vascularized mass protruding to a superior and temporal part of the limbus, and it's causing the matosis of the upper eyelid. And in the inferiorly, you can see that there is a opaque cornea is visible. In the left eye, there is a chemos, tarsier and bulbar conjunctiva along with the opaque cornea, probably the silicone eye deposit, because he underwent the retinal surgery in the past. The B scan of the right eye shows the umbrella mushroom-shaped retinal lesion along with that heterogeneous echos, and it's connecting to the extending interiorly also with that intensity, moderate intensity. In left eye, it's a silicone-filled eye. This is the CT scan of the patient showing the heterogeneous mass lesion involving the intraocular part and also extending anteriorly. And there is also ocular coat calcification present in both eyes. The MRI of spine suggestive of that spinal hemangioblastoma and the syringiohydromyelia. Posterior fossa was within normal limit. The ultrasound abdomen shows the multiple simple cysts in both kidneys and pancreas. ENT examination was normal. He also underwent genetic counseling, but he was adopted child and he does not have any other biological sibling. Patient was also referred for the physician for the hypertension, and he underwent enucleation plus implant in right eye in no vision of in view of no vision in eye and progressive mass. Histopathology showed foamy vacuolated stromal cells along with that multiple thin-walled capillaries. His immunohistochemistry stain shows inhibin positivity for stromal cells and for capillaries shows CD34 positivity. So the clinical pathological diagnosis in this patient was made von Hippel-Lindau syndrome with retinal hemangioblastoma presenting with extraocular extension. So we also had another case that in the 21 years old male presented with that inferior subconjunctival mass along with that multiple dilated blood vessels. CT scan shows there's a heterogeneous mass along with that ocular coat calcification, and it's a PL negative eye. He also underwent the enucleation. Systemic workup revealed no other abnormality. The left eye was completely normal. with the 6/6 vision, and the fundus was also normal. Histopathology again confirmed in this patient there's a hemangioblastoma. And the patient, this is the patient after cosmetic ocular prosthesis. So coming to a review of literature, on the review of literature, we found that there's two cases presented with the extraocular extension. The first is in which this is presenting as an aggressive fungating mass, and in another it's presented as a vascularized epibulbar mass. So the take-home message from my case is that rectal hemangioblastoma is very rarely can present as extraocular extension and should be considered as a differential in case of vascularized mass in blind eye. Hemangioblastoma associated with VHL as well as isolated retinal hemangioblastoma, like in second case, can have aggressive course, and systemic evolution, regular screening is very important in such patient. Thank you.
Thank you, Dr. Namita, for the presentation. I would request our judges for any comments or questions, please.
Dr. Namita, it was very rare and excellent documentation of the cases that you have, good presentation. So is there any particular factors, clinical factors, where you can actually think of aggressive behavior of these capillary hemangioblastomas, retinal capillary hemangioblastomas?
Yes, ma'am. Like in this, our first patient, because he underwent the multiple cryotherapy and retinal surgery, so it causes the scleral thinning. So there is possibility of that, like the retinal hemangioblastoma can present with the extraocular extension. And there's the one report is that by Chu et al., I remember, in which they have reported that the aggressive behavior is associated with the upregulation of HIF2A. That is the hypoxia-inducible factor that is associated with the pathogenesis of VHL disease. So if there is a mutation and this VHL protein form the complex, and this complex has been causes the further activation of this. So if it's HIF2A is upregulated, then the aggressive behavior is documented. So we have only two case reports in the literature, not much documented.
Have you done the HIF, Dr. Namita?
No, ma'am. In our patient, the first patient was he already had VHL disease and he was not actually worried for this. He already knows all about the disease. And in the second patient, because we have advised the genetic testing, because in the second patient there was no systemic involvement. So we asked the patient for the confirmation of the VHL disease. We asked the patient to undergo the genetic testing. However, this lockdown happened and he did not come back. Maybe he will come, then I can suggest.
So a systemic disease in VHL, Dr. Namita, for which year do you expect that it will be clinically visible, clinically detectable, I mean?
So mean age of presentation is around 25 years in that for VHL disease.
Yeah.
So, but it can present less, in the 5% cases, it can present even less than 10 years. So we have to, if we know the patient is having the history of the VHL disease, we have to undergo the screening that is recommended by the VHL Alliance as per the age criteria, that we have to follow that.
Yeah, so probably even at a later age, the same patient who doesn't have a systemic association at this point of time can land up having a systemic association, and that really requires a long-term follow-up in these patients.
Yes.
Thank you so much. Yeah, thank you very much. Dr. Lomi, over to you. Dr. Seema.
Yeah, Dr. Namita, really is a rare case and well documented and well presented. In your follow-up, how long is the follow-up in this patient? When was the last follow-up?
So last follow-up was just I think 7-8 months back, and we had recently had a telephonic consultation. So in the first patient, he started developing that tinnitus thing. So we had advised the ENT checkup. Possibly may he have that endolipid sac tumors he started developing. So we advise him the ENT examination. And in the second patient also we advise that you have to come for the genetic testing. Probably he will come in 1 and 2 months.
So in the follow-up, in your follow-up, what will you consider for? What you want to go for?
Because second patient in the age of the 20. So the first 20 years of age, we need to go yearly at least ultrasonography and 2 to 3 yearly MRI scan, at least 1.5 Tesla to detect spinal and CNS disease. And earlier it was CT was recommended, but now I think ultrasound has been recommended. Good quality of ultrasound. That is enough to pick up that abdominal tumors.
Okay, great. Thank you.
Thank you, sir.
Any comments from Dr. Seema Das, ma'am?
No, nothing from my side. Thank you. Thank you, Namita.
Thank you, Dr. Namita. Dr. Sunita Sabharwal is, I think, absent.
No, sir, I am present.
So, oh, you are presenting from Khushbu Chauhan's ID?
Yeah,
okay.
Yes, sir.
Okay, Dr. Sunita, you can start your presentation. Judges, please note that Dr. Khushbu Agarwal's ID, Dr. Sunita is presenting. Okay, you may proceed.
So my screen is visible?
Yeah, it is visible and audio is also there.
Okay, sir. Good afternoon, everyone. Myself, Dr. Sunita Sabharwal. So my topic of presentation is primary orbital lymphoma, a rare clinical entity with diverse clinical course, necessitates multimodality evaluation and treatment. So first introduction, primary non-Hodgkin's orbital lymphoma is a rare presentation and accounts for less than 1% of NHL throughout the body. Marginal zone B-cell lymphoma of mucosa-associated lymphoid tissue type is the most common histological type. It presents with gradual progressive proptosis, decreased visual acuity, restricted ocular motility, and diplopia. Because of the non-specific clinical signs and symptoms, some diagnostic delay may occur. So early diagnosis require combination of complete systemic evaluation, adequate imaging studies, and early surgical biopsy. Most of these tumors require multimodality treatment, including chemotherapy, radiotherapy, or both, and roll-up surgery mainly for obtaining biopsy. Prognosis depends upon the histology, grade, and stage and treatment modality employed, but the overall 5-year survival rate is approximately 60%. The index case highlights the workup and management of primary orbital lymphoma in a 48-year-old Indian male presented with proptosis and conjunctival mass with excellent local control achieved by radiotherapy. So in our case, a 48-year-old male presented with complaint of gradual, painless, progressive forward bulging and visible mass in right eye for 1 year, which was associated with visual blurring and restriction of eye movements laterally. Visible mass in right eye started from posterior aspect of eye, extending to involve anterior aspect of eye within a duration of 2 months. There was no history of any trauma or any systemic disorder, including thyroid disease, bleeding disorders, liver, lung, prostate malignancy. On ocular examination, the right eyeball was displaced inferior medially with significant forward bulging, suggestive of abaxial proptosis. Proptosis was non-pulsatile, without ocular brew, and size was not increasing with change in posture or Valsalva. On Hertel's exophthalmometry reading, right eye it was 24 mm and in left eye it was 18 mm. Right lateral eye movement was restricted in abduction, dextroelevation, and dextrodepression. BCVA in right eye was 624 and in left eye it was 66. Left eye ocular examination was within normal limit. So the right eye has this pinkish globular mass of size approximately 20 into 15 mm extending from superior temporal fornix and almost reaching up to the temporal limbus, involving whole of the superior temporal quadrant. Mass appears subconjunctival and cystic in consistency with congestion and chemosis of conjunctiva with dilated and tortuous conjunctival vessel along with a prominent feeder vessel. There was no discharge and no visible pulsation present over conjunctival lesion. The intraocular pressure and rest anterior segment examination was within normal limit. Fundus examination revealed no evidence of any optic neuropathy, papilledema, optociliary shunt vessels, retinal vein engorgement, retinal edema, or choroidal folds. No organomegaly or lymph node enlargement was found on systemic evaluation, and rest of the systemic examination was also within normal limit. So systemic workup including CBC, ESR, blood glucose, urea, creatinine, uric acid, calcium, peripheral blood smear, stool test, X-ray chest, upper GI endoscopy and thyroid profile was advised, and all these investigation was within normal limit. HIV serology and viral markers were non-reactive. Then MRI brain and orbit was advised. It revealed an ill-defined mass lesion involving intra and extracorneal compartment of right eye, and mass is encircling the right eyeball, all extraocular muscle, right optic nerve along its whole intraorbital course. No obvious extension of mass is seen in optic canal and superior orbital foramina. No intracranial extension seen. And anteriorly, mass is involving right eye conjunctiva and right lacrimal gland. Posteriorly, mass is extending along retroorbital space up to the level of orbital apex. Color Doppler was suggestive of hypoechoic intraorbital extraocular lesion with significant vascularity inside the lesion and without any encroachment of lesion into the ocular cords. Then biopsy was performed to rule out other lesions with similar clinical presentation. Biopsy was suggestive of mild lymphoma, and immunological phenotyping showed CD20 positive. Then PET CT scan suggestive of absence of another focus, and so stage 1 mild lymphoma was considered. This figure 2 is suggestive of an ill-defined mass lesion which is involving both intra and extracorneal compartment of right eye with significant proptosis. And figure 3 is showing poorly defined follicular appearing areas that are composed of monocytoid B cells, small lymphocytes, plasma cell, and variety of reactive lymphoid cells. So patient was included in curative radiotherapy plan and treated with total dose of 36 gray at 1.8 gray per fraction by intensity modulated radiotherapy technique. So optimal local control in form of complete resolution of conjunctival mass and proptosis was achieved after treatment. Patient was kept on regular follow-up for recurrence and to evaluate ocular side effect of radiotherapy. So clinical pulse, primary orbital lymphoma can grow rapidly and aggressively owing to non-specific clinical symptoms. So some diagnostic delay may occur in orbital lymphoma. So for early diagnosis, adequate imaging studies followed by early surgical biopsy is very important. Full staging workup is mandatory for proper management, and excellent local control and survival can be achieved for patient with radiotherapy or chemotherapy if disease is diagnosed early. It is important to continue long-term follow-up of these patients to assess for local control, complication, and relapse in distant site. So to conclude, primary orbital lymphoma is a rare clinical entity with diverse clinical course. It can affect both genders with slight female predilection. It usually present unilateral with bilateral involvement in 10 to 20% cases, and the vast majority of the patient present over the age of 50 years, but it can present earlier also. It can successfully managed with multimodality treatment after appropriate staging. Thank you.
Thank you, Dr. Sunita. I would now request the judges for any comments or questions, please.
Dr. Feroz, Dr. Lomi.
Go ahead. Go ahead, Dr. Seema.
Yeah, nothing from my side.
Well, yeah. Thank you. It was a nice case. Nothing from my side either.
Thank you.
Dr. Lomi, sir.
No, nothing. I think we can go ahead with the next presentation.
Thank you, Dr. Sunita. Thank you so much. We would now go on to Dr. Isha Sharma. I would request Dr. Isha to please start her presentation.
Am I audible?
Yeah, you are audible and slides are visible too.
All right. So, good evening, everyone. I am Dr. Isha Sharma from the University College of Medical Sciences, Delhi, and I'm going to present this case of axial proptosis and anemic retinopathy in pregnancy. I have no financial disclosures to make, and the clinical scenario is as follows. So we had a 26-year-old primipara with a gestational period of 32 weeks who was diagnosed with severe anemia, and she presented with an increase in the prominence of right eyeball during her pregnancy, which she had noticed on and off in the last 10 years, but it wasn't so significant that she reported to a clinic or to a doctor. And it was a non-pulsatile or a compressive proptosis, and there was no other ocular complaints. When we examined her, we found that the best corrected visual acuity for the right eye was 6/9, and for the left eye was 6/6, with the right axial proptosis measuring 6 millimeters, and there was a slight limitation in abduction in the right eye with an RAPD. The left eye anterior segment was within normal limits, And this is the clinical photograph of the patient. Here you can see that there is prominence of the right eye. There's an obvious proptosis with a fullness of the superior sulcus and inferior and superior scleral show. When we went ahead with the fundus examination, we found that there is an elevated disc with blurred disc margins and vascular tortuosity of the retinal vessels. Whereas on the left eye, if you can see, there's a superficial retinal hemorrhage, probably a Roth spot, suggestive of anemic retinopathy since the patient already has a severe anemia. Now, this is just to bring out the images better. So here you can see in the right eye that there is an elevated disc with blurred margins and vascular tortuosity, as I previously said. So what do we have so far is that there's a primipara in her third trimester with severe anemia and sudden worsening of proptosis, with an elevated disc and vascular tortuosity in the right eye and anemic retinopathy in the left eye. So what is interesting and what is further something that we want to know is why has the proptosis worsened and what has led to the disc and fundus change. Next, since this is an antenatal female, we had to be very careful with what modality of imaging we choose. So we couldn't do an X-ray, we couldn't do a CT orbit. What we could go ahead was with an MRI brain and orbit, but definitely without a contrast. So the MRI brain of this patient was normal, and the MRI orbit gave a well-defined lobulated lesion, which looked like so in the coronal section. It's a well-defined lobulated lesion measuring 2.5 by 2.1 by 2.3 centimeters in size. And on the axial section, you can see that there is optic nerve abetment, which could be the reason for the disc edema that was occurring, and also of the lateral rectus, which could be possibly the reason for the slight abduction limitation that this patient had. So on axial and sagittal sections, again, you can see that there is a large mass in the intracorneal space, which is leading to the right axial proptosis. Along with that, also in the sagittal section, you can appreciate the same. So we diagnosed this case as a high-risk pregnancy, high risk because of the anemia, with an intraorbital cavernous hemangioma with compressive optic neuropathy of the right eye, along with anemic retinopathy of the left eye. So what is so interesting about this case is that there is a worsening of proptosis, which we assume is to be because of an increase in the size of cavernous hemangioma, which had remained quiescent for a very long period of time. Now, what has led to this increase in the size of such a quiescent hemangioma for so many years is that pregnancy has been found to be one very important precipitating factor in these people. First of all, this hemangioma is very, very prominent, more common in females. Secondly, pregnancy is a factor that would lead to its increase in size. So there is supporting evidence which says that the hemangioma has receptors for progesterone. So there are postulates that, because of the sex hormone, there is a sex hormone mediated increase in the size of hemangioma that could have occurred. Or there are other studies which also show that there is presence of progesterone receptors, but a complete absence of estrogen receptors on the other hand. So what this tells us is probably there is a non-sex hormonal mechanism also, which could lead to an increase in the size of hemangioma. Now that non-sex hormonal mechanism is because of an increase in the VEGF production on stimulation of the progesterone receptors. Now, other than these progesterone receptors, we also have, there are studies that have also found that there is presence of vascular endothelial growth factor receptors, along with the presence of basic fibroblastic growth factor receptors, which have been found on these hemangiomas. So despite the presence of receptors, we need to have that stimulus to be able to stimulate those receptors. So as we all know, progesterone increases progressively over the 3 trimesters of pregnancy. Along with that, it was also on our literature research, what we found that there is also an increase in the levels of VEGF and in the levels of basic fibroblastic growth factor in pregnancy in comparison to the non-pregnant state. Other than that, what is also very interesting in this case is that there are some few studies that mention the role of local hemodynamic disturbances like hypoxia or low blood flow or ischemia, which could lead to angiogenesis by capillary formation, which could also be one factor in the increase in the size of the capillary hemangioma. So similarly, in our case, we have this hemodynamic, something that could, stimulate such hemodynamic changes, which is anemia. So the patient has severe anemia in our case, which could have also been a contributory factor to the growth of this cavernous hemangioma. So to discuss, I would like to say that based on the evidence and our clinical scenario, I would like to reason out the increase in the size of hemangioma. One, because of the increase in the progesterone levels in pregnancy. 2, because of the increase of vascular endothelial growth factor and basic fibroblastic growth factor in pregnancy. 3, because of local hemodynamic changes independently, which can be induced by pregnancy as well as anemia. So the take-home message is that we should be aware that there are intraocular hemangiomas or lesions which could increase in pregnancy, and we should always be able to correlate the risk factors which are already present in the case, which could have led to the progression of the disease. Thank you.
Thank you, Dr. Isha. Judges, please, any questions or comments?
Yeah, very interesting case, Dr. Isha, and very well documented. So what was the, how did you manage this patient?
Actually, when we last saw her, she was still in her pregnancy. She was 34 weeks antenatal. So we were waiting for her to deliver because before that, she said she was not very symptomatic. As in, she had noticed that asymmetry in both the eyes, but it wasn't so obvious that, she would have had to take up an opinion on it or something. But we were waiting because we couldn't have gone with general anesthesia or anything because she was almost near term and she was about to deliver. And since she was severe anemia, they were not willing to take any risk of operation or anything. So we waited till when she delivers and then maybe think about, operating her or doing an orbitotomy if there is any sort of progression or anything of that sort.
Yeah, so if it is because of the increased hormonal imbalance during the time of pregnancy, many of these actually sometimes can regress also spontaneously following the delivery. So it would be interesting to know what happens to the lesion, what is the course following the postpartum.
Hi, Dr. Isha. Excellent presentation, and you've done a very good review of literature. Quite impressed the way you presented. And it's good that you highlighted a fact how hemangioma can grow in pregnancy due to various factors. And it's quite a learning for all the speakers who are there in this podium today. Very good. And looking forward to what is the final outcome of the patient.
Definitely, ma'am. Once we do follow her up.
Yeah. Thank you.
Dr. Lomi, sir, any comments, please?
Very nice presentation.
Thank you, sir.
Thank you, Dr. Isha. Since Dr. Akul Raj Gupta is absent, I think we could move on to Dr. Ankit Agarwal. I'll request Dr. Ankit Agarwal to please start his presentation.
Dr. Tanvir, how many speakers are more left now?
Sir, this is the last. This is the last presentation, sir.
Is my slide visible?
Yeah, your slides are visible. Audio is also there. You can proceed, Dr. Ankit.
Okay. Good evening, everyone. The topic of my presentation is unilateral Liszt nodules in the absence of other features of neurofibromatosis 1, a case series. I have no financial disclosures. The diagnosis of neurofibromatosis depends on the presence of two or more of the following: 6 1 plexiform neurofibroma, axillary or inguinal freckling, optic glioma, 2 or more Liszt nodules, a distinctive osseous lesion such as sphenoid bone dysplasia, and a first degree relative with neurofibromatosis 1. Liszt nodules are the most common clinical feature of neurofibromatosis 1 in adults. Usually, they occur bilaterally and multiple in number. They are the most common clinical feature of NF1 in adults. They occur predominantly in individuals with neurofibromatosis 1, that is 90 to 100% of adults with neurofibromatosis 1 will present with Liszt nodules. They are well-defined dome-shaped elevations projecting from the surface of the iris and are clear to yellow or brown in color. Now, the aim of this series is to report a case series of 2 patients with unilateral Liszt nodules without any other physical features of neurofibromatosis 1. 2 patients, a 45-year-old female and a 39-year-old female, came to the ophthalmology OPD for routine eye examination. On examination, it was found that they both had multiple Liszt nodules in one eye and none of the similar features in the other eye. A thorough history and physical examination revealed no other signs of neurofibromatosis 1 in either of the patients. Thus, the the presence of NF1 in these patients was ruled out. We concluded that Lisch nodules, even though a common feature of in NF1 patients, may be present unilaterally in patients without any other signs and symptoms of the disease. Discussion. Lisch nodules are asymptomatic iris hematomas found in neurofibromatosis type 1. They are not found in cases of NF2. They develop during childhood after the appearance of cafe aureus spots, but before peripheral neurofibromas, and so may be useful in confirming the diagnosis of NF1 in children and with no family history and only multiple cafe aureus spots. They are present in greater than 94% of patients of NF1 over the age of 6. They are clear, yellow-brown, oval to round, dome-shaped papules that project from the surface of the iris, which are detected by slit lamp examination and are immunologically ectodermal in origin. Differential diagnosis of multiple unilateral Lisch nodules, which can mimic the appearance, include Kopes nodules and iris nevi. Thus, it is important to rule out other ocular conditions like uveitis and iris nevi before confirming the nodules as Lisch nodules. In conclusion, Lisch nodules, when present as an isolated finding, should not be considered as diagnostic of neurofibromatosis 1, but if present in more than 90% of the cases of NF1 over the age of 6 years. Thus, absence of other signs and symptoms of the disease confirm the absence of NF1. Thank you. These are my references.
Thank you, Dr. Ankit Agarwal. I would request our judges for any comments or questions, please.
Dr. Ankit, did we see any pictures of your cases, the images?
Actually, I lost the pictures. We had the iris picture of one of the patients, but I could not find it. Suddenly, I was due to some computer issue. So we don't have the picture right now.
How do you know for sure that it is Lisch nodules?
We tried to rule out other similar looking nodules like Kopes nodules or Still's nodules, but it was not similar. It looks like Lisch nodules only from the looks of it, because apart from doing the histopathological analysis of it, we have done just imaging only. We have not done any biopsy or the investigations for that.
Yeah, Ankit, it would have been excellent if you in a presentation, and it's a competition-free paper, that you would have, put the extra effort to get the images and put it in your presentation.
Yeah.
So, yeah. Thank you.
Okay, thank you, ma'am.
Any other judges? Comments from any other judges?
No comments from my side.
Okay, so this was the last presentation of the session. I would thank all the participants for the excellent presentations, and now I would request all our 3 judges for any concluding remarks regarding this session and our presenters.
Seema, you want to go ahead?
I think they're very interesting cases and are very well presented, most of them, and I think the documentation aspect probably can be a little better. Since it's a competitive session, it's very important that you document everything, you have the whole workup of the case, and you sort of give a conclusion at the end of your case. There should be a message which should come out from your case, either in the form of, say, a unique presentation or a unique management modality or something which you have done differently in your case, which is very well documented for everybody to understand. But otherwise, I think overall it was quite well documented, and of course, presented
good presentation. So, well, we all had this phase of paper presentation. I also did it when I was, during my fellowship and residency. So one thing that I would really want to tell you guys is, whenever it's a free paper presentation, always, an extra edge is when there is a case series, which makes a free paper, like, the number of cases that you're presenting, and whether it's, even a case series is okay. So case report, you might have presented so well. We had very good presenters here with case reports. But when it comes to a free paper presentation, there is always kind of a extra edge where the cases are more, and you have done a data analysis, a statistics is present, so some people will have a little bit of advantage over the other, although you guys, all of you, did an excellent job. And yes, thank you so much. We also learned a lot from the session. Thank you, Dr. Khan.
Yeah,
Dr.
thank
Lomi,
you
sir.
so much. Yeah, thank you everyone. It's a great learning experience for us also, seeing very new rare cases also, and then yeah, everyone will present it, and then best of luck for your future works and all. Thank you.
Thank you. This concludes the session. Thank you, respected judges, Dr. Seema Das, Dr. Lomi, and Dr. Feroz, for attending the session. And thank you all the participants for their wonderful presentations. It was a great learning experience for all of us. Thank you.
Thank you.
Thank you.
Dr. Saurabh,
Hello. Yes, I am audible.
yes, you're audible. You can convey the message. I mean, I guess Dr. Tanveer is here. You can just tell him.
Okay. I think he's yeah, Tanvir is there.
Yes, yes. Good afternoon, Dr. Saurabh.
Yeah, good afternoon. Actually, I have 3 presentation within this 4:30 to 5:30 period. So I
So,
think it would be better since this session has only 2 speakers.
Okay, so I think you can start. We'll send the recorded version to the judges for scoring. Yeah.
Or else I'll just come back maybe as I am a first speaker in that hall, L hall. So I just come back maybe in 10 to 15 minutes, around maybe 4:45, and then I'll start my video. If
Okay, that is fine. That is fine.
Okay, okay. Thank you. Dr. Sahil can then play.
Yeah.
Thank you. Okay.
Good afternoon, Dr. Sahil.
Hi. Good afternoon.
So Dr. Saurabh Kamal has communicated that he has some other presentation also. So he will be presenting on second number. You can present first and then he will present after 10 to 15 minutes. Your audio is not coming.
Am I audible now?
Yeah, you are audible now. Yeah.
Can we just have a video chat because it's a video presentation? I don't know if the video would be producing enough the background noise and my rehearsal part. Can I just play it for once?
Yeah.
I'll just take the
We present a 35-year-old.
Is it audible to you?
Who reported to the trauma center.
Yeah, it is audible.
Fine, thank you.
So it is 4:30 now. So I think you can start now.
Yes, share my screen?
No, right now, no.
How's it now, Dr. Tanveer? Is my
Yeah,
screen
now the screen is visible now.
is it full screen?
Yeah, it is full screen. Yeah.
A very good evening to all present. So this is a short video on repositioning a luxated globe, a simple technique.
Luxation of the globe is a rare condition wherein there is complete protrusion of the eyeball from the orbit. The equator of the globe protrudes anterior to the eyelid aperture and the obliquus ocular muscle contracts further, pushing the eyeball more anteriorly. It can be classified as spontaneous, voluntary, or traumatic, depending on the etiology. Based on the review of literature, trauma seems to be the most common etiology for luxation of globe. Only a few case reports are available in the world literature on luxation of the globe. As it carries a risk of permanent visual loss, an immediate reaction is warranted. Here we present a 35-year-old male who reported to the trauma center with complaints of pain and protrusion of the right globe. There was associated loss of vision, which was following a history of fall from his two-wheelers 3 days back. On examination, the right globe was displaced anteriorly out of the orbital rim with distortion. Conjunctiva was lacerated with clear cornea, a traumatic mydriasis of the iris, and rhegmatogenous retinal detachment on fundus examination was present. The other eye was clinically unremarkable. A non-contrast CT of the orbit and brain was done, and it showed a Wurz optic nerve. There was no evidence of any orbital bone fracture, intracranial or intraorbital hemorrhage. After taking proper consent and explaining the patient about the prognosis and the procedure, the patient was taken up for surgery. Under strict aseptic precautions, the globe and the periorbita was cleaned using betadine thoroughly. A regional facial nerve block was planned and a mark of 10 mm from the middle of the lateral canthus for the upper lid and 5 mm for the lower lid was made. Lignocaine hydrochloride 2% using a 25 Gauss needle was administered subcutaneously into the lids. The orientation of the needle was parallel to the eye, while the depth of the needle insertion was about 3 mm. As the eyelids are tightly closed behind the luxated globe, any pain causes further spasm of the orbicularis. The facial nerve block thereby helps in the surgery to relax the orbicularis muscle and prevent further push of the luxated globe. A frontal nerve block at the supraorbital foramen with the depth of the needle being 5 mm is also being given. This helps us in decreasing the pain further. Some amount of lignocaine is also administered around the periorbital lacerated tissues. After draping the patient, the curved tip of a Desmas retractor is then inserted between the upper lid and the globe. Another retractor is similarly placed at the lower eyelid. A general exploration to look for any evident full thickness globe laceration, associated muscle avulsion, and optic nerve status is done. This case had an avulsed lateral rectus. However, rest of the extraocular muscle were normal. Orbital manipulation should be kept to a minimum to reduce the risk of orbital edema and further visual loss. We don't have to be very aggressive for muscle reinsertion. The same setting as there is a lot of soft tissue edema present and might just cause further delay in repositioning of the globe. The upper lid Desmas retractor is then pulled up and superiorly, and the lower one is pulled up and inferiorly. Keeping a continuous stretch on the lids, an attempt to reposition the globe is then made by pushing it back with a non-traumatic forceps. As the tissue was very edematous in this case, a repositioning could not be achieved. So, a lateral canthotomy with a cantholysis was planned to aid in repositioning. A local infiltration of lignocaine 2% was done at the lateral canthus. Then, using a Westcott's tenotomy scissor, Lateral canthus was cut open 1 to 2 centimeter in length. This is canthotomy. Using forceps, the lower lid was pulled to visualize the inferior crux of the lateral canthotendon and was cut. This is cantholysis. Now again, the desmoid retractor was reinserted under the upper and the lower lid. The upper lid desmoid retractor was then pulled up and superiorly, and the lower one was pulled up and inferiorly. Keeping a continuous stretch on the lids, an attempt to reposition the globe is then made by pushing it with a non-traumatic forceps. And the lids are simultaneously brought close to each other, covering the globe. Air should be taken while manipulating to prevent injury to the cornea and ocular surface. So we have a successfully repositioned globe. A pyramidal tarsography is done at the end to support the globe. A lid spatula can be placed between the lid and the globe to prevent any ocular surface injury while passing the sutures. Post-operatively, the patient should be told to avoid forceful Valsalva maneuvers like bending over, coughing, sneezing, etc., which may otherwise increase the intraocular pressure. A 5-day course of oral with topical antibiotics should be prescribed. Role of any steroids is controversial. Lateral canthus reformation should be done towards the end using a 6-0 Vicryl and a 6-0 silk. This is important to provide a normal contour to the lateral canthus and prevent any apparent horizontal palpebral pressure shortening. So, takeaway points. A simple manner of gentle backward pressure applied to the globe with forward traction on eyelids at the same time helps in easy repositioning. So, it can be done by a general ophthalmologist who should make every effort for an immediate reduction instead of delaying the case to be managed at a higher center. Prompt reduction results in restoration of full anatomical, functional visual recovery in an otherwise healthy eye. Further, it prevents ischemia of globe and development of phthisis bulbi, important for cosmetic rehab.
Thank you, Dr. Sahil.
Right. So with the video, basically, thank you. So basically, with the video, I just wanted to emphasize that over the last 1.5 years, I have myself done a series of around 20-22 cases of traumatic globe luxation, and none of them had any vision right at the presentation. So like they were mostly after a day or so they had presented to us. So what I wanted to emphasize is that with such a simple maneuver, if it is done right at the first hand, right at the first center of presentation, we could be very well be able to salvage the vision in such patients and thus improve the prognosis of such traumatic globe luxations. Thank you so much.
Thank you so much, Dr. Sahil. So these videos will be sent to the judges for scoring. Now we'll wait for Dr. Saurabh Kamal to start his presentation. I think he will join in 10 more minutes.
Right, we can wait for him.
So we'll wait for him.
Hello.
Hello.
Yeah, I've joined back from the hall L.
Yeah.
I think the last session finished late, so it started 4:45.
No problem, Dr. Saurabh Kamal. Welcome. So Dr. Sahil has already presented. So
Okay.
now you can go on with your video presentation, please.
Yeah. So it was it has been recorded with the audio.
Yeah.
Just let me. Is my screen visible now? Is the voiceover? Are you able to hear the voiceover of the video?
Play the video once. No,
Are you able to hear the audio?
No, we are not able to hear the audio.
Donating secondary acquired lacrimal duct obstruction.
Okay, now the audio is audible. Yeah, we can hear.
With 4 times watering since 9 months. He had persistent acute acrocystitis since 10 days, in spite being treated with oral antibiotics. Systemically, he had hypertension, diabetes, and coronary artery disease. Old CT scans showed bilateral, multiple nasal and orbital fractures with nasoorbital ethmoid fractures type 2, fracture cubiform plate, and skull base injury. Thankfully, there was no history of cerebrospinal fluid rhinorrhea. In view of the non-resolving abscess with multiple systemic illnesses, I preferred simple, quick, and minimal invasive procedure, that is, needle aspiration of abscess. Following this, there was rapid resolution of abscess. Nasal endoscopy, even after 3 days of decongestion, showed right-sided inferior turbinate hypertrophy and left-sided severe deviated nasal septum with hardly any view of middle turbinate. Keeping in mind both systemic illness, severe DNS with altered anatomy in a traumatic case, I preferred external approach. Surgery was carried out in IV sedation after adequate local anesthesia. Curvilinear skin incision was made out with the instrument along the anterior lateral crest. Incision was then made with number 15 blade. It is important to make it superficial and not so deep in a stepwise manner in the case of a mucosal with past history of acute acrocystitis to avoid inadvertent injury to the sac. What was noted in this case was a fibrotic tissue between the skin and the scarred orbicularis oculi muscle. Periosteum was incised with radiofrequency cautery, and tough adhesions were noted between the lacrimal sac and fossa, which were dissected carefully bimanually with periosteum elevator and lens spatula. Previously fractured lacrimal bone was noted, and osteotomy was initiated from it using the small Garrison bone punch. After few punches, pinkish nasal mucosa was seen, and it should be carefully preserved while doing the osteotomy. A fractured bone fragment superiorly was very gently removed and care taken to avoid undue pulling. Sometimes it is advisable to use motorized drills or burrs. Always check for any CSF leak, and if in doubt, keep watering filter paper ready. Anterior bony fragments were removed gently. Inferiorly, sap duct junction was removed carefully to avoid forces transmitting into the subsequent bone. Next, Libutin was injected into nasal mucosa, through passed through a punctum, and vertical incision was given in lacrimal sac with horizontal relaxing incision inferiorly and superiorly. It is important to free the flap from surrounding adhesions, as this was a case of acute dacryocystitis. Corresponding nasal mucosa flap is made carefully, avoiding injury to the septum. Flap is retracted gently. Mitomycin C 0.4 was applied for 3 minutes, after which bicanalicular silicone intubation was done. Because of severe DNS, Bodkin was taken out first through the main incision, and then silicone tube ends were pulled through the nostril. I prefer to inject circumostial mitomycin C injection, especially in high-risk cases such as traumatic saldo and past history of acute dacryocystitis. Next, anterior flaps are sutured using 3 6-vicryl interrupted sutures. Orbicularis and skin are closed in layers. I prefer nasal suction to clean any blood or discharge, following which silicone tube is tied and deposited in nose. Anterior nasal packing is done with betadine soap gauze, and ointment is applied over the sutures before patching. Other eye was operated with same surgical principles. Tube was removed at 1 month, and the patient is now relieved of epifoda.
Thank you, Dr. Saurabh Agarwal. Thank you, Dr. Saurabh Kamal. That was an excellent video presentation. Since we have only 2 presenters and both of you have presented, so this concludes the session. The videos will be sent to respective judges for scoring. All these videos have been recorded and will be sent to the judges thereafter.
Thank you so much, Dr. Tanveer. It was a nice video, Dr. Saurabh.
Yeah.
Thank you. I skipped. I was in the other hall, so I skipped
Right.
your video. Thank you.
Thank you. Thank you so much, Dr. Sail and Dr. Saurabh.
Good day, both of you.
Okay.